Today is MC Patel's birthday, I think, no?
No, ma'am, it was yesterday.
Yesterday. Oh, are रहे sir आ रहे क्या?
हाँ, ma'am, he'll join in between.
Okay.
He's again also at Coimbatore.
Okay.
We are live, ma'am.
Okay.
Dolly, ma'am.
Okay.
Actually, MC sir will this thing. Alka ma'am will join in a couple of minutes, he said.
Okay, fine. Let's start. We'll do the Saraswati Vandana first. Vasu, start kar dijiye, please.
Yes, ma'am. Yes, ma'am. Yes. Very good evening to one and all. We'd like to start our today's exciting program of Master Techniques and Tricks in Operative Ob-Gyn Obstetrics Gynecology. It is a first Maitri National Web Conference, and to take the today's program ahead, we have with us a dynamic course coordinator, Dr. Dolly Mehra ma'am. So Dr. Dolly Mehra ma'am is a consultant Ob-Gyn from Mehra Nursing Home, Ratlam, MP. She was also past president, Ratlam OBGY Society, and madam was part of the faculty at various national and state conferences. So, Dolly ma'am.
Thank you so much, Vasu. Good afternoon, dignitaries, our esteemed faculty, all our delegates. Welcome to this unique Maitri National Web Conference, Master Techniques, Tricks in Operative OBGY. So before starting our conference, the web conference, with folded hands, let's pray to Ma Saraswati, goddess, to the goddess of knowledge, to empower all of us with knowledge and greater insight into the field of operative gynae and obs. So can we have the Saraswati Vandana, Vasu, please?
Yes.
Hello. वो तो सकता है मगर मेरे इसको ढूंढ के लोग आते हैं तो सकता है कि मैं के लिए ढूंढी के वो नहीं करता अच्छे से हटाऊंगी मैं इसी के लिए जानी जाती हूँ दुनिया से आते हैं अनलाइकली अब रियली कुछ भी हो सकता है वैसे अनलाइकली सब कुछ करते हैं
Thank you, Vasu. So the importance of continuous medical education to upgrade ourselves is well known amongst all of us. In this era of Google Smart Patients, I should call them, where they discuss the entire treatment plan, operative procedure, options available, and what, in fact, the type of suture used. How will you deal with the complications are also talked about by the patients. So it is very important for us to have a great insight in our own subject. This web conference is a brainchild of Dr. MC Patel, sir, who is the organizing chairperson of this web conference. He has gathered a galaxy of learned members of FOXY who are masters in their own field. The entire scientific program has been designed by him. He is a true academician and very well-experienced clinician. And of course, a very, very important medico-legal expert of our fraternity. Before his medico-legal practice, he has been a very busy practitioner, a surgeon, helping fellow Foxians in the field of difficult clinical situations. And now, with his immense knowledge about medico-legal aspects, he helps Foxy members in the entire country for various medico-legal crises. I welcome Sir, but Sir is not there. He's busy with a conference. So I welcome with folded hands our guest of honor today, Dr. Alka Kriplani, Madam, who is a great academician and a must-watch laparoscopic surgeon. Alka, ma'am, can I have the CV of Alka, ma'am, please? Vasu? Dr. Alka Kriplani, ma'am, has been the Foxy president 2016. She is president of the Gynae Endoscopic Surgery Society. She has been the president of Delhi Endoscopic Society. She has been on the editorial board of 9 journals, and she has received many awards to her credit, 47 awards to her credit. Our country's best award, the ultimate award, she has been conferred with Padma Shri in 2015, BC Roy National Award, Honorary FRCOG. She has the DMA Medical Teachers Award and the DMA Chikitsa Ratna Award. She has Vidya Vibhushan Award in 2021. Alka ma'am,
Thank
your
you.
blessings, please.
Thank you so much for this lovely introduction. God bless you. It's an absolute pleasure. And let me be honest, I didn't see the full program today only. My God, what a wonderful program it is. It's of so much of use that I'm going to tell all my staff after they finish their OPD, they must sit and listen to, because topics are so pertinent for day-to-day obs and gynae practice people. Cesarean section, commonly performed surgery. PPH, a dreaded complication. We need to really teach everybody how to manage PPH. It drastically reduces maternal morbidity and mortality. On the top of it, I will be failing in my duty. I am watching Patel sir for decades. Dr. Patel sir is silent worker, but he has so much of depth and intelligence. When I was at All India Institute, I didn't know him decades back. Whenever you invite, he will come, and I know him as medico legal person. He had such deep knowledge on medico legal issues. Even I am, we in our conferences, I was benefited a lot by his knowledge in those times. And now the medico legal is so much common. And it's not only medico legal, he only has the power to collect this galaxy of stars and make a program like he has made it today. So I think we should all understand the power of MC Patel sir, that a person without making noise can do such great work. I'm really his great fan, and I'm sorry I don't know other organizers, because it is always a teamwork. It is not only MC Patel sir, it is not only Happy Learning, it is you all. You have really made this great scientific program, and so many people will be benefited. I wish you all the best and grand success, and I know hundreds of people will be logging in today. As such, Happy Learning is such a popular program. Everybody happily joins. So many times I have joined in it, and I wish Patel sir all the best for all the endeavors, and thank you so much for this lovely introduction. Thank you.
Thank you so much, ma'am. Thank you. Now I welcome our guest of honor, Dr. Hema Devakar, who I would say is a crusader in improving maternal health through Manatra program. She has done extensive work for Manatra throughout our country. So Madam has been, can I have Madam's, Dr. Hema Devakar ma'am's CV, please? Madam has been our Foxy president. She is the division director, FIGO, Well Women Health Clinic, FIGO, President, Karnataka Association of Healthcare Providers of India. She has been the chair of Nutrition and Breastfeeding Committee, CEFOG. She has been the UNICEF Ambassador for Impact on Nutrition, ex-chair of Well Women Healthcare, FIGO, ex-president of DIPSI, ex-dean of Karnataka College, past president of Foxy 2013, and an advocate of delivering quality healthcare convener of Manyata. She has had various awards to her credit. FIGO Women Achievers Award 2015, CME Excellence Award for Artists, and Global Asian Award in the year 2018. Can I have blessings from Ma'am Hema Devakar, ma'am?
Namaskar, everyone. Thank you very much, Dolly. As this program is titled Maitri, which is all about friendship. It is decades of friendship with MC Patel. I never pick up his call. Whenever I have a missed call from him, I have to just message him back, kab or kahan. He will tell me the date and the time, and he'll send me the link, and I know I have to be there. That's the fast track rapid connects that we have, and wishing him a very, very happy birthday, which is just 24 hours ago we celebrated. And it's just not important to just live your life, but to continually contribute. And that's what, as Alkaji said, MC Patel signifies. And coming to my very, very beloved Alka, when we say in this title of the program, there is a word called tricks. Okay. Where everybody says, Alka ji ke haath mein kya jadoo hai? Something she does with the laparoscopy. It's like a painting. It's such a pleasure to watch. But the most important thing is that she's not holding it to herself. She is constantly seeing to it that everybody who comes in touch with her gets to the level of excellence that she has achieved. So that is what needs a very, very special applause, if I may say. And the skill transfer is so very crucial because knowing and doing are two different things. I know that Jai, Malpesh, Hemant, Sarveshwari, Dolly herself, Bhagyalakshmi, everybody who is here loves to do the hands-on workshops. And why? Because if you want to drive a car, you're reading books after books and just figuring out what is where and how to, but actually, unless you sit in the car and drive it, you never know what really is in store for you. The same way, so many times we've all traveled by various airlines and we really don't pay any attention to what that air hostess is telling. Say, mask girega, ye karo, wo karo. If really there is a crisis, how many of us will actually be able to follow what she said? So it is really in the skilling, in the doing, the actual learning on the job, which can now seamlessly be done through the digital transfer. That's what this program is aiming to do. So on my own behalf and behalf of all the galaxy of faculty who are consistently and persistently wanting to give their time and efforts in trying to scale up the skill transfers so that we throw into the market not only the healthcare providers, but we throw them with confidence, competence, and the desired skills to reach every woman, every girl, everywhere, every time. So may you be hugely successful in your endeavors, and thank you for making me a part of Maitri. Namaskar.
Thank you so much, ma'am. Thank you so much. So MC sir has been a great clinician, practitioner, medical legal expert, and he has been a social worker, a very silent social worker. He has been involved in so many camps in Northeast where we don't reach. And he has been involved in over 1,000 eye donations. So before starting this scientific program, it is a humble request to our esteemed faculty to please maintain a strict time of 18 minutes plus 2 minutes. At the end of each session, we have an interactive session, time for at least 5 minutes. If there is any difficulty in displaying the video, please forward it to us and Vasu so that we can display. And the delegates are requested to post their queries on the chat box, or there is a QR code provided on the flyer. Through that, you can post your queries and we will deal with it. Please remain throughout the program because the program is so much important in our day-to-day practice that you will have a great learning process throughout this program. So And those who miss this program will be sent, the recording will be sent on various groups and also on the YouTube. So to begin with, I would request to start the session 1. I invite Dr. Anit Kumar and Dr. Kavita Kapadia to start the session 1 of the web conference. Dr. Kavita, are you there?
Yes, I'm right here.
Yeah.
Good morning, everyone. I think ma'am has made my work very easy. So just to go about that, each talk will happen for about 18 minutes and we'll have a 2-minute discussion. At the end of the first session, we will have a 5-minute interaction at the end of each session as well. So we begin without much ado with our first session, which is troubleshooting in performing LSCS. And to chair the sessions, may I please call upon Dr. Jayam Kaman, Dr. Renu Makwana, and Dr. Kishore Rajurkar. Dr. Jayam, I think the slide is not...
Okay.
Hello?
Kavita, you just say Jayam Kannan, that is enough. Yeah, people
yes,
will be
ma'am.
waiting.
No, I'm sure everyone knows of you and about you, but just a brief introduction that you have graduated with outstanding academic status. You've received the first rank in the state of Tamil Nadu in the undergraduate medical education, finished your post-graduation in obstetrics and gynecology, and earned the prestigious A.L. Mudlidhar Award for coming out as first in the university. She's the emeritus professor at the Tamil Nadu MGR Medical University and the course director of the course of fellowship in reproductive medicine. Over to you, ma'am. And next, I would like to call upon Ms. Renu Makwana. Ms. Renu Makwana is the director at the Vasundhara Hospital, Jodhpur and Jaipur. She's a fetal medicine specialist and is the president of the SFM Rajasthan chapter, the founder of the IMS Jodhpur chapter, the assessor for the Manyata by FOXI. She's also the recipient of the Young Scientist Award, the Veer Durga Das Award, and the Marwar Achiever Award. She's involved in various social projects like the ROCO cancer camps, the free camps for pregnant women, thalassemia, anemia camps at periphery areas, and many more. Our last but not the least, the chairperson, may I request Dr. Kishore Rajurkar? Dr.
Hi.
Kishore, hi, good morning, good afternoon, sorry. Dr. Kishore is the ex-HOD Obstetrics and Gynecology and Minimal Invasive Surgery at the Sanjay Gandhi Memorial Hospital, Government College, Delhi. He's the president of the Society of Vaginal Surgeons of Delhi, the ex-SRO ICMR at the MCH division. He's a national DNB examiner, Honorable Finance Secretary IMA DNZ, Honorable Finance Secretary for the FOXI BOH, Chairperson of the PCPNDT Delhi, and part of scientific programs in the national and international conference. He is also the patron of the DGFOD and the medical superintendent at the Medha Hospital, Pitampura. Over to you, chairpersons. I would request you to please introduce the speakers as they come upon. The first talk is the LSCS in obese by Dr. Hemant Deshpande. Chairpersons, if you
Can
could
you put
just...
his slide, please? Hemant
Yes.
Deshpande slide, please, Kavita.
Yes.
Thank you very much for giving me this opportunity to chair the session on the first thing for my brother, Dr. M.C. Patel, because we were one among the 5 vice presidents of 2018, where all 5 of us, Pratima Mittal is here, Leela Vyas, and Rajat Mohanty. All of us were always together. And we decided at that time itself that if at all we go for presidency, it will be M.C. Patel, our big brother, who will go for that. Even though he is younger to me, we always call him as a big brother. We give all blessings to him for a good occupation of the post and the best outcome. Now coming to Dr. Deshpande. Deshpande is also very well known to me. And he has been the professor in the medical college at
the scene at Goa, Gujarat, and other places, Pune and Mumbai. And he has written very good books on high-risk pregnancy, polycystic ovarian disease, male infertility, and ovulation induction, and go on, go on. Hemant Deshpande is the best person who otherwise can talk about obesity and its risk in pregnancy, because he has already dealt with in high-risk pregnancy and in polycystic ovarian syndrome also. And he is apt person to give this lecture on risk of obesity in pregnancy and its problems. Over to you, Deshpande, for your excellent academic output.
Thank you, madam. Thank you for the kind introduction. First of all, happy birthday to Dr. M.C. Patel, sir. Was my vice president and now chairperson of the Medical Education Committee. May I please share the slides?
Dr. Hemant, I will be giving you a reminder 1 minute before your time is supposed to be over. You're going to speak for 15 minutes, and I will give you a reminder once 17 minutes are over, and we leave the last 2 minutes for any questions, if at all.
Thank you, respected chairpersons, for that kind introduction. May I start my first talk, obesity, a challenge in cesarean. Really one of the big problems nowadays, sedentary life habits, the food changes, whatever they are going to have. Last 2 years, I was fortunate to have practically 20 sisters of Sachin Tendulkar, I call them, centurion. The #1 centurion of India is Sachin Tendulkar, who has done so many centuries. So all the girls who are having weight more than 100 kg, they are practically sisters of Sachin Tendulkar, because they have completed 100. He completed 100 runs many times, and they completed 100 kg. 22 patients I had in 2 years, such a big thing, and so many problems which we face when we tackle this particular pregnancy.
Hemant, can you go for slide share?
Pardon? Yeah, slides are done.
Slide here.
I have done. Can you see my slides?
We can see your slide as a normal slide, not as a slide share.
I have already did slide. I have already done slide share presentation here.
Sir, put it in presentation mode.
Yeah, presentation mode. Presentation mode. We have done the slide share, but not in the presentation mode.
Okay, where?
Yeah, down on the left side, on the right side, the arrow button.
Okay.
Or in the top of the ribbon, you will see slideshow. Put it, press on it.
Or you go for the slideshow in the top of the button.
Slideshow here.
The top left corner, slideshow next to design.
It's not here. With me, it is not coming.
Dr. Hemant, down along with the 100%, there is one symbol. You click on that symbol.
Let me talk for I'm delivering a talk on video conference.
See in the top, you see the home.
Yeah.
Using image, design, animation, slideshow. Please go for the slideshow.
Thanks, madam.
You can continue your talk while somebody does. Yeah.
So can you hear me all?
No,
Yes, we are able to hear very nicely.
Slideshow,
We can hear you.
But can you see my slides at least?
Yeah, slides can be seen in the.
That's great. Now, this obesity in pregnancy that's defined as BMI more than 30 kg. In the first antenatal consultation when the girl comes to us, it's an independent risk factors for various adverse conditions that occur to mother, that occur to baby, that occur during delivery, that occur after the delivery, and especially the post-operative infectious morbidities first with the people who are having the BMI more than 30. Based on BMI, we categorize the obesity by WHO. BMI, underweight, 18 to less than 18, BMI 18 to 25, normal, and 25 to 30, they are overweight. But yes, for obesity, we separated them into 3 classes. Class 1 when BMI is 30 to 35. Class 2 when BMI is 35 to 40. And class 3 when BMI is more than 40. And super obesity, that's the one we say when BMI is more than 50 kg per meter square. Absolutely worst condition. And I have 22 patients having more than 100 kg weight, unfortunately. But everybody said safely through the pregnancy, through the delivery or through the cesarean section. So many risk factors. Childhood obesity, yes, responsible. Genetic, obviously associated with obesity. Endocrine problem, too associated with obesity. Sedentary lifestyle, urban dwelling, higher socioeconomic status. PCOD also nowadays responsible for the obesity. And obviously they do have the problem like GDM and as well as metabolic syndrome. Why we are worried about? We are worried because there are so many adverse pregnancy outcomes they are talking. They are exposed, they are having problems of abortion, they can have stillbirth, they can have preterm labor, they can have cesarean or instrumental operative delivery. Their induction may fail or trial of labor may fail at times. And obviously there is a risk of PPH in all these obese patients where we are worried about, along with the problems that they may have risk of DVT too after the C-section or after the delivery. When we provide them antenatal care, we have to take care that they are having a regular ANC care. We have to check all the risks they are associated with obesity. We have to monitor their weight gain. Minimum 7 kg weight gain to 7 to 10 kg weight gain, we have to permit to the girl who is already having more weight, more than 100 kg practically at times. Supplementation of iron, calcium, and folic acid is as normal as the normal patient they do have. Higher BMI, they are associated with lower levels of vitamin D too. So additional supplementation of vitamin D along with the calcium works well in such patients to avoid so many complications. Antenatal risk assessment for venous thromboembolism has to be done. Routine USG examinations has to be done. The dating scan, the
Dr. Hemant, sorry for interruption, but your slides are not changing. Please change.
Sir, my slides are changing here. Just give me 1
minute. But it's only your first slide is here.
1 minute, sir. 1 minute. I will stop sharing and again restart it.
Yes.
Can you all see my slides now?
Sir, now you have to put it in presentation mode. In the bottom of the screen.
Yeah, there is a presentation mode here which I am clicking. The slideshow.
Yes, sir. Resume slideshow. Resume slideshow.
Can you see now the slideshow?
No, sir. You have to stop and again reshare.
Reshare. I want the IT person. I want the IT person. Are my slides changing now?
No,
Yes,
now,
sir.
now.
They are changing, but they are on the slideshow, sir.
It's okay. If they are changing, then there's no problem because my slide seems to be my PC. It's a new one, probably having some problem with the slideshow. But anyway, can you see the changing slides now?
Yes, I think your slides are changing now. Yes, I think you should just go on.
That's
otherwise
what we do because let's not miss the timing. So antenatal risk assessment for venous thromboembolism is also going to be done. And then the ultrasound examination, the dating, the NT scan, the anomaly scan, the fetal cardiac scan, and the growth scans as normal as the other patient. Assessment by anesthetist in the third trimester definitely desirable because these are the people who need more operative intervention. BMI more than 35 in any, they have so many additional risk factors like priming, multiple gestation, age of the patient more than 40, and obviously when there is a preeclampsia or GDM. Aspirin 150 mg to be started from 12 weeks onwards, along with the iron, calcium, folic acid, and proteins. BP measurement may be difficult at times because you require a special BP apparatus. You require a BP cuff, which is the extra large one. Otherwise, it won't fit to their arm. Fetal edema interpretation may be at times problematic because she's quite obese one. And weighing machine may not withstand the weight of the patient. A special weighing machine which weigh more than 100 kg, they are mandatory in your labor room, in your antenatal ward, and your antenatal OPD when you tackle such type of patients. What we need a BP apparatus with special fixed size, extra large size cuff, special weighing machines, and obviously ECG and 2D echo we need to do in this patient as per the need. Obesity per se may not be a risk factor for peripartum cardiomyopathy, but associated GDM and preeclampsia and age of the patient may make them have the peripartum cardiomyopathy. So 2D echo and ECG, you may have to do in an elderly patient with obesity or with BMI more than 35. Frequent ultrasound scannings for the weight of the patient. Healthy diet and appropriate weight gain between 7 to 10 kg. Antenatal exercises under the supervision, obviously not without supervision for obese patient. We don't want her to fall down and we don't want her to get injured because of the exercise what we advise. A DIPSI test is mandatory in all patients. Why obese? Even in normal antenatal patient, we are doing every patient DIPSI, and we all know when it is to be done, when it is to be repeated. Not a single DIPSI, but definitely we have to repeat it when first DIPSI is obviously negative. And timing of delivery and need of induction, we need to do as per need of the case, and this needs to be a case-based thing. Indications for C-sections are same in obese and normal weighing patient. They hardly differ. But yes, induction at times may fail more in obese patient, so that indication may be a little bit more. What consideration to be done in the hospital? Adequate doorway width, mandatory. A big lady, when she has to enter through the operation theatre, through the pre-labor, or through the labor room, or through the pre-operative area, the doors has to be big width. The equipment that can hold the door, the trolleys, obviously, the patient gown has to be extra large size. Appropriate manpower has to be done for shifting the patient, for patient to be taken on the table, and to patient to be shifted from table again on the trolley. It's easy to shift the patient from trolley to the table for the surgeon, but it's really difficult to shift the overweight patient, the obese patient, more than 100 kg patient after the operation from trolley to the from the operation table to the trolley. We have to keep it in mind. The cots, the trolleys, the theatre tables, the transfer equipment, they have to be planned for this patient. So many problems they are having. Anesthesia challenges, whether it is a spinal, epidural, or GA, or at times for putting even the tube difficult at times. Finally, getting the spinal space, getting the epidural space, putting the tube in this particular patient, obviously, is a challenge even to the anesthetist too. Operation theatre arrangement has to be adequate. Shifting of the woman, as I told, is one of the big problems we need to tackle. Wound healing is a big problem because lot of fat is there. Lactation problems are there. Latching, as the weight is more, the size of the breast they are more. Feeding to the baby is going to be definitely difficult. Latching is difficult, and all the problem we need to tackle. Contraception issues are going to be there and may need a prolonged hospitalization after the surgery if they develop some problem or some morbidities. Factor to be considered during the surgical planning. Perioperative respiratory dysfunction is quite seen in this particular girls. Obstructive sleep apnea, obesity, hyperventilation syndrome. And obviously, these are the things they have to be tackled by a respiratory medicine person and with the help of anesthetist. Type of procedure again carries a lot of importance. If it is a plan, you can have so many things planned in labor, in operation theatre as well as in labor. If it is an emergency surgery, obviously everybody on their toes, and obviously everyone has to pull the socks to tackle this particular situation of the cesarean section and obesity. Equipments, again, as I told, large big pickup, the longer size equipment and compression bandage for preventing the DVT in such patients to help in this patient to avoid the problems and complications. Difficult IV access, difficult getting the vents, difficulty in intubation, longer operating time, at times may increase the blood loss, not always, but sometimes. Pre-operative evaluation is mandatory, adequate blood booking is necessary. The evaluate perioperative respiratory dysfunction again is one of the mandatory things in obese patient. As I told you, taking the patient on table is easy for surgery, but shifting the patient after anesthesia, after the surgery, from operation table to trolley, definitely you require a shifter and little lot of manpower for this patient, so she won't have any trouble while shifting. High chances of difficult epidural spinal, difficult IV access, airway securing difficulty, they are going to be there. Antibiotic they need in time, and proper antibiotic, the third generation cephalosporin, are definitely going to help to tackle the infection in these patients. Abdominal wall incisions are one of the big problems, either transverse or vertical. Obviously, we take transverse, never take vertical. But yes, you have to decide depending upon the case to case. Suprapubic low transverse adipose tissue when it is more than 2 finger breadth. In the cutting the adipose tissue, 2 finger breadth above the pubic symphysis, that is definitely where little lesser fat you are going to have. Incision length has to be adequate to deliver the baby. Usually, we take the incision on the skin. We take a little bigger incision on the rectus and still little more bigger incision on the peritoneum so that the delivery of the baby, the skin is more and more and more elastic, so easy delivery of the baby will be facilitated. Risk of infection can be reduced by not making multiple stroke. It has to be a very smooth, clean, cut surgery when you are trying to do the surgery. Something about the subacute fat, which is the worst one. Are they fat lobules or are they fat pearls? Obviously, whatever they are definitely bad. Are they like raspberry fruit? Or they are like a grapefruit? That's a bunch. Or shiny when we are going to cut them, we need to check it. The fat section are also important at the same time. The fat lobules have terminal capillaries and occipital and autonomic and sensory nerves. Being such a neurovascular layer, sectioning of fat becomes a big problem. The fat roots cause all the complication. Cautious use of cautery and achieving complete hemostasis is mandatory here. Gentle finger separation definitely works better with cautery than cutting. Vertical or transverse system, that's everybody's choice, but definitely wound breakdown, wound infection, endometriosis and chorioamnionitis are definitely less with the transverse. The uterine incision, delivery of the babies when it is sometimes big is a problem, but yes, what I told you, take a bigger and bigger incision when you are going to have what's there. Delivery of placenta, again, you have to do after delivery of baby and tackle the PTH after atonic and trauma, or whether it is atonic or traumatic. The baby is out now. What to do? Shall we suture the visceral peritoneum? Shall we suture it or we have to leave it? Better you suture it because that's always, it works very well. Closure of the rectus muscle is definitely 2 or 3 places. Will give her a good support to the abdomen. A fascial closure is definitely good one by delayed absorbable suture. Either it is continuous or interrupted as per your choice. And fat closure is one of the most important things. Fat, we are having 2 layers of fat there. The fascial layer we call it as scarpa and a fatty layer that is a camphor. So closure of both the layer, scarpa as well as camphor is mandatory. Close the rectus, close the fascial layer, and above that you are supposed to put a drain which is closed drain, a drain which is Romovac, a drain which is 12 number that is very small in size, sucking everything from that particular fat which is going to give a lot of discharge there and that will reduce the wound complications. Perioperative mechanical perioperative thromboprophylaxis may be advised depending on the physician's advice. Lifting of the cannuculus with the stitches at times require when you do the section. Vertical incision may give better incision, but it's definitely not good for the healing one. Post-operative care is one of the most important things. Early mobilization, yes, works very well. Avoid dehydration. After 6 to 8 hours, give her chewing gum. The gastric secretion, the oral secretion which are there, they definitely will increase and that will make her bowels to move little early. Supportive care during breastfeeding, initiation as well as continuation has to be done by the lactation consultant. Thromboprophylaxis with low molecular weight heparin, which we routinely do with the help of physician, definitely works very well. Maintenance of personal hygiene, again, a difficult situation in an obese patient because all the fat thighs are absolutely sticking to each other. So take care of the hygiene. Stitch removal, preferably on 12 to 14 a day. Breastfeeding is definitely the difficulties have to be tackled with consultation, latching and feeding position. Obviously, they have to be done. Never feed in sleeping position. A large weight of the breast may even compress the nose of the baby and at times the baby will get practically asphyxiated. So the girl who is overweight has to sit comfortably, hold the baby comfortably in a proper position told by lactation consultant or the obstetrician and feed the baby and do a good burping after the feeding is over. That makes the baby absolutely fine without any complication. Surgical complications are many. Infection, wound separation, fat necrosis, discharge from the wound, serous, blood stain, sometimes serosanguinous, sometimes thromboembolic events, and rarely you get bladder, bowel, or ureteric injuries. Hardly we encounter them. Rather, never we encounter them up till now. But yes, they may occur. You have to take care of them. Tips for better outcome: experienced surgeon, experienced anesthetist. If subacute tissue is more than 2.5 centimeters thick, better to stitch the fatty layer. Better to put a Romovac 12 number drain in subacute tissue. Proper antibiotics has to be given. Proper ambulation, proper nutrition after the surgery, and proper exercise of after the surgery with the help of physiotherapists the breathing exercises, the leg exercises are definitely going to help her to recover early from the surgery. And the take-home message, adequate attention to the sufficient equipments, a policy that has been decided how to tackle and manage this position, a staff training to tackle the obese patient. Yes, this is mandatory. Like we have so many trainings for the obstetric issues, obstetric complication, obstetric problems. Staff training is also mandatory for obesity because it is one of the high-risk pregnancy and has to be tackled in a better way. Section of skin incision, surgical techniques, train, proper subacute train, and application of strategies to reduce the post-operative wound complications and post-operative wound pain are definitely help the patient to recover properly. Consideration for the venous thromboembolism care also is important thing. And obviously, before she undertakes next pregnancy, please tell her to reduce the weight with the help of dietitian, with the help of an obesity expert. Today, we do have the obesity experts available with us, the endocrinologists which tackle the condition absolutely.
Dr. Hemant, last 1 minute, please.
Yeah, I know, ma'am. This is my last slide. Now, the obese lady is holding a beautiful baby in the hand who is smiling, and the lady is also smiling. A difficult section has been done, and post-operatively she recovered well and going home with a smile on her face and saying you thanks, and thanks everyone for patient listening to me. Thank you, everybody.
Thank you, Dr. Hemant, for being on time.
Yes, thank you very much, Yesh Patel. You have proved to be the great professor, and you have stuck to the time, and you have made very crisp points which are required for managing obesity in pregnancy. We all know well, anesthetists may break dozens of needles, but still we will do a very good surgery, keeping up our time and blood loss aptly with all our precautionary measures. Thank you very much for your excellent talk. I think at the end they are going to have the discussion. I request the next chairperson to take over the next talk. Probably Dr. Kishore, please. I think it is for previous cesarean. Cesarean and previous.
I will take a break for 30 minutes. There is a management meeting now. They have called me. So 30 minutes break I will take, and again I'll join back. Please permit.
Thank you, sir. Thank you, sir. We now move on to our next talk, which is LSCS in previous cesarean section. And to deliver his talk, may I ask Dr. M.B. Bellard to please log in and show his presence over here. Chairpersons, would you please be kind enough to introduce him? Dr. Bellard, are you there? Dr. Bellard? I don't see him on the chat.
Bellard doesn't seem to be there.
Yes. Dr. Rashmi, are you there?
Rashmi?
Dr. Rashmi, are you there?
Banerjee seems to be there. Banerjee, am I right, Kavita?
Dr. Rashmi?
Banerjee? I see you.
Yes,
Rashmi
I
Banerjee.
see. No, this is Rashmi
Dr.
CR.
Rashmi,
Dr.
please.
Rashmi? Dr. Rashmi, can you please put on your video and audio? We can see you logged in here, please.
Actually, what happened is I cannot I'm not able to share my voice through this laptop. So I have just joined through my phone.
So far as you are able to show your slides, Bellard also seems to have joined.
Yes, I think he does.
Bellard.
Dr. Bellard, are you there? Dr. Bellard, are you there? We cannot hear you. Dr. Bellard, can you please acknowledge your presence? I cannot see him. Rashmi, are you ready? Can we take your talk?
I'm not able to have an audio because in my laptop. I'm able to share my
presentation in the group. Share presentation in the group. We will share.
Can I share the presentation with you? Will you able to share it?
Yes, ma'am.
Okay, I'll share it in WhatsApp.
Yeah, so there's a slight change in the program. Instead of Dr. Bellard, we'll take Dr. Rashmi first, and she's going to be speaking on LSCS in chorioamnionitis. May I request the chairpersons to please introduce her while she gets her talk ready?
Can you put on the slide, madam, for introduction?
Kavita, put on the slides for Kishore.
Vasu, can you put on this? Can you share the slide, Vasu?
Yes, ma'am. Yes, ma'am.
Shall I share it in the group? Shall I share my presentation in the group? Will you, anyone of you will be able to
Yes,
present
ma'am,
it?
you can share.
Okay, okay.
Vasu, can you share Dr. Reshmi's CV, please, on the screen? Dr. Reshmi, yes, perfect. Yes, thank you so much. Chairpersons, the
Hello.
Dr. Kishore, over to you,
I'll,
please.
I'll introduce Dr. Rashmi. She's the professor of OBG at GMC Thrissur. She's also the secretary of RCOG at Kerala chapter. Then she's also the MRCOG Part 3 examiner. And she's also the coordinator of medical education at GMC Thrissur. She's also the nodal officer of M&M Review Kerala, and she's a national manager of Lakshya. So she has lots and lots of eminent positions in Foxy, and I think we are going to be benefited by her talk on cesarean section with previous cesarean section, and what are the difficulties and how we are going to tackle those difficulties. And I think it is one of the very common problem which is faced by all of us. And over to you, Dr. Rasmi.
Thank you, sir. Thank you for the nice introduction. So, can I request Dr. Kavita to please share the slides?
Just 1 minute.
Okay. So, while
Rashmi,
the
we'll just do
team
it.
is, yeah. So, while the technical team is going to present the slides, am I audible? Is this clear?
You are audible.
Yes, you are. Yes, you are. Vasu, can you?
Yes, ma'am. Yes, ma'am. Just a minute.
Yeah.
So, thank you, Patel sir, for giving me this wonderful opportunity to interact with such an august scientific body and in a very interesting topic, actually. So, this topic remains very close to my heart because often we find while reviewing the maternal nearness, we find many things. Okay, can you see it?
We can see the slide, Rashmi. If you could just be a little clear, just the speaker next to your mouth, so your voice just is fine and doesn't come muffled. Yeah.
No, I think there is some problem with my.
You're okay now. You're okay. You can start.
Yeah.
18 minutes. Your timer.
Yeah.
I'm starting it now.
I promise that I will actually finish it before that now. Okay. So the objective of this session is we will just look through the management options in chorioamnionitis and we'll see whether CS is a safe option and what are the essential cares taken during cesarean section. So what about clinical? Next slide, please. Clinical chorioamnionitis or intraamniotic infection. Am I clear? I think there is some echo coming on.
Oh, sorry.
Am I audible? Yeah. 1 second. I think I have joined from 2 devices. That's why. Now is it clear? Better?
Yes, ma'am.
Yes,
Okay.
it is better. And I'm sorry I introduced you for previous sections, but your topic is different. Sorry for that. Sorry for that.
Fine. Absolutely fine. So, chorioamnionitis is an acute inflammation of the membranes and chorion of the placenta, as we all know. And it occurs, we often assume that due to the ascending polymicrobial bacterial infection whenever there is a membrane rupture. But we should always remember that it can occur even with an intact membrane. So, next slide, please. It is a most common infection-related complication in labor and delivery and a major contributor of maternal morbidity and near-miss cases, and also It is one of the third leading cause of maternal death in our confidential review of maternal death analysis. It has a potential to affect 1 to 6% of pregnancies. Actually, there was a terminology given for the chorioamnionitis, that intrauterine inflammation or infection or both. The name itself tells you that there could be inflammation or there could be infection. You needn't have infection to have a chorioamnionitis, but it was abbreviated as triple I, but this terminology is not actually very popular. And when does clinical chorioamnionitis occur? As we can always assume, 85% occurs in the intrapartum period and 15% occurs in the antepartum period, even before the patient gets into labor. How does this occur? So it occurs from various sources. You can have an ascending infection from the lower genital tract. You can have a hematogenous or a transplacental passage. Even an amniocentesis or a chorioamnionitis sampling can cause an iatrogenic infection, or even an anterograde infection from a peritoneum. So we have seen patients who have had a peritonitis due to a surgical cause coming to us with chorioamnionitis. So that can also occur. Can you show the next slide, please? I'm sorry, I did. Okay, next slide, please. Next slide. Okay, so this is how the different scenarios happen. So next slide, please. So what causes? Is it okay?
Yes, ma'am. Yes, ma'am.
Yeah. So what is a causative organism? It is multifactorial. Polymicrobial infection can occur in 50% of cases, with the majority happening with Ureaplasma urelyticum and Gardnerella vaginalis. And we can also have Mycoplasma, Streptococcus, Lactobacillus, Bacteroides, anaerobic bacteria also have a major role, but often we see that it is usually polymicrobial invasion. And what happens when chorioamnionitis occurs? There is a microbial invasion of the amniotic cavity, which will in turn elicit a systemic and local inflammatory response. However, recent studies have shown that the amniotic cavity may be absolutely safe, but there will be microbial invasion only in 61% of women with clinical chorioamnionitis symptoms. So a patient comes to us with the clinical features, all the clinical features of chorioamnionitis, but you take and do a culture of the amniotic cavity, you will not get a report. And 34% of the patient will return clinical. So what does it mean is, even if your amniotic fluid comes out culture negative, there is a clinical chorioamnionitis going on there. Next slide, please. Next slide. Can you please change the slides? Okay. So this is what happens. 61% will not have microbial invasion. Even without an invasion, you can have a clinical chorioamnionitis. Then, what are the adverse maternal outcomes we are very worried about? The major risk factors are the patient can go into postpartum hemorrhage secondary to uterine atony. She can even have a uterine rupture. She can go for an unplanned hysterectomy, blood transfusion. In general, a maternal morbidity, which is not welcome. And postoperative wound infections, endometriosis, abscesses, thrombophlebitis, this can all lead to long-term sequelae. And also the patient will need definitely an ICU admission. What about the neonate? The baby is also at risk with low UPGAR scores at 5 minutes, increased risk of neonatal seizures, neonatal sepsis, bronchopulmonary dysplasia, intraventricular hemorrhage, periventricular leukomalacia. And the baby will also need an intensive care unit care. And there is even a risk of neonatal death and long-term infectious morbidity. Next slide, please. I'm sorry. Can you please change the slides? Okay. So these are the maternal risk factors. And the next one, next slide, please. So these are the neonatal complications. So moving on to next slide, please. So moving on to diagnosis of chorioamnionitis. Clinical chorioamnionitis is diagnosed definitely by a presence of maternal fever, plus you should have 2 or more of the 5 clinical signs like tachycardia, maternal tachycardia more than 100, fetal tachycardia more than 160, tenderness of the uterus, purulent or foul smelling fluid or discharge, and also maternal total count more than 15,000. So if you have a mother coming with fever and two of these symptoms, we have to diagnose her as clinical chorioamnionitis. And this accuracy is only about 50%, but the thing is, we'll have to corroborate with the other biochemical and cultural results. So next slide, please. So these are the usual amniotic fluid parameters. You can have a microbial growth, which is a gold standard. Getting a culture from the amniotic fluid is the gold standard in diagnosing. But as we have earlier discussed, only 60% of patients coming to us with term chorioamnionitis will have a growth. But you can have a gram staining. You can look at the blood sugar level, the glucose level of the amniotic fluid, which is less than. If it is low, we have to, it is more specific. Then interleukin 6, matrix metalloprotease, WBC count, and leukocyte esterase may all contribute to the diagnosis. But because there is only 50% chance of your diagnosing it with diagnostic accuracy with the clinical symptoms. Next slide, please. Now we'll come to the million-dollar question, how to treat the clinical chorioamnionitis. The standard treatment is administration of antibiotics, give antipyretics, and also expedited delivery. These are the three arms which should never and go together. Next slide, please. So the antibiotics, we have a wide array of antibiotics in our armamentarium, starting from ampicillin with gentamicin every 8 hours, or ampicillin sulbactam, clindamycin, vanco, erythro, and ceftriaxone, or clarithromycin and metronidazole. So, depending on, but always the first choice remains the ampicillin with gentamicin in most of the centers and most of the clinical guidelines. And next slide, please. What about antipyretics? Antipyretics should be started simultaneously with antibiotics. So whenever a patient comes to us, we have to start her on antibiotics and antipyretics and we'll have to start her on a bundle, like sepsis bundle. And this will definitely improve the prognosis. And antipyretic administration has been clinically and evidence-based prone to reduce the adverse neonatal and obstetric outcome. And most common recommended one is acetaminophen, or good old paracetamol, can be given orally, rectally, or intravenously. Every 4 to 6 hours, we can give the oral dose, and total dose never exceed more than 4 grams is the one given in the guideline, but maybe we say not more than 2 grams. And cesarean also, even after cesarean, you will have to consider giving them antipyretic and antibiotics. So let us look at the next slide, please. Next slide, please. Next one. Okay. So now I'm coming to antenatal corticosteroids. So these are some things, because majority of patients may come to us with preterm. They may be preterm. So can you give antenatal corticosteroids? So it is remaining controversial because we fear there will be a immunosuppression. We can activate latent infection in the mother and the risk of neonatal infection. But a large meta-analysis was a very good eye-opener, because even though we give corticosteroids, it will significantly reduce the risk of intraventricular hemorrhage and periventricular leukomalacia. That's what the study came out with, because you can and you should give, and even if you have given only one dose, it is going to lower the risk of neonatal death. Next slide, please. So this is the study. This is a meta-analysis. Administration of at least one single dose has an overall beneficial effect on the neonate, and without increasing the risk of sepsis or other adverse neonatal outcome. This was a large meta-analysis which compared numerous studies, numerous randomized controlled trials. Okay. So next slide, please. So again, coming to the other drug in our armamentarium, the magnesium sulfate. Will you give magnesium sulfate for Europe? Of course, we have to give, especially if the patient is less than 32 weeks, and this will reduce the risk of cerebral palsy by 32. That is, 32 is the magic number we will have to remember, and current evidence supports. But you should not delay the delivery to complete the dose. You should not. Even a 2-hour dose is said to be protective. Next slide, please. So now coming to the delivery. So as we all know, we have to expedite delivery, and it is expected that now 90%, what we expect is 90% of patients with clinical chorioamnionitis should be delivered within 12 hours of diagnosis for better maternal and fetal outcome. So you have to start delivering the baby within as soon as it is diagnosed, as soon as possible. So what is the next option? Which is the mode of delivery? Vaginal delivery is a safer option. So most of the studies tells us whenever you open a textbook, open a study, it will tell you vaginal delivery is the safer option than cesarean section. CS is reserved for standard obstetric indication alone. But actually, because there have been reports of significantly increased risk of adverse maternal outcome among women with chorioamnionitis who had undergone cesarean delivery. Next slide, please. Okay, so next slide, please. So these are the evidences, BJOG. Then next one, next slide, please. Thank you so much for changing the slide. So, but in reality, what do we see? What we see is, and there are many other studies which tells us that women with clinical chorioamnionitis are more likely to have a delayed progress of labor, a prolonged labor, a dilatation arrest, or a fetal heart rate abnormality. So again, the ball comes back into our court, and 40% of the patients are more likely to have a cesarean delivery. So even if we say that we have to vaginally deliver the patient, it is better for the mother. Most often in real life scenario, we may have to go for a cesarean section. Next slide, please. So CS in chorioamnionitis. So often, because of maternal and obstetric contraindications, we have to go straight away for a cesarean, or because of abnormal labor progress or arrest of dilatation, when a baby develops fetal distress, which is more likely to happen when there is a chorioamnionitis, or in maternal distress. So these are the indications where we have to go for a cesarean section in chorioamnionitis. Next slide, please. Next slide, please. Is cesarean section safe in chorioamnionitis? Definitely, there is an increased morbidity with cesarean section, but it can be safe. Let us look at it. How to make it safe for the mother and the baby. So the main thing which we have to remember is don't wait for too long. We have to take the right decision at the right time. And start her on antibiotic. She may already be on an antibiotic, which is definitely broad spectrum. Ampicillin, gentamicin is the very popular choice. But if you are going to take up the patient for a cesarean section, add on an anaerobic coverage with clindamycin or metrogyl. Okay. So this is what we should definitely do, or step up the antibiotic. And what about the post-operative antibiotic? Most often we will think because she is having chorioamnionitis, we'll have to give her post-operative antibiotic. Actually, there is a very good study which tells us that even a single IV dose post-operatively is beneficial. And there is no role or no external added benefit if you're giving it this antibiotic for long. But provided the patient has become febrile. If the patient is febrile, continue the antibiotic till 24 hours she is febrile. So this is something we always have to remember. Give the right antibiotic for the right time and right duration. Next slide, please. Now, what are the investigations? So we will have to go for investigations before to look at the blood counts, cultures, urine, blood, and vaginal swabs. So this will all give us valuable information. And even though this will be delayed by 1 day, you will be ready with the next antibiotic to change, because always remember to give the cultures prior to the surgery. Next slide, please. So this is another drug, N-acetylcysteine, which has to be given, which is an antioxidant and an anti-inflammatory agent, providing substantial neuroprotection. So given as a dose of 150 milligram per kg, IV loading dose for 60 minutes, followed by 50 mg per kg, continuous for 4 hours, then 100 mg until delivery. This will improve the neonatal outcome. Now, what about corticosteroids? If you are planning for cesarean also, give her a 1 dose of steroids, and at least a partial dose will benefit, but don't wait for the completion. Magnesium sulfate, start for neuroprotection, at least a 2-hour dose benefit, but don't delay for 24-hour dose. Antipyretics, definitely think about giving an intravenous or acetaminophen. Next slide, please. Next slide. Okay, so this is the end. Okay, so coming to intra, you have started the cesarean. You're going to start the cesarean. Vaginal cleansing with antiseptic solution before the cesarean delivery will reduce the postoperative infections. You see these are the evidence from 3 recent meta-analysis. Even in a patient with emergency cesarean, you have to try this. And especially in chorioamnionitis, you will have to go for a vaginal cleansing. The best option is a povidone 1% solution for vaginal cleanse. Whereas if you are going to give a skin preparation, chlorhexidine will be the better choice. Next slide, please. Next slide, please. So now doing a cesarean section, this may be a better option, an extraperitoneal cesarean section. So this is a type which is done without entering the peritoneal cavity. Especially if there is a systemic infection and peritonitis suspected, or if you are similarly, if there is a clinical chorioamnionitis, better to do the try for an extraperitoneal cesarean section, because that will prevent the spillage of the infected material into the general peritoneal cavity, and you will definitely have a potential to reduce the further morbidity. So this is how
Dr. Rashmi, you have last 1 minute left.
Yeah. It's over. Okay. So these are the skin incision. We have to remember, right, it is a bit lower, and you have to go through you have to dissect the pyramidalis muscle insertion and then lift up the peritoneum and go outside the peritoneal cavity. Next slide, please. So intraoperatively, we take swabs and fluids for culture. Never forget to take the swabs and fluids for culture, and placental and funicular biopsy for histological chorioamnionitis. And there is a doubtful role for peritoneal wash and baby. And then closure also should be very meticulous and avoid, make sure of hemostasis. And baby should need a intensive care monitoring. Then, what about postoperative? We have discussed this earlier. Single dose antibiotic, continuous or step-up dose. So, single dose is said to be as effective. Next slide, please. Sorry. Okay. Next slide, please. Okay, postoperative antibiotic, single dose may be enough if the patient is stable and febrile and improving, but you may consider continuous. Next slide, please. And ICU monitoring. Next slide, please. With a Meo's chart to quickly pick up a patient who is worsening. Fluid management should be very meticulous, avoid hypothermia, maintain normoglycemia, and also implement an enhanced recovery pathway so that patient takes oral fluids earlier and she recovers early. Next slide, please. Vigilant monitoring for any worsening and follow up on cultures. So, and whenever you get a chorioamnionitis, it should better be documented, reported, patient is debriefed, the bystanders are debriefed, and we should conduct audits to improve the outcome. Because this is not very common, you get only 1 in 100 or 6 in 100 patients. So better each case should be your study material. You have to document it and have audits of the available clinical cases to improve the outcome, what went right in this patient. So audits are the key to better improvement. Okay. Can you please change the slide, please, for my last slide? That's my last slide. Okay. Chorioamnionitis is a potential danger. Timely intervention improves the outcome. Antibiotics, antipyretics, and delivery are the mainstay. And CS is an option which should be exercised with adequate precaution. Thank you so much for the audience. And I'm very sorry because of the technical glitch. I couldn't share the slide and there was some... Thank you.
Thank you, Madam, for that wonderful talk. Really enjoyed your talk. Moving on to the next talk, I request the chairpersons to introduce Dr. Bellad, sir, to talk on cesarean in previous LSCS.
Thank you, Dr. Rashmi, for logging in on such short notice and, being our to-go person. Thank you so much. We move on to the next session. Will the chairpersons please introduce Dr. Bellad, and can we have the slide up for Dr. Bellad, please, Vasu?
Yes, ma'am.
Yeah. Would one of the chairpersons please introduce Dr. Bellard so we can move on to his talk, which would be the last for this session? Dr. Bellard, chairpersons?
Maybe you can introduce.
Hello?
Kavita, go ahead.
Yeah, okay. For the next talk, we have Dr. Bellard. He's going to be delivering a talk on LSCS in previous cesarean section. And he has finished his fellowship in perinatology from the University of Illinois, Chicago. He is a global network scholar, 2004-2007, the principal investigator for international trials, labor clip, preterm, cradle care, rapid iron. He's the fellow of the Indian College of Obstetrics and Gynecology. He has 75 plus publications in high impact factor journals and has written 2 books and 14 chapters, delivered more than 1,000 guest lectures. And he's an expert review member of the ICMR for the Center of Excellence on Preeclampsia. Welcome, Dr. Bellard. Without much ado, we will go on to this talk, LSCS in previous cesarean section. Dr. Bellard, over to you. Dr. Bellard, are you there?
Yes, he's there. Sir, you can unmute, sir. Bellard, sir, you can unmute. Bellard, sir, can you unmute?
Yes, Dr. Bellard, please start now. He is already unmuted.
We'll give him a minute. If not, then we'll have to move over. Dr. Bellard, are you there?
Dr. Bellard is there, but yes, I think some problem with his
Yes,
laptop.
I think he has some network issues.
You can have some
anything connected.
expert comments.
If he is connected, he has some
time is there.
laptop problem.
We'll give it 2
Dr.
minutes.
Bellard, what is the problem?
In the meanwhile, maybe we can take over some discussions. The last 5
Yes,
minutes.
yes,
Can we
yes,
start?
yes.
Yeah,
Please.
maybe we can take some discussions in the meanwhile. We'll give him a couple of minutes to settle down.
Okay, can I give my comments, madam?
Yes, of course, sir.
So I would like to comment on first on Dr. Hemant's lecture. I just want to give some practical tips. If first of all, when you gave this webcam conference, I would like to say that please change the word from LSCS to CS. I mean, not always we do LSCS. So many times we do CS, that may be in the upper segment. And therefore, we should always say CS. That's the first thing. Second thing about when we do a cesareans on obese patients, sir has beautifully enumerated everything. I just want to say that the surgeon who is operating should have a very good breakfast and hydrated, and that should be the first case in the list. Number 2, also see to it that you have a lot of proper assistance, including the assistance from the head end, and that is an anesthetist. Because so many times we ask them to retract the upper end of the incision using the LSCS forceps and then trying it in so that you are able to have a good picture. Then the correction of dextro rotation in obese patient is very, very important, because I have seen there are more dextro-rotated in obese patients than in other patients. So therefore, the injuries to the uterines are minimized by this. For that, you must look at the round ligaments before you give an incision on the uterus. See the round ligaments are at the same level. That will tell you that the dextro-rotation is already corrected. And of course, the auditing and the ERAS, I mean, early recovery after cesarean is very must for this. Then for the next lecture, which was there, I would say that we must pick, because it is very difficult sometimes to pick up the cases, which is chorioamnionitis. It is not easy to diagnose. And you must, whenever you get a patient, जिसको fever है or something that she's looking sick and you're not able to raise her BP in spite of your fluids, you must suspect that there may be some septicemic component in that, because chorioamnionitis will affect both the mother as well as the baby, and you have to be ready for that. And always take the blood before starting all the antibiotics. Urine and blood, everything has to be done before the antibiotics. And I would also like to know which steroid she will prefer if steroids are to be given, because we had lots of patients during COVID. During COVID, we had lots of patients like this, and it was very difficult in which patients we had to give steroids and which steroid we had to give. So these things, if the speaker could tell us. Thank you.
Dr. Reshmi, can you take that question, please? Dr. Reshmi? Dr. Reshmi? I don't see her. I think she has. I think she has logged off. But sir, what are your views? What are the steroids that you prefer using in such cases?
I have been using dexamethasone only, because it is slightly longer acting, and the start of action starts at the same. Whether you give hydrocortisone or you give decadron, it's the same thing, but it is a more anti-inflammatory is decadron or dexamethasone. So I had used dexamethasone more than hydrocortisone.
Perfect. Thank you so much, sir. Dr. Bellard, are you ready now? Can we have your presentation on the screen? Dr. Bellard? I think we have some network issues. What we're going to do for now is that we will move over to the next session. And when Dr. Bellard is ready, we will come back for his talk. I think that makes sense instead of delaying the entire program. Thank you, respected chairpersons. We will get in touch with you again when Dr. Bellard is ready with his presentation. In the meanwhile, I would like to ask the next coordinators for the next session, Dr. Prerna and Dr. Dhwani, to please take over. Thank you, Dr. MC Patel, Dr. Gandhi, and the entire team for giving me this wonderful opportunity.
Dr. Kavita, Dr. Bellard has conveyed that within 1 minute he may be able to join. He has some microphone problem in his laptop. He is trying to solve it. So if give 1 minute more, if he joins, okay. Otherwise, we will go to the next session.
Okay, so any inputs from your end, sir, regarding the previous two talks, something, a take-home message from any one of the experts over here?
Chairpersons.
Because I think this obesity is actually something that we all deal with a lot. The average weight of the patients, I think, has significantly gone up. I don't know whether it is the obesity pandemic or whether we are dealing with older women, but it is truly a challenge sometimes to, deliver these babies, and even looking after them post-op, making sure that, they're moving around. There is enough exercise that's happening to prevent DVT. And also sometimes. Hello.
Can we move on to the next session now?
Yeah.
We have Dr. Renu Makwana. Can we have inputs from Renu ma'am regarding the session, because Dr. Bellard is going to take 1 minute to join. So can we have Dr. Renu Makwana's opinion regarding this?
Hello. Good afternoon, everyone. It was nice session, and obesity is very common nowadays, and we come across the main problem in these patients is serum screening. And if we advise them NIPT, then fetal fraction extraction is again less. And so risk of anomalies should be explained to them that because of their this body habitus, we have certain limitations for the same. Then we have to keep ready, like Dr. Hemant sir said, that you equip your institute with big blood pressure cuffs, robust weighing machine, so that it doesn't crack down, because nowadays we have sleek glass wala weighing machine na? So we have to keep that more quintal wala machine. Fine. And then sonography, I think if you are only doing the anti-scan or all, you should send the patient for second level ultrasound to certain radiologists, so that responsibility can be shared.
Hitting both again. Which one?
PAC. PAC is mandatory for these patients, so that anesthetist is prepared for the same. And then during intraoperative and
yeah, thank you.
Okay. Yeah. Thank you.
Sorry for that. Thank you so much, Dr. Renu, for that wonderful input. Dr. Bellad, are we ready to start now?
Can you hear me now?
Yes, we can.
Can you hear me?
Welcome. Yes, we can hear you, sir. We are ready.
Please permit me to share my presentation.
Vasu?
Yes, ma'am. Yes, ma'am.
Yes. Welcome, Dr. Bellad. We've already introduced you. I hope you were around when we did the same.
I know.
Yes, we would like you to.
Okay,
Vasu?
can you?
Yes, sir. You can share the presentation, sir.
Can you share now? Can you see?
No, sir. We
share, sir.
1 second. Let me join and share my. Okay.
No. Do you want to, Vasu, should he send it? Yeah, that's perfect. Yes, now, yes, we can see it now.
Sir, put it in presentation mode or slideshow.
Yeah, I'm doing that. Is that okay?
Perfect, sir.
Yep.
Just, okay. Good afternoon. Sorry for that inconvenience. What happened is I was in an emergency. There was one twin pregnancy. They called me for atonic PPH. I'm on the OT dress only here. So sorry about that. Good afternoon. I think Dr. MC Patel, I must thank, and all the organizing team. Kavita Kapade, I think I must have been the most disturbed person for you today because this was an emergency. So cesarean section in previous LSCS, I've just gotten previous, it may be 1 LSCS, 2 LSCS, or maybe more than multiple LSCS. So the challenge here is the scenarios have changed. You all know people want even middle of the night to do cesarean. Please don't oblige to, in case you are operating on a previous LSCS, timing, budgies, everyone will tell for this. So be careful on these. Okay. So that part, you should be worried. And see, rise in cesarean sections, you know what is happening with this. The poor communication and poor counseling is the biggest difficulty in all C sections. So here is a small video I just want to share with you. If you don't properly communicate, hide karna kaise? So I open this. This is newest, no? Open network, nahi barabar. So if you don't properly communicate, you will end up with these problems. So let's be careful on this. So what all obstetricians think is cesareans are safe. Every cesarean is not safe. We should realize. In spite of taking aseptic precautions, we do end up with problems. In spite of proper anesthesia, pre-anesthetic checkups, still anesthesia complications are known. Antibiotics at least 20 minutes before you should give, but be careful while you are administering an antibiotic, which may cause problem. Am I audible? Hello?
Yes, sir. Yes, sir.
Yes, sir.
Yeah, we have seen quite a few patients coming with antibiotic anaphylaxis, and we keep watch on the blood transfusions. In last 2 weeks, we had 2 trolley patients in my own institutes. This patient was on IVF pregnancy. She was put on the anticoagulants and low molecular heparin. Patient had a severe gum bleeding, and for which he was given massive transfusion. Fortunately, we settled, and after 1 week we did section. Babies are fine. Hello?
Can the others please mute? Can the others, except for the speaker, please mute your mics, please?
Mary ma'am, please mute yourself.
Improved surgical technology is there, but they are associated with the challenges. So difficulties in C-section, especially with previous LSCS, entry of abdomen. In the entry of abdomen, you may have difficulty in entering the peritoneum. And once you may open the peritoneum, maybe even inside the peritoneum, you end up problems. People have opened the bladder, sometimes people opened the intestines. So one should be careful. So even delivering the head and all, I'm not going to the go in depth because there are separate talks on that, but placenta previa, accreta these days are more. Obesity, this is the scar is hidden in this obesity. So where to take incision is the challenge. And look, these are the types of patients we do receive for previous LSCS. So one should be very careful. And inside you may find the bladder like this. So I'm just showing you some of these videos of the entry of the abdomen. See, when you excise the scar, please don't open the incision inside the rectus. Also, don't open at the same level. Go inside. See, this is where I am doing is I am cutting with the cautery and going above the original rectus incision or the fat area, so that I will go in the virgin area on the rectus sheath. So it becomes easier for us to go ahead and do that. Secondly, when you see this, I hope the video is clear. So what we have done is we have taken the incision skin, excised the previous scar, but we have entered upper part of that. You cut the fat above that so that you are not opening in the same rectus area. And then, see, when you see this, here, you can clearly make out that the rectus sheath is very, very clearly seen, and it is like a virgin area on this side. So this advantage of this is when you approach the peritoneum here, you will be above the fat, and even the uterine lower segment adhesions are away from your area. So you please see that it is easily extendable, and your incision will be like doing a primary cesarean section. So youngsters, please follow this. It will be very, very useful. So, and once this is done, when you open the rectus sheath, there you have split that, and the muscles, when you see that at the upper edge and the middle, you will see a slight amount of fat. That is the indication for you to open for the peritoneum. Don't open blindly anywhere. When you go upper area, after the rectus sheath is opened and the muscle, they just split. See there, you can very clearly see the peritoneum, and without any of the bladder or the bowel, and omentum has gone on the sides. So you can make out that this was the above the bladder, so that even if you have got some band of adhesions, that can be cut so that you are safely opening the peritoneum, so that you won't injure the bladder. And you see this side, there is on the omentum is stuck on the right side, which I will show you in my next video. So this, once you have opened the peritoneum, look at this. The peritoneum is stuck on the upper area, and this is the bladder which is stuck. So when you separate, go as high as possible and open very gently and delicately. See that the bladder can go very easily down. Don't try to open here itself and you end up with the problems. So please note that entry of the abdomen in the previous LSCS is very, very important. And most important in many cases, the lower segment sometimes will be very much thinned out. And there one has to be careful because you may not get the proper planes to suture. So this is the video I am showing that how exactly I just want to show I routinely use and see, look at the uterine musculature is being cut with the cautery, and once you see the membrane, you use the artery to separate that and see some major vessels because the placenta was anterior and it was lying lower side. So we cut open that, and then once you see the membrane, we gently do that separation, and after this the ventouse is applied, because even if with the smaller area, the head can be easily deliverable. So the head is delivered very easily, so that there is no hurry to deliver the head. Once you are delivered, the placenta is delivered gently and nicely after ensuring that it is separated, and see that it is not causing any problem. But if there is a time, normally what we do in our institution is either delayed cord clamping or cord milking we are doing. So cord milking even in preterm babies is safe. The intracranial pressure what is produced with the milking is preterm babies are able to they tolerate that. So once the placenta is delivered, the challenge is in closure of this. So closure of the eye close in 3 layers, 2 muscular layer and 1 peritoneal layer. So this suturing is very, very important. And generally I can use either the green armtas or the Ellis forceps at the angles. First I start generally with the opposite side, so that we start with the angles are secure and the bleeding is stopped. You look at this, in this case, the lower segment is so much thinned out. The assistant's hand is coming in the way, but you see that the upper part is thick and you see this lower portion is very much thin. So usually we take first here and then we start from the other side. And you see that the separation, excuse me for that repetition. So this was the video I'm showing here is the omentum was stuck at this area, but initially I didn't do anything. See, this was bladder, which was stuck along with the omentum. So these are the challenges, but once you have delivered the baby, you have quite adequate space, and this is a ovary. So we separated this adhesions, because when you suture, sometimes bowel is behind this. So you need to be very careful. That is why after you have done the closure, I have opened one laparoscopy we have done post-cesarean, where the bowel was sutured along the angle of the uterus. It was posteriorly caught in that. So we just have to separate and suture the intestine, and patient went home. That was done laparoscopically. So please understand, posteriorly one should be very careful when you are, even when it is eventration is done or exteriorization is done. Sometimes for a bleeding, you may take deep bites at the angle, you may encounter these problems. So one has to be careful. And then these are the omental adhesions, which I just want to show there. And many a times you see this. These are the clamps applied on the after this delivery. Never try to do anything if they are not coming in your way. But later on, for the future, any of the surgeries, you should see that the abdomen is free of adhesions. So you have excess, so correct them and do that. So this is the omentum that was cut and separated. And this is where I was telling, when you are suturing the peritoneum, which I generally do it, so you better separate the peritoneum and the bladder properly, and suturing must be done adequately and correctly by 2 layers of the myometrium. So this is very important, because nowadays we are seeing a lot of cesarean scar pregnancies and placenta percretas and accretas. So even, when you see that woman in the previous, this was a case where the abdomen was falling like this and the scar was here. So what we did is we separated this part of so that, this placenta, the band of adhesion, fibrosis, is separated both at the upper and the lower edge of the incision, so that the fat closure, see, we put 3 LEs on upper and lower side and separate the 3 bands of adhesions generally are noticed at these. And once you separate this, the skin closure becomes very easy and the abdomen of the woman becomes flat. It will not be like, under covered like that. So this is the fat separation, which we do that because that is a fibrosis of the previous scar. So please understand, when we are looking at the previous LSCS patients, we should properly evaluate preoperatively. What is the goal? Is to minimize the maternal morbidity and mortality. Inform and keep your surgical colleagues. Sometimes you never know, the bowel may be stuck. You might have opened the intestine. Just keep that I am taking this case at this time, so that they are available. The time of delivery, if it is an elective, please keep this when every staff is available, so that blood and blood facilities and other colleagues for your help will be there. To maximize, please, preoperative hemoglobin should be very good, because antenatally one should correct. And blood, even though you may not anticipate, but sometimes may be required, see that it is properly arranged, and proper counseling before, because you may encounter, however expert you are, you may sometimes injure the bladder, sometimes you may injure the intestines. You must keep that, and surgical complications must always be kept in mind, and that must be told in a subtle way. Don't tell that, otherwise the patient may think that you don't know how to do the surgery. So you must convey that these, in a majority of the case, may not happen, but once in a rare situation they may happen. That rare person may be you. Sometimes it can happen. So this is very, very important. To conclude my presentation on that, antenatal buildup of the woman is very important, and ultrasound diagnosis is very, very important, especially proper positioning of the placenta. Reserve the blood. Protocol of the safe surgery must be followed. Always keep difficult cesarean section at good hours. And yesterday only we did the previous 2 cesareans. They were densely adherent, but things went very well. Ensure correct team, and most importantly, counsel, communicate, and provide a good care. These are the 3 fundamental principles of any good surgery. And previous LSCS, however experienced you are, however expert you are, it causes many of the time pressure and tension. So you must be cool, so that you can do yourself. When you are doing cesarean, is a team procedure. So the team leader must be cool. He or she should not be under any tension. If the leader become panic, then whole team will be panic. So be prepared, and you effectively manage the situation. So thank you very much. And to save the mother from the cesarean scar pregnancy and other complications, one must close the uterus in 2 layers and ensure that, especially myometrium. Many people don't close the peritoneum, but I do close, and I recommend closure for my colleagues. So thank you. Any questions? I'll be more than happy to answer, because it's a too vast topic. I tried to cover, because most of us here are well versed with this. Thank you. If there are any questions, I'll be happy to answer.
Thank you, sir. That was a very interesting and a very wonderful talk. Great with images and videos of surgeries. It was very interesting to hear, sir. And I request the chairperson for any comments.
It was a beautiful presentation with very nice videos. I want to ask you one question, sir.
Yes, please.
In previous cesareans, you said that we should close in 2 layers. That is
Yes.
what you are recommending.
Yes, yes.
But what I think is that it is not the layers which are important, 1 or 2 or 3, but it is the hemostasis. I mean, just approximation is required. And if there is a hemostasis, then if it is 1 layer, 2 layer, 3 layer, doesn't matter. Bulky, if you do in a previous section 2 layers, then there is more chance of, I don't know, there is more chance of it being a vascular area in between. So I would prefer you can use 1 layer, 2 layer, 3 layers. But I think if it suffices 1 layer and hemostasis is complete, then 1 layer is also good. This is my opinion.
So I just want to convey here is, see, when routinely 2-layer closures were done, our incidence of placenta per accreta, even cesarean scar ectopic or cesarean scar pregnancies were very, very less those days. And today, everyone in a hurry, single layer closure, the endometrium is not being proper. In between, it can pop out. Hemostasis is a very simple thing, sir. Whether you can do, I do without locking, continuous sutures, no lockings are done.
We should not lock at all.
Yes, that we don't do that. And second layer, when you strengthen the first layer, and that is where it matters, because in previous cesarean scars, usually lower segment has been thinned out totally, especially when you are doing a turn. So it is always strengthen the lower edge of the incision, because that is the one which is going to protect. And people are scared to take the second layer because of the bleeding. There is a technique that you should not be taking directly vertical to vertical. So you go obliquely, lower edge you take and come out in the oblique area on the upper side, and that covers the first layer. The objective of this second layer of myometrial closure is to ensure that this endometrium is directly not exposed outside. So that is the only.
That is a standard teaching, and I retired as an HOD, and I was taught only 2 layers, and I used to practice 2 layers. But for last 10 to 15 years, I was doing only single layer, and I was getting very good results. And one more thing, sir, for the beginners, whenever they do a cesarean section, and if it is a thinned out lower segment, or there's a previous section, and we should put a stay suture on the lower part, so that when you start closing it, you don't lose the lower. Sometimes you lose that lower thing. It is for the beginners, not for you or for experts, but for beginners.
No,
I think,
sir, there I recommend is especially people in emergency second stage cesarean section, or very thinned out area, because the people have sutured posterior wall with the upper segment.
Yes, that is what I wanted to say.
Thinking that it is an the lower edge. So because the lower edge goes beneath the bladder down. Absolutely. And they miss. We have been called for correcting this. The posterior wall of the uterus bulges and people suture. Correct. But never one message I would like to give whoever is doing the cesarean is, don't go as that I'm an expert, I can handle. See, people are stumped by the patients with the previous cesareans. So never be very much, that what I can say, that don't be overconfident as far as possible.
Absolutely. Because cesarean section
when we are overconfident, the patients teach us a lesson. So please don't be overconfident. Do the safest surgery.
It is the simplest operation, and it is the most difficult operation.
Agreed. Thank you so much, sir. Thank you.
Thank you. Okay, sir. Thank you so much, sir.
Dr. Anit, move on.
Thank you, madam. Thank you, sir, and thank you, chairpersons, for the holding on to the wonderful session. So we'll move on to the next session, and I'd like to invite coordinators, Dr. Prerna Keshan and
Wait,
Dr.
Dr. Anit, please wait.
Sorry.
Dr. MC sir is there, and I would like to
Sorry,
introduce
madam.
you over here. You can call the next session later on. So I request Dr. MC sir, our organizing web conference chairperson, who has joined, to say a few words. But before that, Mr. Vasu, I would like to have Dr. MC's CV, please. So as you all know, MC sir has been a great practitioner, a great academician, a great clinician, and a great medico-legal expert who has helped so many Foxians all over the country. So he has been the Vice President of Foxy 2018, Organizing Chairperson, Secretary of AICOG 2017, Chairperson of Ethics and Medico-Legal Committee Foxy 2011-2013, Honorary Secretary, State Organization of Gynecologists and Obstetricians of Gujarat 2022-2024, Organizing Chairperson of MMCon 2018, Honorable Member of National Inspection and Monitoring Committee PNDT, Government of India 2015. He has been President of Ahmedabad OBGY Association 2010 to 2011, and he is National President of the National Medico Organization. He is President of Ahmedabad IMA Branch 2007-2008, Organizing Chairperson of Vivekanand NMCon 2013, and President of Lions Club Ahmedabad. So welcome, MC sir. We would like to have your inputs on this web conference.
Thank you. Thank you, Dr. Dolly. Let me say a little sorry because I was stuck up in one flight. But it gives me immense pleasure to welcome you all the guest of honor, faculties, and my team, coordinator, conveners, and all the delegates who have joined this webinar. With experience of my Happy Learning Masterclass, so many of have attended that very series. And in this week only, we completed our 194th episode. And with this, so many of our friends requested me to come up with this kind of webcon for whole day with specific focus topic. So we selected surgical skill tips and surgical techniques rather in our day-to-day OBGYN practice. And we have selected faculties who are master in their respective field. So hopefully we all delegates who have joined this webinar and who are going to join in few times, they are going to be benefited lots with this webinar. And one more thing, I was listening to Dr. Bellad. Bellad is excellent speaker. I have heard him so many times. He stick to topic. As far as previous section is concerned, he has very specifically mentioned that if it is elective one, it is always better to do at convenient hours, because as far as medico-legal consequences related to this part is concerned, if we have planned in early morning, if at all blood is required, if at all assistance from other colleagues are required, it will be easier for us to manage in this type of situation. One more thing, proper counseling in previous LSCS, whether it is one previous LSCS, two or multiple, is very much important, with possibility of injury to surrounding structure like bladder or bowel or so, and requirement of blood. If we have explained this to the patient and relative, and if at all it happens, then it becomes easier for us to face the situation. So very nicely discussed by Dr. Bellad. So without wasting much of your time, welcoming you all the guests of honor, faculties, speakers, convener, coordinators, and all the delegates. Thank you very much.
Thank you, sir. Thank you. Thank you, Dr. Patel. Thank you so much.
Sir, Rajoria sir, Rajesh sir, one point I just wanted to add on. Somebody asked last time that which steroid we are using. See, if in India, dexamethasone only is recommended. Sorry to interrupt in between, but the reason being, we do not have the betamethasone, which is the combination of betamethasone phosphate and acetate. Actually, in Europe and USA, we have betamethasone phosphate 6 milligram, betamethasone acetate 6 milligram. One is short acting, another is long acting. That combination betamethasone we do not have in India. So it is my sincere appeal to everyone to use dexamethasone, and it is recommended by Government of India. So if you are using betamethasone for the lung maturity or for prematurity, and there is another note I want to, if you are not delivering her within 1 week, please don't use the steroid, because it has become, people at 28 weeks to give the patient twins because he is likely to deliver. She may not deliver at 28 to 32 weeks, because if you observe our Lancet publication on antenatal corticosteroids, where the pregnancies, that is the first study which looked after the pregnant woman and the babies who went after receiving the steroid, they did not deliver preterm. They went in for term because that was given like that. And when they went into term, there was an increased incidence of sepsis in both mother and the babies. So I request everyone, unless you are delivering preterm within 72 hours, don't do this. And tocolytic use also is recommended only 72 hours to ensure the steroids to act. So my humble request on use on antenatal corticosteroid. We are also doing one current study with the WHO on, is 12 milligram betamethasone is required or 2 milligram is required, because 12 milligram is a very high dose, and that is why this study we are taken up. So I am sorry for that interruption, but this information.
No, actually, sir, that question was not for the baby. The question of steroid was for the mother. Mother ke liye tha.
No. I was not, but generally I am talking about
Absolutely right, and Safdarjung Hospital is also part of the 2 milligram study.
Yes, I know that. Because it is come from that. We are the lead site on that, sir.
Dr. Chalani he's made it. Okay, sir. Thank you.
Thank you so much, sir. Thank you, respected chairpersons. We'd like to move on to the next session. Over to Dr. Prerna and Dr. Dhwani.
Thank you, ma'am. I'm indeed a great honor to be here and a part of this wonderful CME today, and such a string of stars and dignitaries around. We have our next session, that is the session on troubleshooting and delivering a baby in LSCS. Thank you, Patel sir, for giving us this opportunity to coordinate the session. And I also welcome my coordinator, Dr. Dhwani Rolekar. The first chairperson for this session is Dr. Alok Sharma sir. Dr. Alok Sharma sir is a consultant OBGYN, Maternity and Child Health Center, Civil Hospital, Sundarnagar, Mandi, Himachal Pradesh, and is the founder secretary of Indian Menopausal Society from Shimla chapter, and is a member of Public Awareness Committee, FOGSI, and holds various credentials to his credit. Second chairperson for the session is Dr. Mary N.A. ma'am, who is a senior consultant, past president of Naga Coil ONG Society. We welcome you, ma'am, amongst us, and we are really, really honored to have you. Our third chairperson, Dr. Dhwani, kindly introduce our third chairperson, Dr. Sarveshwari Notia. Dr. Dhwani, are you there? Dr. Sarveshwari Notial is the founder and managing director of the Kishori Foundation, and the NGO work focused on conducting screening programs and awareness camps in rural and urban areas of Uttarakhand. Ma'am was Director, Medical and Health Services, Government of UP, and is a life member of UP chapter of OBGYN Society. And her field of interest is early detection of breast cancer and cervical cancer. Ma'am holds various credentials to her aura, and we welcome you, ma'am, to have you amongst us, and really honored to have you. We now request our chairpersons, Dr. Mary and Dr. Sarveshwari. We can't see Dr. Alok Sharma joining in. We have called him, but maybe he's stuck in some emergency.
Prerna ma'am, we have Deepak sir also in the chair.
Sir. Yes. Hello.
Yes, ma'am. Deepak Bagde sir.
We have Dr. Deepa Bhagde sir with us. Dr. Deepa Bhagde sir is a very, very learned and a very, very known face for every Foxian. He is the founder of the Foxy Friends, for which is so well known, and is a very dear senior for each one of us. He's a past president, SOGOG, all Gujarat's Gynae and Obstetrics, and Dr. Bhagre has been the past president of SOGOG and past his past positions and head of the department of MP Shah Medical College, Jamnagar, and he is the first ever SOGOG oration in 2014, and he's delivered almost about 63,000 babies in his practice since 1985. We are so proud to have you amongst us, sir. So we request our chairperson to kindly introduce our speaker. Speaker Dr. Suchitra Pandit ma'am is in a glitch of which she has will be taking some time. So our first speaker will be Dr. Muralidhar Pai. So I request our chairpersons to kindly introduce our speaker. Over to you, sir.
I think can we have CV of Dr. Pai? I think, first of all, I want to thank Dr. Patel for giving me this opportunity to be here with such a elegant, educated, and highly qualified persons. I know I have worked 36 years in Gynae in different places of Uttar Pradesh, and I have come across every complication of cesarean section. So this topic was a topic everyone should know about it. So this is chosen by Dr. Patel is really a creditable topic for all of us. I know I'm going to learn a lot from my seniors and from my juniors also. And I welcome Dr. Muralidhar Pai. You taught me something. You taught me how to write the CV. Everything in 4 lines. So it's a great pleasure to introduce you, Dr. Pai. And I know you are in medical college, you are in professor. Your CV shows a professor should be like this. So I'm so happy to see Professor Muralidhar B. Pai, and you are Dean now in Sikkim Manipal Institute of Medical Science and Professor of Ops and Gynae, and 37 years academics, 22 awards, 15 international fellowship, 207 publication, 3 textbooks, and 792 guest lecture. Everything is there. So congratulations, and I wish all our juniors should be like you, and they should create an example. Those examples should come from them to their students. And at this age, I can say I'm also a student of yours. I can follow you, and this is what we need from our coming high posted, high literated, and high educated juniors. Thank you so much, Dr. Muralidhar B. Pai. I want, please start your topic. And that was my favorite topic. If the head is free, how to take out in cesarean a free head. This was my favorite topic. And of course, fixed head is also a problem. And the free head is more than that. So please start your topic. Thank you so much being with us. And I'm really, I can say it's my pleasure to see Deepak Bangne here, and the Ashok, I couldn't see him, and the Mary, I think her name is Mary Annie, and she's there. Thank you so much. And please start your topic. Yeah. Thank you.
Thank you so much, Sarveshwari Madam, for your kind words. And I thank Dr. Patel, sir, for giving me this opportunity. Please allow me to upload my PPT. Yeah, thank you so much. We think that cesarean section is the simplest of the operations. And of course, it's the commonest operation that is done all over the world. When everything is fine, it's definitely the easiest operation to do. People have done in no time. I myself, the shortest duration of my cesarean section, once the anesthetist timed it, it was hardly 14 minutes. But then my previous speakers have told the difficulties that they can have in the previous cesarean sections, obese patients, and things like that. Now, floating head is a big challenge. People usually think that floating head should be easy compared to a deeply engaged head. Yes, deeply engaged head has its own challenges. Dr. Suchitra was supposed to talk about it. I'm sure she is going to shortly talk on that. That's a big challenge. But then floating head is also a challenge. Usually, if the head is just gone into the pelvic brim, or if it is engaged, just engaged, it's very easy. The method that we use is what we call just liver out the head. In fact, in one of the DNB exams, the examiner asked the student, what is the role of the thumb? Most of the student could not answer. The answer is, there is no role for thumb. In other words, we do not grip the head and pull out the baby. It is impossible to hold the head and pull or lift anybody. However, it is easier to pull others' legs, both metaphorically as well as during cesarean section. So with that as an introduction, let me now give you different scenarios of floating or mobile head. The commonest scenario is a preterm baby, because here the lower segment is not well formed, and usually the head is high and not engaged. And here also we have to be a little careful. The baby is smaller and the head is also very softer. The bones are not, ossified properly, and the sutures are also not ossified properly. There's a wide gap. So how do you manage? Well, you can manage this in the same manner as other cesarean sections by putting a lower transverse incision, but many books, many authors suggest a low longitudinal incision. This is because we can actually extend the incision little higher if you need. It is always easier to extend the longitudinal incision compared to a transverse incision. But one has to be careful not to extend the longitudinal incision lower, because it can encroach the base of the bladder. Now, people have also suggested classical cesarean section for preterm baby, but all of us know classical cesarean section is a no-no in modern obstetrics, except very few conditions, like maybe sometimes conjoined twins, or if you are going for a cesarean hysterectomy, or if you are doing a cesarean section in a cancer cervix patient. Whereas low longitudinal incision is the most preferred incision to deliver a preterm baby whose head is floating. But as I mentioned a little earlier, a lower transverse incision is also okay. But then you have to follow the same principles which I am going to tell in case of a term baby with a floating head. Now, what is the principle that we follow? There are different principles that we can follow. One is manual delivery. The other is an instrumental delivery. Let me talk about manual delivery first. Here, the incision has to be as low as possible. This is very important to understand. My professor and HOD used to say, even if it is an elective cesarean section, it is always advisable to do a pervaginal examination before you do the cesarean section to know the length of the cervix. If the cervix is long, then the incision has to be as low as possible. If the cervix is very short or taken up, then the incision has to be as high as possible. After a low incision, you have to insert the hand below the head before the head slips this side or that side. This is very, very crucial and important before applying any other technique. Now, once your hand is below the head, then you should not rush to deliver this baby because it is slightly difficult as the head is floating and high. What you have to do is you have to allow the liquor to drain little bit. Once the liquor goes down, slowly the head will slide on your palm. And now is the time it is easier to hook out the head. Should you have any difficulty, you can ask your assistant to give a slight fundal pressure. In fact, you don't even have to ask. Nowadays, all the anesthetists are very well versed, and without your asking, they offer to give the slight fundal pressure that is required. With this simple technique, most of the floating head can be delivered. Now, the next thing is, before I go to the next technique, I am showing here what is actually meant by slight fundal pressure. So you put your hand beneath the head first, allow the liquor to drain, and then gentle fundal pressure will complete the job. The next one is, as I said, instrumental delivery. In that, the first preferred, the simpler, non-traumatic is the vacuum delivery. Non-traumatic both for the baby as well as for the mother. But we must remember that vacuum delivery at cesarean section is only for the term baby and not for the preterm baby, because anyway, even in vaginal delivery, vacuum is contraindicated for preterm baby. Now, usually it can be the same vacuum that you use, or you can use a silastic cup as well as, you can use a kiwi's cup at the time of cesarean section. The only point is if you're using just the cup with the attachments instead of a kiwi's cup, then you need to have a long tube. And this should be always kept ready because you cannot go and search for this at the nick of the time. In Manipal, we always had a vacuum in the OT also with a long tube. And then, of course, where to apply the vacuum cup. Of course, as in case of vaginal delivery, the cup should be applied as posterior as possible. We don't have to measure here the vacuum distance and all other things. The posterior as possible is because while we deliver, we know that we have to maintain the flexion of the head. That is the most important aspect. Now, that is exactly why another important tip is before you do the cesarean section, before you do the pervaginal examination, you must have a abdominal examination and a clear-cut idea which side is the back, because usually the occiput is on the same side as the back. Okay, so once you know that the back is on the left side, this vacuum cup can be applied onto the left side of the head, which is obviously more towards the occiput. And once you apply this, then you can actually deliver the baby in the same manner, maintaining the flexion of the head. Now here, it is a kiwi's cup. As you can see here, apply the cup and it is just a hand driven and you can create the vacuum. And most important thing is maintaining the flexion. That means as in vaginal delivery, we always, the traction is in the direction perpendicular to the head, and maintaining the flexion of the head, that is very important. You may anticipate some extension of the incision either while applying the cup or while delivering the baby or both, and you have to be ready for that as well. The next instrument is a forceps. Well, in a deeply engaged head, it is a single blade, or there is a special instrument called vectis, because you cannot apply both the blades in a deeply engaged head. This single blade will act like a shoe horn. Whereas in a floating head or a mobile head, you need to apply both the blades. I want to underline both the blades. Now, which forceps to be used? You can use an outlet forceps because the head is just there. It is not very deep. So there is no need of a low cavity forceps or any other type of forceps, just a pair of ordinary outlet forceps. Again, this is a very, very important instrument, should be kept in a OT for delivering the mobile head. Now, how will you do this? So you can actually use the left blade as the lower blade. There is nothing like left and right here, because usually in a floating head, the head is in a transverse position. So the left blade will be like a lower blade. And on top of that, you can apply the right blade. And here, once you apply properly, this is obviously a cephalic application, because here left blade goes to the left side of the baby's head and right blade goes to the right side of the baby's head, even though we use it like a lower and upper blade. And then you deliver the baby slowly as shown in the video. And once you deliver the head, then of course you can disconnect the blades, and then of course you can complete the delivery. Now, it is very, very important to note that not everybody can use this. I have used it a couple of times for a floating head, not to actually use it as a method of delivery, but to demonstrate that it can be done. So it is always important to apply this on a mannequin and try this, whether you can do this or not. So here, as you can see, as in vaginal delivery, we have to do a phantom application first. Then you have to put hand below the head, and on the left side, the left blade goes to the left side, right blade goes directly onto the right side. Every time you have to guard the blades, not to injure any soft parts of the mother or the baby, and both. Here it is very important. Extreme gentleness, extreme caution is very important, and then you slowly deliver the baby. So that is about it. And the final or the desperate attempt is to convert the cephalic presentation into a podalic presentation, because if you remember what I told right in the beginning of my talk is that it is impossible to hold the head in your hand and deliver the baby, but it is always easier to pull others' legs. So what you do here, you put your hand inside all the way, catch hold of the ankles of the baby, and slowly do the internal podalic version so as to convert the cephalic presentation into a podalic presentation, followed, of course, by breech extraction, because you have to do all these things in succession, and immediately there is no assisted breech delivery here, but it is usually a breech extraction. But having said that, you have to follow the same principles. That is, the back of the baby should be facing the obstetrician, and when you pull the baby, it has to be parallel to the OT table and not at an angle to the OT table, because if you pull at an angle, then the baby's head will go for extension, and that will be extremely difficult to deliver the baby. So as you can show in this graphics, that you put your hand all the way inside, catch hold of the ankles of the baby, and gently rotate. Now, these things have to be done with extreme caution, and then, of course, you will be delivering like a breech extraction. If it's a very thinned out uterus, if there's a baby is big, this procedure can be extremely difficult, but this is the only option. The other option could be converting this transverse incision into a inverted T incision, but then whenever you give inverted T incision, please remember the incidence of rupture of uterus is same as that of a classical cesarean section. So if it is a primary gravida, then you have to counsel the patient beforehand that this is one of the possibilities that we may have to do, and all the other consequences. If it is a multi-gravida, then of course it is prudent to have taken the consent for sterilization, and if you had to have a inverted incision, you should usually follow that operation by bilateral tubal ligation. So that's all I want to talk about the floating head. Thank you so much for the opportunity.
Dr. Mary, you want to say something? Dr. Bagde? Deepak?
Yes, only that was fantastic and very well thing. The only difficulty, yes, I understand we have used all that thing. I'm more comfortable with forceps, but that is something different. It's a personal thing. But what I would like to say, Dr. Murlidhar, what in a case of a twins,
Yes.
When
In fact,
it's
I had
the first one is an oblique thing. It's
yeah.
because it's so floating. By the time you put it in the head goes and turns into a transverse or something like that.
Yes. In fact, I had that 14 minutes cesarean was actually a case of triplets where one of them was a conjoined twins. If it's a simple twin, it is still easier. The conjoined twins was difficult, and everything was floating there. Nothing was fixed. First, we had to deliver the singleton baby. Luckily, you may think of so many things before putting the incision, but once you put the incision, once the liquor drains, the things will totally change and on the table, and you will have to. The one important point in all these situations is that your both abdominal incision as well as the uterine incision has to be big enough. Don't worry about giving a small scar and playing there. So this is very important. People prefer a classical section in those situations, but most of us would like to avoid that. So I had given a transverse incision only. Now, luckily for me, that first baby was a singleton baby. I delivered somehow. It was a small baby. It just came off like that from the intestine. But now the challenge was both the heads were floating. And then you have to deliver one head, and then whatever comes to be delivered, the baby offers itself. Please take me out. This is the first. So you have to do step by step. And I totally agree with you. These are the situations where you have to keep your calm at most, and you have to have enough space. Don't worry about the space. Everything can be set right later. Even if you had to extend the incision transversely, or even if you have to go for inverted T, don't hesitate to do that. The most important thing is to come out clean, and then you have all the time on earth to repair the uterus. And that's why it's always better to take a consent for sterilization before that.
The other thing, Dr. Murli, you said a very gentle fundal pressure. Does it really work? Frankly?
No, it is. In fact, in one of our PG classes, we had a nearly 1 hour debate whether to give fundal pressure or not, and the debate was twofold. One was the fundal pressure in vaginal delivery. Second was fundal pressure in cesarean delivery. I can just give the conclusion. The conclusion was fundal pressure in vaginal delivery should be avoided at any cost, because there is a fear of inversion of uterus and things like that. Whereas you are not worried so much about the inversion in a cesarean section, because you can always easily reduce the inversion or revert it back. Whether fundal pressure helps or not, yes, it helps. Many a times.
Personally, I feel that's a good method. Frankly, and the second thing I would like to say, as you say very rightly, floating head. I would really like to map the fetus before I really start on a fetus, because as you said, you might have to go for internal modeling. Once you map the fetus, before that, you really know where to get the ankles. That is very important, because as you said very rightly, the liquor is drained, and you struggle to find even the ankles, or you even struggle to find any part of the baby. So the experience says that at least try to map, especially if it is a premature and a floating head.
And there can be a fracture femur. People have done desperately so many.
I've done couple, but that was in bridge delivery, the initial years of my practice.
Sir,
can I make a comment?
Sir, please, sir. I was waiting for your comments rather than advice.
Murli, in my last 45 years of obstetric practice, I have used forceps for delivering a baby's head always. Right from that day till today. And I have never had the need for the anesthetist or the assistant to sit on the baby patient's head, the tummy, to push that baby up.
Sir, is it routinely or for floating head? Is it routinely or for floating head?
any head. As soon as I disengage the head, I apply the forceps and control delivery. There is no question of anybody pushing from up or anywhere and whatever. And I have done that for the last 45 years. It's not something which it's a sporadic thing that has been done. I've never used the 1-2s because when you use the 1-2s, it takes a couple of minutes before that head can be applied on the head to pull it out. And now if you look, I'm going to, when I talk about my Odon device oration, I'm going to tell you exactly what the RCOG said and how the RCOG changed in their attitude regarding 1-2s to forceps, forceps to 1-2s and back to forceps and so on. So that is one thing. And second thing, you said about a vertical incision. In my 45 years, I have never taken a vertical incision. I can deliver any preterm or whatever through a financial incision, lower incision.
Yes, sir.
There is no need because if you start using a forceps, either preterm, floating or whatever, you have a controlled delivery and there is no need for anything. I'm sure PK would be able to add on to it. He has done so much of obstetrics in Mumbai along with me.
Mary, you want to say something?
PK sir.
Good afternoon. Excellent talk. But I feel personally that when Dr. CN said that vacuum takes time, there is one vacuum which is called MITIVAC, which doesn't take so much time. So you can use that instead of any other type of vacuum. That is one thing. And I fully agree with CN that forceps helps delivery in the best possible way compared to vacuum. And we have in teaching hospital in our unit 8% forceps delivery, 4 to 8% in different years. For 34 years that I have worked there in Sion Hospital and KEM Hospital. If you know how to apply forceps, it's an excellent tool to use for vaginal delivery or even for delivering baby through C-section in lower segment.
Thank you, sir.
Yeah.
Thank
you.
you.
I want to say something.
Yeah, just a quick.
Unmute yourself. Unmute yourself.
I echo
as Dr. Pai said,
Dr. CN and Dr. PK. Yeah, that my forceps rate is almost 20% even now, and I don't know. It's just because of the practice or whatever it is. It is only one blade I use as a practice, even in a floating head, and I've been quite successful with some pressure, funnel pressure, and a practice as a help. Thank you.
Mary, please
Very
say something.
one interesting case, Murli, I must tell you, which I saw about 10 years ago, where a patient was transferred for repeated hemoglobin drop and going into shock and was transferred from Dubai by flight to Mumbai. And when I examined her and I realized that there was intra-abdominal bleed that was happening, people were suggesting that it was probably poor closure of the uterus or whatever. And would you believe that when we opened the abdomen, it was a liver tear because they were trying to push the fundus from top to get the baby out.
That's a very, yes.
The rib had gone into the liver and there was a liver tear which was continuously bleeding. It had to be sutured to so that patient could survive. These are the things which are occasional complications, but you must realize that there is no need whatsoever to do all that.
Yes, sir.
Sir, can I make one comment, sir? I actually just about delivering of a preterm baby in cesarean section. Some people have used. They give 5 units of oxytocin before the baby is born, and that helps in delivering the baby. So, what is your opinion about that? I have used it in a few places.
I have no idea, sir, because usually
I have done it, but I
no,
don't know
we
whether what is
usually
the
give
recommendation.
oxytocin after the delivery of the.
See, that is a standard thing. But I have used it in 2-3 places, but I was scared after that.
CN sir should give the opinion, sir.
The one point I want to say.
Yeah.
Thanks to Dr. Purendre, thanks to Dr. PK Shah, Thanks to Dr. Deepak. Thanks to Dr. Kishore. And a big thanks to Dr. Pai. Because you have taken me, it was so lively. You have taken me literally to the theater. And I felt as if I'm doing. So it's great, and it's a real education to all of the delegates, all of us. And about the Forceps, I had a professor who always delivered the baby in cesarean by the Forceps. Dr. Alpesh Gandhi, what do you say about
Good
this?
afternoon, Alpesh Gandhi, sir.
I am enjoying the discussion, sharing of experience of all of you. I just wanted to make the comment different. I am using a vacuum during cesarean very frequently in my practice. That's a different thing. What I am going to tell is different thing than the scientific talk. I would like to congratulate Dr. MC Patel for this brilliant scientific program. And you all will be surprised to know that at present, more than 3,000 have joined to listen our esteemed faculties. So this is something new, because in the time of so many webinars in a day, we have 4 to 5 webinars in a day, and usually presence in all webinars around 200 or 250 or 300. And today we have more than 3,000 delegates who have already joined, and they all are getting tips from Dr. Mulidhar Pai, Dr. C.N. Purandare, P.K. Shah, and all our esteemed faculties. So I would like to congratulate MC Patel, and would like to thank all the esteemed faculties.
Thank you, sir.
I just want to say one thing. We need a person who is so educated in medical field, in everywhere, in gynae, Dr. MC Patel. He has made all of us to join together here, and not a single, but 3,000. So we should be with you, sir. Our best wishes are with you, and love to celebrate your victory. Thank you so much.
Thank you.
Thank you, ma'am. Thank you, sir. Thank you, speakers. Thank you, chairpersons, and our respected Bhagle sir and Alpesh sir and the entire crew. Thank you so much for being with us. We really are honored. Do we have Thwani with us? Thwani, are you there? So we now move on to the next session, and I hand over to our coordinators of the next session, Dr. Pranjal, to move on with the further proceedings.
Thank you very much, Prerna.
We were waiting for Suchitra. Has not joined.
Ma'am has certain emergency, so ma'am will be giving a talk a bit later.
Okay, I'm a real big fan of her.
Everybody of us, madam. So after a fantastic heart-throbbing this talk on of section of troubleshooting, now let us march towards, without much ado, let us march towards our next third session, which is going to be oration by none other than respected dignitary Dr. C.N. Purandare sir. Sirs, everyone, not only in India, he is an international figure, we know, and he's been looked upon for any problem if an obstetrics is facing. So welcome you, sir, again. And indeed, we are lucky to have two honorable chairpersons, Dr. P.K. Shah sir and Dr. M.C. Patel sir, to grace the occasion of this oration. So without much ado, I hand over mic to. Before that, please, CV of Dr. Shah sir. Vasu. Dr. P.K. Shah sir's CV. Yes. P.K. Shah sir.
Pranjal, just one line. Pranjal, just
sir,
one line.
Yes, sir. It's very difficult to sum up you in one line, sir. You are gurus of all gurus, sir.
Sir, you don't need any introduction. I know that. You don't need any introduction. But let her say something about you.
Sir, Guru of Gurus, sir. Heartful respect for you from all of us. We are very indeed lucky to have you, sir. And just to complete the formalities, sir was past president Foxy, IAGE. Sir was past president ISOPAP West Zone, joint secretary Images, fellow Wellstart International USA. Many posts he has graced in Foxy, nationally, internationally, many conferences he had been faculty, and above all, sir is known as a teacher of teachers. So welcome you, sir, for this.
Enough.
Thank you, sir. Thank you.
Thank you.
Thank you very much. Next CV, Dr. MC Patel, sir, CV. So this full day we are enjoying the academic fees because of mastermind Dr. MC Patel, sir. What to say about him? Dr. Patel, sir, is a consultant obstetrician gynecologist and he's a medical legal counselor, Vice President Foxy 2018. Sir, so we are really enriched by your presence and thank you, sir, for this special webinar. So I request Dr. Shah, sir, to introduce legendary Dr. C.N. Purandare, sir.
5 மாசம் முடிஞ்சிருக்கு. நீ மார்க்க டெஸ்ட் நம்ம பண்ணிட்டோன்னு அதனால நல்ல வேலை அதாவது போச்சு. வித்தியாசமா ஒண்ணும் இல்லைம்மா, எல்லாமே நல்லா இருக்கு.
Technical team, please mute all of the others.
बोला था मैंने, राजन बोला था ना, मैं
Shah, sir, please introduce.
PK, you are mute.
I can't read it, but anyhow, there is no need to read out anything for Dr. C.N. Purandare. He is the past president of FIGO, Foxy, Mumbai Obstetric Gynec Society, and a very, very, very loved teacher from Mumbai. I had an opportunity to work with him when I was the secretary of Foxy and when he was the president. And I think I have learned so many things from him, other than obstetrics and gynecology also. I can't read because he was made honorary member of so many international societies that if I try to read that, I think I'll take at least half an hour. Without much of ado and without wasting time, as I can't read your CV properly, okay, now it is seen. But I think we would love to hear you, CN, speaking on Odon. I think this is something which we all must know and practice. Though we have been talking about it for last many years, it is not being practiced. And that is why probably Dr. MC Patel thought of the best person who can deliver this talk, and that is Dr. C.N. Purandare. So, Dr. C.N. Purandare, the stage is yours.
Dr. PK sir, can I take 1 minute?
Yeah, go ahead.
Yes. Dr. PK sir, and I would like to, I'm happy to share with all of you that recently, just in last month, Dr. C.N. sir was awarded fellowship of AOFOG, Asia Oceania region, and I was a witness there. So proud moment for all of us. So congratulations, Dr. C.N. sir. I know you have so many fellowship, but this is one more and special for me because I was there.
Thank you.
Thank you, Dr.
Thank
Alpesh,
you.
for sharing this information. But before Dr. C.N. Purandare takes over, I would like to thank him very specially because in spite of his very busy schedule, merely on my first request, he had agreed to deliver this oration and this new subject, Odon, we have selected to be delivered by Professor C.N. Purandare. So without wasting much of your time, all the delegates, etc., then I request Dr. C.N. Purandare to proceed with the oration further. Thank you, sir, for joining.
But before CN starts, I think I want to inform all those who have joined us that Dr. MC Patel is contesting for the post of president for the election year 2024. And I request you all to vote for him for the post of president. And I wish you success and all the very best, Dr. MC Patel, sir.
Thank you, sir. Thank you.
Yeah.
Can I request the host to allow me to share my screen? It has disabled screen sharing.
Technical support team.
Vasu, please take care.
Done, sir. You can share your screen now.
The technical team needs to allow me to share the screen.
Sir, you can share your screen now.
Please make him a co-host.
Yeah.
Yes, now they have allowed it. Okay.
Thank you, sir.
How do I go to? Okay.
Sir, slide, sir.
What has happened?
Okay, sir. Okay, we can listen you.
Full screen.
How does that happen? Full screen now?
Next to the 79%, there is a cup shade.
Okay, anyway, let me start off with, can I have this thing out, my, the rest of the pictures for the time being? So that we can, anyway, MC requested me to talk on Odon device, and recently I've given this talk to 2 or 3 different societies on this Odon device. But my special interest in it is because I have been associated with developing the device from 2012 to today, which is 12 years of hard work in changing what originally was proposed as a device by WHO to be considered. Now, this is something which in operative obstetrics is a new tool on the block. I mean, this is apart from the vaginal delivery where we use 1-2s or Forceps or whatever, we have this Odon device which is being now the trials are over in Europe. It will be marketed in Europe in September, and hopefully it will be marketed in India in March or April of next year once the clearances are there. You all are aware that there is a rising trend in cesarean section rates in the changing world, and that trend is due to many reasons. And I mean, you cannot pinpoint any particular reason for the cesarean section rate rising. Whether it is MC Patel's medical legal reasons which are pushing the obstetrician to go for cesareans rather than vaginal deliveries to avoid any kind of risk of complications, or for that matter, many reasons where there are multiple pregnancies because of IVF and women marrying late beyond 35. So the incidence of late pregnancies are there. And I was just 2 days back, my son was telling me that he had just come back delivering a 48-year-old woman. So you can realize what the situation is where IVF is being done by women at 45, 47, and so on. And when you look at the cesarean section rate, I wish I could get rid of this.
You have to change the slides from the arrow.
No. This is fine. This is fine now. I've got this sorted out. Okay. The cesarean section rate, when you look at various places, and I remember the time when 2018, when we were in Brazil and we were trying to get the local hospitals to have the pre-Congress workshops on various aspects of cesarean and normal deliveries and so on. And the section rate in Brazil was over 80% in the private practice. And when you look at the cesarean section rate starting from Egypt, where the Egypt cesarean section was 10%, is today 56%. We're talking about 20 years where the section rate has gone from 10% to 60, nearly say 56%. And the same also in China, and means the Chinese cesarean section rate has gone up so much, especially when there was a one-child norm, the cesarean section rate was over 60%. And I remember going to China for birth congress, and I was giving a talk on repeat cesarean sections and vaginal delivery after birth. And I asked the audience, which was a good 1,000 people sitting there, that has anybody delivered a second baby? And would you believe nobody stood up? Which meant that they were going to face a 60-70% cesarean section rate women going in for deliveries where the placenta accreta, placenta perfida, whatever, and they had never ever seen a situation like that. So how do you tackle a situation where the cesarean sections are so high?
Sir, we are not seeing your other slides. This is only first slide. You might be changing, but you might be changing, but it is not displaying here.
What is happening?
Slides are not changing, sir.
Why are they not changing?
It's stuck.
Now it is locked completely. Your screen sharing is locked, it says.
Screen sharing is there. It is, we are getting the message. You are viewing Professor C.N. Purandare's screen. So your screen share is there, but somehow.
Now, how do I go about it? Will technical team tell me how to sort this out?
Can you share your PPT, sir? In the group, we will share. We will start it from here, from technical side.
I can say, can you see the thing now with all my slides?
No, Ranjan, your slide is seen with your photo and your name. No other slide is seen.
How do I do? What I can do is I will go out and come back again.
Yes, sir. Yes. Stop sharing.
Yes, sir.
Stop sharing.
No, the share part is not moving at all.
Sir, you please come out and join again.
That is the only thing I can do.
Yes, sir.
Yeah.
Can the technical team help in that, sir?
Okay. Now I am sharing the slide.
Yes, sir.
Okay, is that seen now?
Is
the first slide?
Sir, change it from your side, from the arrow with the.
Can you see the second slide now?
Yes, sir.
Yeah.
Okay, then we'll stick to that and let's get on with it.
Yeah.
So, as I said, that there is a rising trend in cesarean section, and the section rates, which in Brazil were 80%, and now in China and so on. So the incidence of cesarean section has nothing to do with the evidence-based medicine, the way the section rates are going up. But does it have more to do with the doctor's income as perceived by society? And when we were taking out the recommendations from FIGO, this particular aspect was very positively highlighted by some of the countries. And that's why if you see the FIGO recommendations, it says that the charges that the doctor charges for cesarean as well as normal delivery should be same. It would mean that probably you will be charging more for normal delivery and little less for what you're charging for cesarean section. So overall, when you say that if you're delivering 100 delivery, your income will remain as it is, but the patients will not perceive that you are doing a cesarean section because you're going to make maybe a lakh or two more. And that's why purposely you're saying that cesarean section should be done. So the FIGO recommendations say now that the charges of normal delivery and cesarean section should be same. As a matter of fact, you put in more effort doing normal delivery than a cesarean section. And doctor who there is a perception also that doctor who does not want to work at night, or the doctors who has lost his or her skill to attend a difficult vaginal delivery, you try to do a cesarean section. And I remember a paper which came out through Vadia Hospital once, saying that maximum cesarean sections were held between 4 and 8 p.m. because people wanted to go for their consulting rooms and they finished their cesarean section went, so they didn't have to come in the night as well. So these are the situations which are prompting for cesarean section to go up, and of course the medical legal issues that are. The major biggest issue in obstetrics is dystocia. When you call everything that dystocia is responsible and therefore you are going to do a cesarean section, you need to understand the progress in obstetrics is more difficult to achieve than many of us believe and think. That we can do something and go ahead and modify things. It is not so simple as that when you are trying to do the progress in that. But in the meantime, many doctors have lost their skill to attend a vaginal breech or a twin delivery. If you ask nowadays a newer generation to go and deliver a vaginal breech, they will run away. And I'm sure P.K. Shah is here, who has actually produced papers to show how beautifully vaginal deliveries can be done without any morbidity increase. And the horrible trial which was conducted in Canada, which said that breech delivery has the risk of huge mortality, and therefore cesarean section should be done. And most of the breech deliveries started having cesarean sections. But one must understand that whether you do breech delivery by cesarean section or you do breech delivery by vaginal, the technique remains exactly the same. How you deliver the baby. One is you are doing quickly, the other one is masterly inactivity. And now the new president of FIGO who's coming in has shown time and again that the position of the patient, where it's on force, when the patient is delivered like an animal, the breech comes out on its own without any hassle at all. And those are the techniques we need to go back. And I saw Murlidhar showing all those mannequins. I think we'll have to go back to the mannequins to teach our undergraduates to what the delivery thing should be. Now, the second stage of labor to describe the event that takes place between full dilatation of the cervix and time of delivery, up to the birth of the singleton baby or the last baby in a multiple pregnancy, whatever. So the second stage of labor, the moment the second stage reaches, people think that, okay, in 15 minutes it's not delivered, go ahead and do a cesarean section. So at the start of the second stage, the fetal presenting part may or may not be fully engaged, meaning that the widest diameter has passed through the pelvic brim. And the woman may or may not have the urge to push. So in that situation, you cannot expect, just because the cervix is fully dilated, the baby to come out in 10 minutes. So the evaluation of second stage is important, the assessment of descent, the duration of labor, and the amount of oxytocin you are giving. It's in terms of when you are giving in milli-units, how much you are giving is not 1 unit in a drip and 2 units in a drip, as a lot of people believe in, but it should be in number of milli-units that you are going to give to the patient, which will bring about the proper contraction. So the protracted descent that occurs in time of labor, where the dilatation and descent is taking place, with the nulliparous, multiparous will differ. And the arrest of descent when it takes place, again, you will find that the time will take place needed for that dilatation and descent to take place. So the arrest of descent when it occurs, you have the option of doing a cesarean or operative vaginal delivery, vacuum, or a forceps delivery. And I mentioned about the RCOG and ACOG recommendations, and I'll come to that later on when we talk about the difference between the one-tooth and the forceps delivery that is happening. The increase in infant mortality when the second stage exceeded 150 minutes. You're talking about so much time. If the fetus is perfectly normal, there is no need to rush to do a delivery just because the second stage is getting prolonged. And especially with epidural anesthesia, when the second stage is definitely going to be prolonged. So the progress is being made. The duration of second stage alone does not mandate intervention by operative delivery. Because if the head is not completely down, there is no question of doing a high forceps. You have a problem using the other instrumental deliveries, and then the option is only cesarean and nothing else. The childbirth and pelvic floor injuries. What is the price of a prolonged second stage of perineal health and disease that you have to look for? And therefore, that when you say a cutoff limit is 150 minutes, beyond which if you look at the lacerations which occur, avulsion of puborectalis, which you 4D ultrasound and MRI, we will see that how the lacerations can cause severe damage to the perineum. So in the labor, the shortest and the most dangerous journey of a human being is that goes through the lower strata of pelvis. So second stage of arrest will have cesarean section, forceps and vacuum, and now the option of Odon device, which has come in. Now, it is important to accept that both the instrumentally assisted deliveries and cesarean sections play an important and complementary role in modern obstetric practice. It's not that every patient has to be delivered vaginally with instrumentation or whatever, dead or alive, or do a cesarean section at the other end completely. You have to understand the subject when you want to do really what needs to be done. So the more things change, the more they remain the same as far as the overall situation is concerned. And in a clinical situation, the obstetrician is faced with the question, is the instrumentation feasible? Should you be doing instrumentation or you should be doing, whether you are doing a trial of forceps in theater or whatever it is. And if the instrumentation is the best option available, which instrument would be suited for the situation that you are facing? And a valid option when problems arise during second stage of labor or alternative for C-section when the situation is so-called failure to progress in the lower pelvic state occurred is the obstetric forceps. And when you look at the forceps should be considered as an alternative to C-section when the situation is so-called failure to progress in the lower pelvic state. Now, even though cesarean sections is now very easy, you find that antibiotics are available, whatever it is, but even in spite of that, even though so many years things have changed, this fact is often forgotten today in favor of fetal health, that maternal mortality is several times that of a vaginal delivery once you decide to do a cesarean section. Now, a question of mid-cavity forceps operation with rotation of 45 degrees or less classified by the scheme proposed in 2006. Now, in 1992, the RCOG came up with a recommendation that forceps should be avoided and 1-2 should be used. So everybody shifted to using 1-2. A lot of people kept their forceps in the cupboard and said that it's not needed at all. And started using 1-2s. By year 2000, the second recommendation came that after evaluating for 8 years, the RCOG and ACOG both say that there is place for forceps and 1-2s is not the best solution to delivering the patient vagina. By 2008, RCOG and ACOG said that you try and avoid 1-2s because of the complications associated with the baby, the chignon, the eye complications and so on, and forceps, if done properly, should be used instead of 1-2s. Now imagine from 1992 to 2008, 2009, we are talking about a period of 16 years where all residents who went under our guidance, I continued to use the forceps, so that my residents did learn, and I'm sure PK also did the same thing in Mumbai. But so many other institutions didn't do it. And after 2009, if you tell the obstetrician that fine, now tomorrow onward you use forceps and not 1-2, They don't even know how to assemble the forceps. Forget about applying the forceps, delivering the baby with the forceps, and so on. So these difficulties will arise, and the main crux of the problem is that you must understand what forceps is. When you apply a forceps, there is a compression force, traction force, and a rotational force. And at no given time, there are only two forces should be acting at a given time, which means the forces when it is applied, the compression force is standard. It is not going to change. When you are pulling, you don't rotate. When you are rotating, you don't pull, which means that you do one thing at a time along with the compression force that you are experiencing the baby. So the cardinal rule for forceps deliveries is abandon the operation if it does not proceed smoothly. If you find that it's not working, leave aside. Don't use unnecessary force. You leave the force outside the forceps, you never have any complication. And evaluate the reason for difficulty and then allow further progress of labor, whatever you want to do, cesarean and otherwise. Now, forceps use is faster and more successful in achieving delivery than 1-2s at higher station. This may be of immense importance in acute fetal jeopardy. And I can tell you in 1983, when I came back from England and I started private practice, I was rushed in routine patient who was fully dilated. I was going there and they suddenly called me to say the fetal heart is down to 60. And when I went there and I saw that the head was not completely down, it was in mid cavity. And I said to the hospital labor ward nurse, give me a mid cavity forceps. And she said, mid cavity forceps? Ridiculous. Nobody uses mid cavity forceps there. I said, give me a mid cavity forceps because I need it. And I applied the mid cavity forceps, delivered that baby. Baby was fine. If I had waited for the anesthetist to come with a fetal heart down to 60, I would have lost that baby. So there is a place for every instrument, whichever instrument that you use, the right instrument at the right place to be used. And the forceps today is preferred by ECOG and RCOG recommendation guidelines, which are put forward in 2008. So every great advance in science has issued from a new audacity of imagination. And that imagination has come from this particular device, which came in and Odon assist. In 2012, the WHO asked FIGO to evaluate an sort of instrument, which was created by an Argentinian mechanic who said that he used to take out the cork from the wine bottles to use that bottle subsequently by putting a plastic bag inside and negative pressure and pull the cork out from the bottle. When he was watching his wife delivering in the hospital and everybody struggling there to get the baby out, he said, why not use this? A smaller space, bigger size coming out. Why not use something? And he designed an instrument, the concoction, which was like this. The central portion had a stick there with rubber in front, which was used by small children in guns and arrows, where you put on the board with 100 marks and 200 marks and 300 marks and a plastic bag. This was originally in 2012, which came in, it was literally 1 foot and 4 inches long. So I said to the entire team that if you take this in front of a patient to say, I'm using this to deliver your baby from below, patient will run away. And this has to be reduced. So we reduced the size to the size which you see there now. And the idea was to put that rubber on cap on the baby's head and put the bag around the baby's head. I will be showing a video how to do that. This has been further modified in the last 4 years, and where the trials are all complete in Europe. So this is the instrument now which is there. It's much shorter. There is a plastic bag. There is the same device as you saw, the central long tube with a rubber cap in front and 4 little flanges which are on the side to pass this plastic bag over the flange. So the first innovation in operative vaginal delivery since forceps centuries and vacuum extractor, it's very low cost, less traumatic, and applied by mid-level providers. Now, why do you say it's less traumatic? Because there is no compression force. There is no rotational force which is there. There is only a traction force which the bag, when you're pulling, you are applying it, and the rotation occurs on its own without any problem at all. So the safety, feasibility, and preliminary efficacy multi-country randomized trials have been done, inclusion in WHO guidelines for the labor and delivery, and inclusion in strategies developed by the foundations and the agencies that are there. To prevent maternal newborn complications with trauma, hemorrhage, infection, birth asphyxia, maternal and newborn complications of second stage of labor, and so on. So this assisted vaginal birth in the 21st century prolonged a complicated second stage labor requiring assisted vaginal birth or emergency C-section occurs in approximately 10 to 15%. And when the Odon device was used, which was the inflatable device for assisted vaginal, the efficacy, the successful assisted birth rate with Odon assist in clinical trials was up to 88.5%. which is huge when you are considering any instrumental delivery vis-a-vis the cesarean sections we are talking. Now, how does it work? Now, we are going on to the video now. What is happening? Yeah. The video is not getting on.
Just right click, sir. Right.
Can you see the slides at least?
Yes, sir.
Have you been able to see the slides?
Yes, sir. Yes, sir.
Yes, sir. We can see the slide.
Now let me get. I'll have
right click करो sir.
सेन डबल क्लिक करून बघा जरा.
तेच करतोय मी. ह्याच्यानंतर 1 मिनिटात चालू व्हायला पाहिजे. It's not starting the. Now it started. Good. Okay. Now this is the device which you put on the baby's head. The plastic which is put in, and the flanges go over the baby's head, and then the bag goes right up to the baby's neck. On the right hand side, there is a inflatable area which gives a marker which tells you that the inflation is complete. The sleeve is complete. Then you take the inner structure out, and then you use the back to just pull the baby's head. The baby's head rotates on its own, comes out. When you come up to the top, just release the air and come out, and then the baby can then be delivered very easily on its own. I wish I can show you the slide again, video, which will be, if it is possible, it will be good, so that you can understand while I don't talk. So sliding of the sleeves and the bag, you see that green mark. Once you inflate below the chin, the tube has a sleeve. It inflates. Then you take the central portion out and then use the bag to pull the baby's head. And the baby's head comes out. Then you release that sleeve. So the sleeve comes out and the bag is removed. And then you have the baby's head there, which you can go ahead and deliver. So the preclinical, clinical, and post-market evidence data which is there now, it has been bench state simulation studies have been done, founded by the Saving Lives at Birth by BJOG and AJOG, and then registration mark, which C mark has been obtained in Europe for September release, and the post-market trials with randomized clinical trials which have been done, feasibility in the low-income countries which have been utilized, and the clinical introductions of it. Now, there are numerous papers which have been already published on the Odon device, and it will soon be released by September to be used all over Europe and America. And I have suggested to the manufacturer that give us at least maybe 1,000 devices, and maybe 2 or 3 major centers in India. Foxy will do the trial as well and give our experience. And they have agreed in principle that they would do that from September to April. April, the government will anyway sanction it, but why not make our people use it as well? So that is something which is likely to happen. And I will then ask Foxy to maybe select a couple of centers where it can be done. So there are no device-related serious maternal adverse reactions. Well accepted and very popular among mothers, irrespective of whether they were administered epidural anesthesia or whatever, because it's a very tiny device. The successful delivery rate was as high as 88.5%. And the ease of use related by obstetricians is easy to use. And I mean, this is not something which you require a major expertise or whatever. And a situation where now you are trying to retrain people to do a forceps delivery who have never done a forceps before. And this is something which is a very simpler way of doing it. So the Odon Assist is a new and effective option that is very popular with women and obstetricians and has important potential benefits for babies. And it's not available on the market yet for MNHI. Are excited to potentially work with Foxy to prepare for implementation in India, including possible clinical trials and with FIGO joining in as well. So I hope that we are able to do something for Foxy after September, and maybe do a couple of university centers where there are large numbers to do the things. So the imagination is more important than knowledge. When you look at it, look at an Argentinian mechanic coming out with some imagination, which was important than knowledge. And if when Henry Ford was asked that how many extra horsepower vehicle can you make, he said, if I asked my customers what they wanted, they would have said a faster horse, because in the traffic in Mumbai, if you were to take a horse, you'll probably reach faster than going through a extra horsepower sports car, which can't even move in this traffic. So in 2012, when the World Health Assembly at the World WHO director, who was prior to my friend Tedros, the Chinese lady, Margaret Chan, she said that the Odon device developed by WHO and now undergoing clinical trials offers a low-cost, simplified way to deliver babies and protect mothers when labor is prolonged. It promises to transfer life-saving capacity to rural health posts, which almost never have the facilities and staff to perform a C-section. If approved, the Odon device would be the first simple new tool for assisted delivery since forceps and vacuum extractors were introduced centuries ago. And imagine now, it's been 12 years, still it has really come out with the final product, which will be released very soon. And Foxy, what did Foxy say? That may all midwives and physicians be prepared. Teaching of obstetrics ought to be geared towards adding skills and not limiting them. When you are talking about training people, you say that you don't do this, you don't do that, you only do cesarean section. I keep on always saying the time will come, there will be only 2 types of delivery. One, cesarean section, And the other one, because there was nobody there at the time of delivery, which is normally occurred, and there are no obstetricians and to tell them to go and do a cesarean section. So these are difficult situations and difficult times that we are. And I cannot persuade myself that women or their babies are truly well served when physicians are no longer taught the skills to safely assist all of those babies who can be vaginally born. And we need to make that effort. Thank you very much for the patient here.
Thank you very much, sir, for talking about this new device. And I would like to congratulate you and thank you also on behalf of Foxy and all Foxyian, because you could convince manufacturer to provide 1,000 or even more than that number. This device is for trial in India, because if we come up with data from India, it will be much easier for our Foxyian friends who are working in this obstetric field to digest it and to implement in their day-to-day practice. And thank you for joining this webcon and delivering this oration. Thank you very much. Comment from PK Shah, sir.
Excellent talk, CN. We are just waiting for the next year to come when we can use, because I still remember when I was the president of Foxy, we started hearing about Odon device and we were listening to it. At that time, we thought it is very clumsy to use such an instrument. But now that you have shown the demonstration, it appears to be something very simple. Even a non-medical person can use it for delivery in a patient who is in labor for a long time and there is a difficult delivery vaginally. The people who do not want to use instruments can deliver with Odon's device. Thank you for excellent presentation and a superb oration. Thank you very much, CN.
One comment for all of you. Somebody in the last meeting when I presented this asked me how much it's going to cost. I don't know what the cost is going to be, but the whole device, if I am as an Indian trying to work it out, innovation is something which we always do. They say that you buy the whole thing together and that is the whole package, sterile package which comes in and you open it. I would say that the central portion of everything is, there's nothing wrong with it. And you could use it again and again. It's a question of the bag which is outside, which has the pressure and sleeve which is there. If we are using so many things by keeping our instruments in the formalin boxes, in the laparoscopy boxes to sterilize them and use them again. And I'm sure some solution could be found out to reduce the cost as far as the countries where they can't afford it to maybe this, if this is say 5,000 rupees, I'm just guessing. So why, if you can work it out in 500 rupees, why not? And I mean, this is something which we'll have to look into once the system is in place, and then when they come out with it by September, October, to say that, well, okay, we are going to give you 1,500 devices. You do it in 3 different major institutions, 500 cases each, and see what your results are, which can be put for the IJGO journal, that 1,500 cases done in visa again, along with Forceps, 1-2s, and whatever comparison that can be done. But hope that we in India would get something at a reasonable price, which we can out for our patient. Thank you very much for giving me this opportunity, and PK for as a good friend for so many years to be there today to chairing the session for this
My
oration.
pleasure.
Thank you very much.
I'm at Geo Convention Center for a conference. So I'm speaking from my phone.
Very good. Thank you very much. Thank you.
So nice.
And I am attending this from Coimbatore.
Thank you very much. I think you can go ahead with the program now further.
Yeah.
Thank you, sir. Thank you very much for sparing time to deliver this excellent oration.
Thank you.
Thank you, sir. We are really enriched. And who other than you to talk on this topic? Thank you, PK Shah, sir. Thank you, MC Patel, sir. Thank you for gracing this occasion. And with this, we are completing the third session well within time. And I request the coordinator of the next session to take on. Thank you very much. Thank you, MC Patel, sir.
Thank you. Thank you, Pandit.
Thank you, sir. Thank you for giving the opportunity to coordinate such a nice webinar. All of us are very much benefited by this. Now we are going to start with the fourth session. That is the very important session for all. It is on surgical management of PPH. And everyone who is working in obstetrics should know about it. Our esteemed chairpersons are Dr. Shakuntala Kumar, Dr. Rajendra Singh Pardesi sir, and Dr. Anju Turior. Please, and our speakers are Dr. Sheila Mane madam, Dr. Ajit S. Nayar sir, and Dr. Pratibha Mittal madam. Please put the CV of Shakuntala Kumar ma'am. She's a secretary, IMA, Delhi, co-chairperson, PGD, MLC, scientific advisor, DGF North, past chairperson, Adolescent Health Committee, executive member of Adolescent Health Committee, AOGD, joint editor, and she has done lots of publications, and she's a speaker and faculty in more than 200 national and international CME. Over to Dr. Parth.
Thank you, madam. So it was really nice talk by all the previous speaker, and the oration was excellent, especially for the young gynecists who have left the art of vaginal delivery. So our next chairperson is Dr. Rajendra Singh Pardesi sir. Sir has presented a lot of papers in national and international journals. Sir has been awarded for the 7 times for the best paper in FOXI and AICOG conferences. Sir was faculty in many national and international conferences. And Sir was a chairperson of Food and Drug Committee, FOXI 2012 to 2014, and awarded as a Dr. Consortia-based committee award. Sir was VP of FOXI and VP of AMOGS, and now Sir is President of AMOGS. Sir, welcome you. Madam, would you like to invite our third chairperson, Dr. Anju Turian?
Dr. Anju Turian is from the Bihar State Coordinator for SSN and PP, President BOGS, Vice President AOG SPJ, Zonal Coordinator Family Welfare Committee, ex-Zonal Coordinator IAGE, ex-member of Breast Committee CIMP Committee, trainer of EMTC, life member of so many societies. She's taking active part in the international and national conferences, recipient of Corona Warrior Award and Gynecologist Award of Community. She's working with Rotary Club, and her field of interest are challenges in obstetrics and infertility, and she's promoting awareness for regarding cervical cancer, cancer breast, and their prevention. Welcome, ma'am. And now I request Dr. Shakuntala Kumar madam to introduce and invite our first speaker, Dr. Sheila Mane ma'am.
Thank you very much, Dr. Patel sir, and the whole team of Happy Learning Webinars to give me this opportunity. It is my privilege to introduce Dr. Sheila Mane to you. Can I have the slide, please? Dr. Sheila Mane madam is a very well-known faculty and very well-known figure in FOXI, and so in so many national and international webinars and seminars I have seen her. She has been past president of PSOG, has been member of several societies, past president Bangalore Menopausal Society, past president of ISOPAC Society Bangalore, vice president FOXI 2014. A very favorite person of mine, has conducted many academic programs for postgraduates and Foxians, served as national faculty and facilitator in adolescent health, known as the PPH lady of this country, and has raised many leaders and guides in PPH programs. She has had best committee awards in Safe Motherhood Committee, and has been the recipient of Best Teacher Award. Ma'am, I could go on and on and on in your praise, and I know you as a wonderful academician. So, madam, over to you for your deliberation. We would love to hear from you about the PPH and the various sutures. Over to you, madam.
Thank you. Thank you, Dr. Shakuntala, for those kind words, and I thank Dr. MC Patel and team for inviting me. And I'm seeing the deliberation this morning, and excellent oration by none other than our Dr. Purandare sir. And it was nice to hear about everything. And good afternoon, Dr. Pardesi, Dr. Sarveshwari, Nautiyal, Dr. Anju, Dr. Dolly Mehra, and everybody here. Okay, I see so many familiar names. Thank you, Dr. Shakuntala, once again. And without any delay, I will start my talk. It is coming as that they have disabled participant screen sharing. Can they make me a host?
Vasu, please do the needful.
The technical team. Technical team.
Vasu.
Can I?
Yes, ma'am.
No, still it is coming as same.
You can try them now.
Oh, yeah. Can you see my slide? Can you see the slides?
No, ma'am.
Not yet. Yes, it is going to get displayed. Wait.
I think Dr. Pratima has been made the host. So please check.
No. Sheila ma'am, I am also co-host.
Can you see the screen is not seen?
No, ma'am. Try once again, ma'am.
Now,
yeah.
Okay, we can see.
Presentation.
One slide we can see.
Yeah, I think I have to just adjust that. You can see it now, no? Yeah.
Sila, put on slide number 1. We are seeing slide number 6.
That how important is compression suture, and since its introduction by B. Lynch since 1994, it has really saved so many lives as well as so many uterus. Now, compression suture, there are many, like it is B. Lynch, Heyman's, Cho suture, cervicoischemic, transverse B. Lynch, sandwich technique, and Nausicaa compression sutures. Now, how should be the compression suture? It should be quick, effective, and safe. Okay. So, and others, there are so many other sutures also, like Periara uterine compression technique, Ball's uterine compression technique, then Kuhaba uterine compression, and Cormack MG stitch, which is by our own person. Now, coming to the B. Lynch technique, which was developed by Christopher B. Lynch. So, in B. Lynch, the laparotomy is necessary. Now, what happens in, if it is following cesarean, no problem. But if it is following a vaginal delivery, we have to take an incision like a hysterectomy on the lower segment cesarean. We have to exteriorize the uterus, and the suture exerts continuous vertical compression on the vascular system because the vessels come from the sides. And before placing the suture, we have to perform bimanual compression to see if bleeding stops. The assistant performs compression and manifests it with 2 hands while surgeon places the suture, because the uterus is so much atonic that the assistant will have to compress it. Suture material can be used is number 2 polyglycolic acid or number 2 chromic catgut may be used. Now, this is the, you saw in the diagram point A. So this is point A, which is 3 centimeters from the lateral wall as well as 3 centimeters from the lower flap. Then you come out at point B, which is again 3 centimeters above.
Ma'am, you are not audible.
So that is points. So the needle is come inside the uterine cavity now. Now you have to come up at point D, which is on the posterior wall. So the suture will run transversely across the posterior wall and it comes out at point D. Okay. And then again, the suture runs across the fundus. Now, dealing suture is for the atonic postpartum hemorrhage, as mainly we are compressing the upper segment. And you pierce at point E, which is again 3 centimeters above the upper flap, and then come out at point F. Now, in my experience, or sometimes even we can ligate the angles so that the bleeding will also be less. And after we have applied the suture, we have maintained the tension. You have to throw a knot and hold it and then close the uterine incision. And finally, then have to tighten it, might get invaginated or some problem can happen. And then the knot is tied anteriorly on the lower uterine segment. Then the modified B-Lynch, which was modified by Richard Heyman and Professor Arul Kumaran. Modified B-Lynch, there are 2 mediolateral independent vertical sutures on the right and left side. They can be placed without lower incision or after the hysterectomy incision has been closed. So here, when you are doing it after the uterine incision is closed, you will have to be very sure that there is nothing inside the uterine cavity. Same principle, keep the cavity compressed and 2 vertical apposition sutures are applied. And as I said, if it is following vaginal delivery, you don't have to even open the uterovesical fold of peritoneum. No need to push the bladder because we are putting it only for the upper segment. Here in this diagram, you can also see is it audible now? Sorry.
Yes.
Is it audible?
Yes, Sila, we can listen.
Yeah, sorry. And they can be placed without lower uterine incision. And in this diagram, you can also see 2 cervicoischemic sutures which are placed on the lower segment. And that these 2 cervicoischemic sutures where you are approximating the anterior and posterior wall, leaving the os open. And these are used mainly for the lower segment when there is a lower segment bleeding, particularly in the low-lying placenta or in placenta previa, or sometimes you have a lower segment postpartum hemorrhage. Just there is a oozing from the lower segment. So you can use this cervicoischemic sutures. So this is for the Heyman suture. This is demonstrated during cesarean. If you want to ligate the angles, we can ligate the angles also. So here first the angle is ligated and then the suture is placed. Now it is a surgeon's decision. Sometimes you may find during PPH that there is so much of oozing from everywhere. Okay, even though the uterus is contracted, you will find sometimes there is a oozing. In those cases, this Heyman suture is very helpful because it compresses the cavity. Okay, it is not totally atonic, but there is a
Sheila ma'am, we cannot hear you.
Ma'am is having a poor network.
come. Now here you can see that it is a I'm sharing again. Can you see the screen? My screen is visible?
Yes, ma'am.
So these are the toe sutures where there are square sutures, and it is not that you have to take it every time. Here I am showing you two toe sutures on the upper segment. So it depends from where is the bleeding. Now in lower segment, sometimes if the lower segment is not that wide, you may find it difficult. So you can take cervical ischemic suture. Okay, so that is the toe suture, but for this you will need a 10 centimeter long needle, because as it is the uterine myometrium is thicker in the upper segment. So, and you will have to needle the thread on that. Okay, so that is toe suture. So multiple square sutures occluding the uterine cavity. So the lochia can get treated and chances are there. It may be useful in placenta previa. Suppose if you have a placenta which was just near the womb, the upper flap, even you can put there also. Now the ischemic horizontal sutures below the lower uterine segment on sides. Then transverse B-linge. This was again introduced in 1997 by B-linge to compress the uterine vessels. And here it is a transverse suture which compresses the lower segment transversely, while an assistant checks the vagina to ensure that the bleeding is controlled. So you are still inside the cavity. You come out behind. Now I remove the anterior wall of the uterus to see the sutures inside. The cervical suture 1 centimeter wide of tissue on the other side of the uterus, plus behind the uterine lining, and the puncture the posterior wall of the uterus 3 centimeters close and safe. Then puncture the posterior wall of the uterus again 3 centimeters above the incision and exit behind the uterine. And then you tie it anteriorly. So we have occluded both the ascending as well as the descending branch. And it is very helpful in placenta previa. And then you close the cavity. So this is particularly for the lower segment. Then you have uterine sandwich technique, where along with B-linge, you can also use the tamponade, balloon tamponade. So here it is more easy with the B-linge as the cavity is not compressed. And it is useful in combination with other hemostatic mechanism. So they found that it further decreases the bleeding after a compression suture is applied. Here you will have to inflate it only 100 ml. Okay, insert the balloon, only inflate it with 100 ml, and then close the uterine incision, taking care not to burst the balloon. And then you put the B-linge suture, or if it is already been put up, then you tied it off, and then inflate the balloon, like you will have to push the fluid from below and check for any further bleeding. These are the Nausicaa sutures. Now here, again, you have a 70 millimeter in length a needle, 3/8 curved needle, and begin by needle fixing from the uterine serous lateral to the bleeding point. inside the uterine cavity go transverse to cover the complete bleeding area. So the sutures penetrated the full thickness of the myometrium without stitching the anterior and posterior walls together. The final results are shown in a sutured uterus in which a pattern resembling the body of fictitious giant worm ovum in the Japanese blockbuster is known as that. So, or it looks like Nausicaa of the valley of the that can be seen. So that is why it is called as Nausicaa. Now the people, obstetricians from Taiwan have a very large experience. They are the one who have come out. I had an opportunity to meet them in Thailand. So this is again, even we can go up to the lower segment also, or if there is a bleeding from the upper segment as well as the lower segment, particularly in adherent placenta. Now, all of us, we know that in cases of PAS, okay, there could be anteriorly previa excessive bleeding occurring from the implantation site after removal of the placenta. So in that case, again, we can just catch the bleeding points, or we can take again these type of sutures even there also, like the Nausicaa sutures, you know, you can go through and through if it is on the anterior wall and try to control the bleeding from the implantation site after removal of the placenta. Now, these are the again variations like Periara's uterine compression suture, series of transverse and longitudinal sutures. So you are in B-Lynch, you are taking, but here you are just taking the bites on the wall of the myometrium or the uterus and then tightening it. So, but you have to take care to see that it is just below that anastomosis of the between the ovarian and the uterine, and below that it's been put. And you know, it looks very simple in the diagram, but it will be very difficult because we know the vessels run across there. So there are 2-3 rows of these rows are placed, each directing just a minute. To completely envelop and compress the uterus, similar to the way one might truss a stuffed roast. So when the transverse sutures are brought through the broad ligament, care should be taken to avoid damaging blood vessels, ureters, and fallopian tubes. The longitudinal sutures begin and end at the last transverse suture nearest the cervix and do not enter the cavity. The myometrium should be manually compressed prior to tying down the sutures to facilitate maximal compression. This is Bhal's uterine compression. These are all the modifications of B-Lynch. Okay. Again, it is taken separately, one on this side and one on that side. So the entail 2 sutures instead of 1 with the knots tied in the anterior inferior without any difference in the compression effects compared to the original B-Lynch sutures. This is again Uhaba's uterine compression sutures. Sometimes, you know, the 1 and 2 which you are seeing, you may have to put only 1 or 2. You find that the area where the placenta was attached is so thinned out and that keeps on bleeding. So we can just take a suture there, like through and through you can go, or sometimes you find here. So you can take these types of, these are the compression sutures. And Cormack MG stitch, we know that is again invention of Dr. Mahesh Gupta. It compresses the myometrium and occludes the uterine artery, thereby reducing the uterine blood flow and causing hemostatic compression. So I thank everybody.
Hello.
Ma'am, we are not audible.
नहीं चल गया बस चल रहा है पर रख दे अगर जूम खोल के रख दे अगर वो मेरी जो वो है ना मेरी उस पे उसको मैं ऑनलाइन कर दूं वैसे जरूरत नहीं पड़ेगी मैं
Thank you, ma'am. Thank you for the excellent talk. And I request chairpersons to please comment something on the talk.
It was really an excellent talk by Dr. Sheila Mane. Sheila Mane is really known as PPH lady. She has tremendous work in PPH. As PPH is really still a major cause of maternal mortality rate. And she has explained very nicely the billion stitch. Single steps she has explained very nicely, comparing to even other stitch methods also. Thank you, Dr. Sheila Mane.
Dr. Sheila, excellent talk as usual. And I know you have a lot of experience in PPH. You have your own checklist and PPH tray and so many things with your name. I have also experience of many B-lynch sutures techniques, but we should always first of all, we should always try to identify whether this stitch is useful in this patient or not. It is not something like in all cases we should go and we should apply this stitch. I think this is a time of on needle suture material. So most of the places what I have observed is a straight needle with a big good length is usually missing. So in sometimes it is very useful. So it is good to keep one straight needle with a good length in our OT. And I think particularly in lower uterine segment bleeding, P-lynch is not that much useful.
Not useful.
Particularly in lower segment, if you apply 1 or 2 jaw suture, sometimes with jaw suture, you can...
Cervico-ischemic also we can take. If it is the distance between the cervix and the lower flap is not much, we can take cervico-ischemic also. And for lower segment, I showed that B-lynch transfers for placenta previa. I have used it and that is also very useful. Okay.
And one more thing is I would like to suggest that once you apply B-lynch stitch and PPH is controlled, it does not mean everything is over.
Yes.
Post-operative as a follow-up is also very, very important. And till sometimes up to 3 months, we should go for the follow-up.
Yeah, actually, there is I forgot his name, a doctor from Pondicherry. He has a very good collection of cases where following B-lynch, he has almost 22 cases who have conceived. Okay. I mean, it does not affect fertility also. But anyway, when the patient is bleeding, our main motto is to save the mother and save the uterus at that moment. But the fertility is also, not affected to that extent, unless sometimes, we have seen in few cases, if it is put unequally, gangrene happening and all that, maybe in those cases it was too tight. Okay. So, but in our experience, we have really found that it is very effective.
It is really very effective, very useful, very effective, very simple. We can perform it within 3 minutes and immediate effect is there. Excellent. Really, it's a very useful and one more armamentarium in our hand. But at the same time, we should always keep in mind about the necrosis or pyometra or other complications. And it is not like, so usually what happens once PPH is controlled, patient is discharged, after that we forgot. So it should not be that in particularly.
I think golden hour is not the first one. The 4th stage is also a golden hour. Again, we have to monitor the patient. Okay. So as I said regarding Hemans, my experience where the patient going in for pulmonary edema, she needed aortic wall replacement, and I had to do the cesarean for her and combined with cardiac surgery. So I just did a cesarean, clamped the ankles, ligated the ankles, packed the uterus, because I knew that cardiac surgeons are going to hyperenize the patient, and I knew she will bleed once I come back. After 4 hours, when I come back, she was oozing from everywhere because heparin was given for cardiac surgery. So I used Hemans, I used cervicoischemic, I ligated the uterines, I could save the uterus.
And in original B-lynch, stay suture at fundus is not described. Yeah. But sometimes once uterus is retracted and there can be a loop of suture material where intestine can be entrapped or so sometimes stay suture is again debatable.
Some people prefer to take a stay at the fundus so that it doesn't form a loop. Okay, theoretically, if we keep. Thank you very much for that excellent points, Dr. Alpesh, and excellent discussion. And Dr. MC Patel, sir, I wish you good luck. Okay, those who are watching, all of us have observed sir's work. I think some people, they work so much, but many of us will not know. And really at the grassroots level, okay? And so much of empathy for the human being and the hard work, not only for obstetrics and gynecology. I think you know how sir works. So I wish him good luck, and looking forward to see you as a president of Foxy, sir. Thank you.
Sheila, for excellent talk, and thank you for kind words also.
Over to Dr. Parth.
Yes, madam. And now let us proceed for further. I would like to invite Dr. Ajay Pardesi sir to invite our next speaker, Dr. Ajit Nair sir. Ajay sir.
Can I share my slide?
So, Parth, you are muted.
Yes. So, welcome everybody. I would like to invite Dr. Ajit Nair sir for the next talk on operative tricks and techniques. He is president of Kerala chapter of RCOG, fellow representative ICC RCOG South Zone, additional professor, Government Medical College, Thiruvananthapuram, Kerala, past president of KFOG, past president of Kannakol ONG Society, past vice president and joint secretary of KFOG, past chairperson of research committee of KFOG, MRCOG examiner. I think he is the right person to deliberate this talk. So over to Dr. Ajit.
Thank you, sir. Can I share my slide?
Yes,
Is it
sir.
visible now? I think it's visible now. Is it visible? Good afternoon. Respected chairpersons, seniors. At the outset, I would like to thank Patel sir and the whole team at PIRSA everybody for giving me this opportunity. The topic that is given to me is placenta accreta spectrum, the surgical management. What is placenta accreta spectrum? It is a new name suggested by FIGO in 2018, which includes accreta, ingrata, and perpetua. The placenta trophoblast invade deeper than normal, that is into the myometrium. When the placenta implants at an area of defective destabilization caused by pre-existing damage to the endometrial-myometrial interface, the placenta accreta spectrum occur. The most common reason is the previous cesarean section and the combination with the placenta previa. The classification is grade 1 is accreta, grade 2 is ingrata, grade 3 is when it perforates. 3A is limited to the uterine serosa, 3B is urinary bladder invasion, 3C is invasion of other pelvic organs, mostly the parametrium, the broad ligaments. The most important thing in the management of placenta accreta spectrum is the early diagnosis. Patients with the low-lying placenta and a previous uterine surgery should have a thorough sonographic evaluation at the time of anomaly scan, that is 18 to 24 weeks. And we have to see that is the sonolucent layer between the placenta and the uterine wall is maintained. Are there any lacunae inside the placental substance with the turbulent flow? Are the blood vessels bridging are there any blood vessel bridging between the uterus and the placenta and the bladder? What about the retroplacental myometrial thickness? Is it thin? Is there a bulge of placenta into the bladder? So the ultrasound is very diagnostic of accreta spectrum. You don't need to do a MRA. The indication for doing MRA is evaluation of a possible posterior placenta accreta spectrum. And for surgical planning, especially to assess the depth of myometrial invasion or the parametrial involvement. Otherwise, the ultrasound is equally good to diagnose PAS. Often, there are cases where ultrasound has done a correct diagnosis of PAS and MRI said that there is no PAS and actually it was a PAS. So ultrasound may be more important in diagnosis of PAS. Nowadays, we have changed the scanning from the 18 to 24 weeks to the first trimester, early first trimester. If you do a scanning in a case of previous cesarean section before 9 weeks, and if it is in the gestational sac in the lower pole, lower anterior segment of the uterus, particularly in the niche of the prior cesarean scar, think of this possibility, and you have to consider option of termination of pregnancy. At 11 to 14 weeks scan, all other features of ultrasound features of PAS may be present, so you can plan it early. Even other cases also, all previous cesarean section, there should be a scanning at around 34 weeks of case, 34 weeks of pregnancy, a dedicated scan to look for the placenta. So we can avoid the unexpected PAS in theater. Coming to the management proper, counsel about the diagnosis and the potential sequelae like hemorrhage, need for massive blood transfusion, may end up in a cesarean hysterectomy, need for intensive care admission postoperatively, and injury to the urinary tract, especially the urinary bladder, the ureter. And we have to plan a delivery in a facility with adequate facilities and sufficient expertise. In Western countries, they say should be in a tertiary care center, may not be practical in our setup, but at least there should be a facility with adequate facilities and sufficient expertise. Usually, we plan the elective cesarean section between 34 to 37 weeks. But if there is a persistent bleeding and all, we have to consider doing surgery before 34 weeks. In such cases, consider giving antenatal corticosteroids. Even in the antenatal period itself, correction of anemia is very important. Try to make the hemoglobin more than 11 grams. Arrange sufficient blood and blood products. And there should be informed consent, discussion of intraoperative complications, and the interventions needed should be there in the consent. When you prepare for the delivery, there should be a multidisciplinary team of involvement, involving the urologist, vascular surgeon, blood bank, interventional radiologist, anesthesiologist, neonatologist, critical care team. But unfortunately, we may not get all these things. So at least an experienced obstetrician, the anesthesiologist, and a critical care team. And we need to inform the urologist that if we require your assistance, please come. So at least a urologist should be informed. 2 large IV cannula should be there. Invasive arterial monitoring is always recommended. Consider ureteral stenting, especially in percreta cases. Anesthesia, previously the concept was always go for a GA. Now, regional is also suggested. So again, it should be the discretion of the anesthetist. Thromboembolism prophylaxis is recommended. Tranexamic acid definitely reduces the blood loss. And we need to plan the surgery. What exactly we are going to do? Are we going for a cesarean hysterectomy or are we going for a conservative management? How to reduce the bleeding in the surgery? The primary problem in surgery for PAS is the torrential bleeding while attempting to separate morbidly adherent placenta and when we do the surgery, the hysterectomy. This can be reduced by controlling the blood supply to the placenta after the delivery of the baby. So what we do? One recommendation, especially that is coming from the Western world, is inserting balloons in the common iliac arteries or aorta and inflating it after delivery of the baby. May not be possible in all our setup. Another new option now we routinely use is using a clamp to temporarily clamp the aorta or common iliac arteries. Previously, we used to do the internal iliac artery ligation. But the issue with internal iliac artery ligation is, especially the blood supply to the bladder base, from where the torrential bleeding occurs, is actually coming from the anterior abdominal wall. The blood supply to the anterior abdominal wall is not from the internal iliac. Actually, it is coming from the inferior epigastric, which is actually a branch of external iliac. So, actually, we need to block the common iliac or the aorta, not the internal iliac. That may not help in placenta accreta spectrum cases. So, this is the Phylis aorta or common iliac artery clamp, which we usually use for all cases of PAS. It is a traumatic clamp, a simple straight instrument, looks like a Alice Forceps, but with blunt tips. Inside of the blood is smooth, and even on maximum closure, there's a 2 millimeter gap, which prevents the crush injury to the vessel wall. It is applied after lifting the common iliac arteries or aorta with a Babcock's forceps. So we don't have to open the peritoneum or anything. Just lift the Babcock's the arteries with the Babcock's forceps and apply the clamp. It is very easy to apply, and even we don't need much expertise in applying the common iliac artery clamp or aorta clamp. Coming to the surgical steps, the preferred incision on the abdomen is always a vertical midline. And when you put the incision, expect adhesions. And we have to remove the bladder, dome of the bladder may be at a higher level. So we have to keep that in mind when you put the incision. Sometimes the incision has to be extended above the level of the umbilicus. Prior knowledge of the location of the placenta helps to avoid incision on the placental site. So some people even recommend an intrapart ultrasound. At least we should have some idea about the placental location. Incision on the uterus, usually we put a vertical incision on the upper part, upper segment, or you can put a transverse incision, and can be even on the fundus a transverse incision if the patient is for a hysterectomy. After delivering the baby and clamping the cord, the first thing we do is you take the uterus out, exteriorized, bowel is packed, and avoid prophylactic osteotomy. We don't want the placenta to separate. Then we apply the aorta or common iliac artery clamp. Nowadays, routinely we are applying the aorta on the aorta because it is quite easy and we need only one clamp. Previously, we used to use a common iliac artery on both sides, but the aorta clamp is quite easy to put. No dissection of the vessel is required. Just lift the vessel with the Babcock's and apply the clamp. Make sure that the tip of the clamp goes beyond the vessel. So completely it is occluded. But again, the vessel wall will not be crushed. And take a quick decision regarding the plan. Well, are we going to for a hysterectomy with the placenta in situ? If the morbid adhesion to the uterine wall is localized and not going through the myometrium, placenta can be removed from that area by sharp dissection, and bleeding can be solved by the local hemostatic sutures, which actually is described very well by Sheila Madam. Another option is the conservative surgery, which we will discuss later. Then coming to the obstetric hysterectomy, again, there is the next topic is obstetric hysterectomy, so I am not going into that details of that. Sequential clamps are put on the upper pedicles up to the uterine vessels. Then we have to open the UV fold. The moving the Foley's bulb will help to identify the upper border of the bladder. Open the UV fold and push down the bladder sharply below the level of the placenta. You don't have to do a completely down up to the vagina, because when you try to separate below the vagina, then the bleeding will occur. So push to the below the level of the placenta. So you can identify the lower level of the placenta by palpation with your fingers, by palpating the lower part of the uterus. Vessels on the bladder surface can be tied or coagulated. Clamp the uterine vessels and the parametrium, and then whether to go for a total hysterectomy or subtotal hysterectomy. The textbooks and all, the classical description is in placenta accreta, always go for a total hysterectomy. But practically, if you try to separate the bladder down, actually there will be a lot of bleeding. So the best thing is subtotal hysterectomy, but make sure that the complete placenta is removed. So go below the level of the placenta and do a subtotal hysterectomy. Once the uterus is removed, look for any local bleeders, check the integrity of the bladder, inspect the ureters. Now you can go for the unclamping the aorta clamp. After informing the anesthesiologist, noting the duration of the clamp applied, there are cases which we have taken up to 1.5 to 2 hours the clamp is put, and the patient, there is no bad effect on the patient. And then after remove the clamp, after unclamping, again you have to look for the bleeding. So if there is a bleeding, again sometimes you have to reapply the clamp. After that, when the clamp bleeding, everything is checked, then you can put an intraperitoneal drain, estimate the blood loss, and close the abdomen. So this is a percreta case which we have done. It's a subtotal hysterectomy actually. Only it was a percreta case. Post-operative care, again the ICU monitoring, antibiotics usually for 40 to 72 hours. Low molecular weight heparin is always recommended, along with other thromboembolic prophylaxis. The analgesics, antibiotics, again catheter, usually it is kept for about 48 hours. But if there is a cystotomy or something, you may need a prolonged catheterization. Then coming to the uterine conservation with the placenta resection. When there's a focal accreta, resect the part of the uterine wall with adjoining placenta and reconstruct the uterus. One procedure that is described is the triple procedure. So it actually involves perioperative localization of the upper edge of the placenta and putting a transverse incision above the level of that fetus is delivered. Uterine devascularization by temporary occlusive balloons in the anterior division of the internal iliac arteries, and then the myometrical excision of the affected area and repair the defect, especially where you want to preserve the fertility. And again, we have to remember that the local excision of the myometrium may be a less morbid procedure than the hysterectomy. So need not be always you have to go for this conservative management in patients with who wants a fertility preservation. Even other cases also we can consider going for a management conservative steering. Other options are leave the placenta in situ, especially if there is no bleeding, and wait for the autolysis or giving systemic methotrexate. But unfortunately, the evidence is against this because there are a lot of cases coming with the secondary hemorrhage, infection, and morbidity, mortality is quite high. So these things are not recommended now. Another point is sometimes if unexpected accreta occur on the table, what to do? If you open the abdomen and seeing that lot of vessels are there on the lower segment, and or sometimes the placenta is percreta. So what to do? If you are adequate surgical expertise, you can go on with the surgery as we discussed. Otherwise, even you have to consider closing the abdomen, sending the patient to a higher center. Otherwise, you can wait till a optimal surgical expertise arrives. And meanwhile, you have to alert the anesthesiologist so that he can put can arrange blood. And if diagnosed after opening the uterus again, many of the same principles can be applied, but consider stopping the bleeding immediately. Consider using aorta clamp. And if there is no bleeding, again, even such cases also after packing the uterus, you can consider transferring the patient. Otherwise, if the surgical expertise is available, go for the hysterectomy. So these are the things about the placenta accreta spectrums, the surgical management. Thank you.
So thank you very much. That was very elaborate and exhaustively covered. Just a comment that what Dr. Sheila Mane said beforehand, that when we are doing the cesarean and when we have to prevent PPH and then talking about the placenta accreta syndrome, if the lower segment is extremely vascular and when we are securing all the vessels and when we are suturing, so instead of giving vertical sutures, if we give horizontal sutures in the lower segment and vertical sutures on the upper part of the incision, then I have been able to secure and achieve hemostasis in majority of the cases. As far as placenta accreta syndrome is concerned, in some cases in 90s and in early 20s, a few cases have come as a surprise. Some of the cases we have been able to manage very well, but there are some cases where they bleed so extensively that sometimes it is very difficult to, even when we are systematically devascularizing, and ultimately we resorted to hysterectomy. So the word is that golden time is not to be lost. We have to take a decision for a subtotal hysterectomy if we are not able to achieve hemostasis. That is my take on the.
The most important thing is control of bleeding. Stop bleeding. So that is very important.
Correct.
Thank you, Dr. Ajit. He has explained very nicely, and it's very important topic. That's because placenta accreta spectrum, it increases if not detected in time and treated in time. It increases MMR also, and basically the detection is important, and because morbidity and mortality is very much high due to the bladder and bowel involvement, and in future also if you will not detect and the emergency, so we may face even later on also problems to the mother. Thank you so much.
Thank you. Actually, the cases are actually increasing, especially because of the rise in cesarean section rate. So there should be a dedicated scanning to look for the placenta accreta. Often the sonologist will not be knowing that it's a case of previous cesarean section. So we have to give information that it's a previous cesarean section, look into the scar, so that dedicated scanning is very important to detect it.
So would you ever agree for conservative management?
Yeah, few cases we have done this excision, local excision, but definitely it is a predominantly it is a hysterectomy only. Few cases.
Sir, have you used any time vasopressin for local excision?
No, sir.
I have tried it and it's very effective.
Yeah, should be.
Sir, any role of suction evacuation? Suction. That Paniker's method of controlling the PPH, even in cesarean.
When a case of suction actually is very useful for PPH, atonic PPH, but I doubt whether it will be useful for accreta spectrum.
No, in placenta accreta, I don't think it's going to help, sir. Because this is one case, or I mean, this is accreta, when usually the obstetrician get panicky. So at that time, we have to maintain a cool and then act accordingly.
Madam, you are with two devices. That's why your voice is echoing.
Yeah, I'll stop one.
So, Monica Madam, should we proceed for the next one?
Do you have, sir, any data of mortality in Kerala from accreta, placenta?
Actually, in the last 10 years, actually, we have about 18 cases of maternal death due to accreta spectrum. So even though we are doing all these things, still 18 cases of maternal death is due to accreta spectrum. Anyway,
because of not diagnosis, because you are also evaluating causes.
Yeah, most of the cases are not diagnosed actually. So that is the reason. And often in small hospitals.
Thank you, sir.
Thank you, sir. Thank you for the excellent talk. Now we proceed to the last part of our session, and I request Anju Torier Madam to introduce Pratima Mittal Madam, who is a speaker of the talk on obstetric hysterectomy, which is a very important and it should be done timely.
Thank you, Dr. Monica. On the outset, I would like to thank the organizers, especially Dr. MC Patel, for giving me this opportunity to share this platform with all the stalwarts. I also wish that he will be the president-elect. I bring greetings from Bhagalpur, that is the Andhra Pradesh, and all the best to all of you. Can I have the CV of Pratima ma'am, please? Without wasting any time, would go ahead. The CV.
Dr. Anju, you can be short, just one line that
Sure. Because
I
she's a
was
known
vice
personality.
president
She needs no.
with Dr. Patel.
Okay. Dr. Pratima Mittal, she's the professor and head of Department of Obs and Gynae in Amrita Hospital and Research Institute, Faridabad. She's got honorary FRCOG from Royal College of UK for exemplary work. She's been the vice president of FOGSI in 2018, president Association of Obs and Gynae of Delhi in 15-16. She is the formerly consultant and professor and HOD of Obs and Gynae VMMC and Safdarjung Hospital, New Delhi, and member technical resource person of MOHF. She received various
Thank you,
awards.
Dr. Anju. I think we are waste time. Please let's
Okay,
go ahead. I want to share the screen, dear.
Dr. Anju, Dr. Pratima is probably the person who has established the biggest HTU in India, one of the biggest.
Congrats, ma'am. Thank you for letting me know, sir.
Parth, can I share the screen?
We can say she is encyclopedia of high-risk pregnancy and critical.
Can I share the screen?
Vasu?
Yes, sir. Yes, sir. Pratima ma'am can share now.
Good evening, everybody. Till the time I share the screen, I just want to say that I have worked as a vice president with Dr. MC Patel, and he, as in the morning, Dr. Jayam also said that we were all vice president together, and he is just like a brother to me, and he is really, really a silent worker, but very diligent, very sincere, and very hardworking. So I request all of you to support him, and my support is obvious. Of course, it's very obvious. So, I just want to, wish him success, and want to see him as a president in the next session. Please, can I share the screen? I don't get the screen sharing option.
You can share.
But I'm not getting that option, dear, at the moment. You have to remove this now. You have to bring it to.
Parth, you have got madam's slides. Please share from your side.
Share. I will share. Can you see now?
Yes, ma'am. Yes, ma'am.
Okay. Okay. So I'll go ahead. I'll just make it full slide. Okay, so today I'm going to talk about obstetric hysterectomy, though it's a dreaded, surgery which everybody's scared of and don't want to do it. But saving life, as has been already highlighted, is the most important thing. And we have to save the life rather than saving the uterus if it needed. So it should be, of course, the last option, but it has to be resorted to in many cases just to save the life of the woman. What is obstetric hysterectomy? We all know obstetric hysterectomy is performed at the time of childbirth, vaginal or cesarean after delivery within 24 hours. It can be emergency. It can be planned, as in the case of PAS. It is technically more difficult. The complications are 4 times more, but it is life-saving situation. When you go to the history of obstetric hysterectomy, initially it was started, first hysterectomy was done in 1869, but in that the patient died. And in 1876, Poro did the one successful obstetric hysterectomy. Both mother and baby were survived. So it is called Poro's operation. What are the indications? We all know that now the spectrum of indication is changing. PAS has become the most important indication. And then, of course, atonic hemorrhage is always there. But with the use of, with various sutures, compression sutures, which Dr. Sheila has talked about, we are able to control many cases in which we are able to conserve the uterus. Of course, rupture uterus, sepsis, fibroids, traumatic hemorrhage, all come, and malignancy, all are indications for obstetric hysterectomy. Here, I would like to discuss two cases. One case is about the atonic PPH, and the second will be about PAS, for which I will talk a very little because my previous speaker has already talked a lot about PAS. So coming to this case, this is Gravida 3, Para 2, Live 2 with failure to progress in second stage, had LSCS, followed by atonic PPH. Brace sutures were put but didn't help. Patient had massive bleeding, so blood component called for and total hysterectomy was done. Here you see the decision taking, the timing, which is very, very critical. We have to see that we should not delay hysterectomy and just keep on waiting that bleeding will be controlled, and the patient goes into multiple organ failures. So it is important that we take a decision early rather than delaying it and leading to the MOD. And all conservative measures, of course, have been tried, but it should not be delayed to such an extent that patient cannot be revived with a good quality of life. Then again, when it is an emergency, what are the pre-op preparations? We have to resuscitate the patient, very important. ABC has to be seen, oxygen has to be administered, IV access with 2 wide bore cannulas, blood grouping and cross-matching, and crystalloids should be administered. Urethral catheter should be ensured, and counseling, which is very, very important, counsel the patient and the relatives and obtain a written consent. Very important that you must obtain a written consent, because later on we have to get into medical legal issues, and then we have to approach Dr. Patel that will help us out. So we have should not forget this important step. Inform the most important experienced obstetrician, because obstetric hysterectomy can lead to many complications. Other preparations are mobilization of the anesthetists, theater, blood bank team, availability of proper surgical instruments, give prophylactic antibiotics, ensure placement of intermittent compression stockings on patient to decrease the risk of DVT. Which procedure should be done? It has been already discussed, total or subtotal. If the cervix and paracarpus are not involved as a source of hemorrhage, subtotal hysterectomy should be adequate to achieve hemostasis, and safer and faster. Which is safer and faster. But if the lower segment and paracarpus are involved, definitely it should be a total hysterectomy. What are the advantages of subtotal hysterectomy? Less operation time, reduced hospitalization, reduced risk of bladder and urethral injury. But the disadvantage is potential risk of malignancy in the cervical stump. So it should be followed as for routine patient with the uterus for as regular cytology. Bleeding or discharge associated with the residual cervical stump can be seen some problem in many patients. Whether the other operative concerns, which anesthesia, general or regional, both are good enough, both are acceptable. Which position, supine or lithotomy, both are reasonable. Lithotomy position may be helpful in cases in which you are suspecting some traumatic PPH, because it will be cervical manipulation can be done in those. Then skin incision, I'll talk about it in my next slide. Which depends, what are the principles that will be adequate exposure. So for adequate exposure, it is definitely vertical midline incision extending from umbilicus to suprapubic region is important. But if already you have given an incision for cesarean section, then you can extend it on both sides by Maillard or Czerny's technique. Double clamping, very, very important. Double ligate the vascular clamp, because these patients are very prone to hemorrhage. Pedicles should not be kept very long to avoid slipping of the vessels. So pedicle should be just appropriate length, and the clamp should be supported and not manipulated. It is very important, because if you pull the clamps, if you do twist the clamps, this may strip the vesicles away from the adjacent tissue, which again opens the blood vessels, which are very, very difficult to clamp and suture without injury to the nearby structures, especially the ureter and the bladder. So clamp should not be manipulated too much, and it should be just supported. Exposure of pedicle is always facilitated by upward traction of the uterus, which kinks the uterine vessels so that bleeding will be decreased. So exteriorizing the uterus is important, and upward traction is important, which will help in reducing the bleeding. And for preventing urological complications, it is important to identify ureters, especially if the anatomy is distorted, and sharp dissection should be done if the bladder is adherent. What are the steps? we all know it's very simple. I'll show a short video on that. Elevate the uterus out of the abdomen. Bilateral round ligaments clamped, cut, and transfixed. Windows created in broad ligament and free ties pass through it and tied. Tubo-ovarian ligament clamped, cut, and medial to the ligature and transfixed. Peritoneal fold opened below the round ligament and uterine skeletonized, doubly clamped, cut, and transfixed, and uterosacral and McInrod's ligaments clamped, cut, and transfixed. Cervico-vaginal junction is identified and incised. Vaginal angles are secured and transfixed, and uterus is removed, and vagina is closed by interrupted suture. Coming to this small video, I'll just show you how it is being done. The first step, as I have said earlier, ligating the round ligament. So this we have taken. The round ligament is cut, transfixed, and ligated. A window is made between the tubo-ovarian ligaments, and there again a suture is passed through this. So they are circumferentially tied, as well as the clamp, cut, and transfixed on the uterine side, and we will cut the tubo-ovarian ligaments. Then anterior pouch of peritoneum, if it is already open, it's fine. If it is not open, then you open it and then push the bladder down and open the posterior pouch of peritoneum. So next is that you skeletonize the uterine arteries. Clamped, can you see the arteries? Then clamped, cut. See how the clamp is being put. It should be put at the right angle to the cervix, and so that it is able to take all the paravesical tissues, and the bladder is already pushed down. So it should be and doubly ligated. It is a vascular pedicle, so it should be doubly ligated. Now paracervical clamps are put. This is on the other side. And paracervical clamps are put, and the pouch of Douglas is opened. Paracervical ligaments are cut, and identify the lower end of the cervix. When there is difficulties, I will talk about it later. Identify the lower end of the cervix, open the vagina and clamp and remove the uterus, and just tie the ends of the vagina with interrupted sutures. And before that, you may have to ligate, you should be ligating the uterosacral ligaments posteriorly. So you can see ligating the ligaments posteriorly when you're incising the posterior vagina, and vagina is closed by interrupted sutures. So what can be the challenges which you can face in such cases? Can you see the slides now? So what can be the challenges? There can be uterus which is bulky, and it is difficult to manipulate such uterus. So it is important how to deal with it. Extra abdominal, you take out the uterus, extra peritonize the uterus, and then only you will be able to hold it. But it should not be manipulated too much, pelvic tissue. Other challenge can be pelvic tissue, which is adjacent to uterus, are very, very edematous and friable. How we will handle it, we'll talk about in my next slides. Uterine and ovarian vessels are markedly encharged and distended. Traction or twisting of the clamps or on vascular pedicles may strip the pedicles away from the adjacent tissue. So, and other challenges are that pedicles shrink in size as edema subsides after delivery. And if not transfixed, they may slip through and may lead to secondary hemorrhage. Ureters may be sanctioned, clamped or stitched because often heavy bleeding interferes with the proper exposure. Other thing is the identification of vaginal angles on the cervix to complete a total hysterectomy in laboring patient, because the cervix is fully dilated. You cannot identify the lower end of the cervixes. Other challenges which we face is trauma of extensive uterine rupture gives rise to gross distortion of the anatomy and edema of the uterus. So you are not able to really identify the uterus, ureters, and normal anatomical structures. Placenta previa per accreta may extend into the bladder and other pelvic organs, giving rise to more, adherent placentas and more bleeding and visualization, making it more difficult. Scarring from the previous section, cesarean section, obliterates the uterocycle space and makes the separation of the bladder from the uterus difficult and injury prone. So what have we learned when we were doing the hysterectomy? Most importantly is to double suture of vascular pedicles, which I have already talked. First, circumferential tie, followed by transfixation sutures should be taken. Transfixing suture alone will improve only hemostatic control, but when edema subsides, they can result in the hematoma formation. So it is very, very, very important that you do use not alone transfixing sutures, but with circumference proximal ties. Another point is the bladder dissection. Avoid blunt dissection of the bladder. The bladder wall becomes edematous and friable during labor and may be injured by blunt dissection. So what you should be doing, that if you have to do a blunt dissection, please on a Kelly's clamp, you can tie a small rolled gauze and push it on the localized portion only with a focused movement. It should not be grossly, with bluntly you're putting the whole bladder down. And otherwise, better is to stick to the meticulous sharp dissection by the Metzman scissor with the cup turns towards the uterus, away from the bladder, for dense adhesions between the bladder and the lower uterine segment. And the other important thing is traction and counter traction. Pull the bladder on one side, uterus on the other side, and identify the field. You will get some field if there is it is not deeply invading. And inadvertently, if you open the bladder, so don't worry, you will be able to stitch it. So it is better to identify rather than just keep on struggling with the adhesions. If you do make an incision into the bladder, just close it. Just don't be scared. Which other method is we were saying that identifying the lower uterine segment, the cervix, especially in the fully dilated cervix. In those cases, it is important to follow the lower uterine segment between the thumb and the forefinger. And if you are not able to do it, just put your finger, open the vagina, lower uterine segment, incise the lower uterine segment, use a finger to identify the lower end of the cervix from the cervical canal and identify the area where the clamp should be preferred. It is always better to do a total hysterectomy, especially in cases of cases which we have talked, where the bleeding is from the lower segment, and in cases of placenta previa. Other is the closing, vaginal angle sutures. The vagina is very, very friable. So how we should be handling it very gently. Vaginal angle sutures should be taken and supported, followed by interrupted sutures, or you should close the vaginal cuff early, or you can leave the cuff open, and to secure hemostasis, you can just take a continuous suture, non-locking suture, in order to allow drainage until spontaneous or pre-peritoneization occur. Ligation of uterine artery. Should it be done? Should it not be done? If your bleeding is controlled, you are able to skeletonize the uterine artery. It's very, very important. But if you are not able to control the hemorrhage, ligation of uterine artery at original or internal iliac ligation can be done if large hematomas, especially in the broad ligament and retroperitoneal space, distort the anatomic relations and defy the attempts at direct clamping and suturing. So it is important that in such cases where you are not, hemorrhage is not controlled, you can go for internal iliac ligation, artery ligation. And in drastic emergencies, of course, the aorta may be compressed, clamped for a time to stop bleeding while regaining a clear view, and then do the surgery further. Post-operative care is equally important. Monitor vitals, ensure parenteral antibiotics, ensure blood transfusion, institute thromboprophylaxis once hemostasis is secured, and when patient is stable, the sequence event should be reviewed and discussed with them. Very, very important that we talk to the patient what really happened, why this has been done, because it has got a lot of psychosocial impact on the patient when the cesarean hysterectomy has been done. Complications, of course, we have to be, ready to deal if any complication occurs. The steps which we have talked till now will definitely prevent complications, but we have to be ready to identify and deal with it. There can be complication due to excessive hemorrhage, massive blood transfusion leading to coagulopathy. All these things we have to keep in mind. There can be a visceral injury, there can be infection, vaginal cuff cellulitis, abdominal site infections or urinary tract infections. There can be delayed complications like thromboembolism, fistula formation, and psychosocial problems. And we should be anticipating these, and we should be, able to prevent them or treat them. Coming to a second case of PAS, I will not go into details because it has been already discussed by Dr. Ajit. But in this case, I'll just like to highlight one or two things. One is where to give incision, how to close the uterus. So Gravida 2 Para 1 with previous cesarean, diagnosed placenta accreta, came to with 34 weeks. She was taken to OT after arranging 4 PRBC, 4 FFP, and 4 PRP, massive transfusion protocol, and informing the urologist and vascular surgeons. The most senior obstetrician discussed with patient and relatives about the need for hysterectomy, and then informed consent was taken. Again and again, please see that consent is very, very important. Senior anesthetists were called and pediatrician were also called. Discussion and planning regarding various measures like placing of balloon catheter. If there are facilities and you can do it, you must do it. Ureter stenting, if you're expecting it is a placenta accreta, there can be problems. In those cases, you must do ureter stenting. Ensuring availability of ICU beds, availability of all these multi-specialty team, blood bank facility is a must. So this is a case where you can see the placenta accreta in the lower segment. Upper segment incision is given. Placenta is left in situ. The placenta will be, and the uterine incision will be closed. And to stop to prevent urological injuries, it is important. Again and again, I'm saying sharp dissection of the bladder in the midline to mobilize the bladder. Perioperative cystoscopy with ureteral stent placement and checking the integrity of the bladder, filling with methylene blue solution should be done in the high-risk cases, and all clamps should be placed medial to the uterine vessel. So this is very, very important. And another thing which we are talking about is the retrograde filling of the bladder. If you fill the bladder retrogradely, you will be able to see the adhesions between the bladder and the uterus more clearly, and the dissection will be much, much easier. So filling the bladder by 200 to 250 milliliter of saline will make your job much easier if you're suspecting a case of placenta accreta or accreta. In those cases, it will be easier to remove the adhesions if the bladder is partially filled. Another option is, with Dr. Ajit, of course, just named it, but I would just like to highlight it, is the retrograde hysterectomy. We have done 1 or 2 cases, and I find it very easy, and it is much more better to prevent injuries as well as to prevent hemorrhage. In these cases, of course, the initial steps are the same in the clamp, cut, and transfix round ligament and fundal structure. Incision in the posterior vaginal fornix is given, and the uterosacral ligaments are cut, and ligation of the uterine arteries is done. And from there, then bladder is partially filled, and clamp, cut, and transfix the paracervical ligament from the posterior, opening itself, and dissection of the tissue between the bladder. So you're coming from posterior to anterior, and dissection of the tissue between bladder and anterior vaginal wall is done under vision, and the anterior vaginal wall is cut. And so you can, mobilize the bladder from the uterus in a much better way. You'll see the next diagram. If here you can see, we are opened it posteriorly, clamping the uterine vessels. And from here, we are going, and from posterior to, we are going anteriorly rather than from anterior to posteriorly. So to sum up, I will just like to say that obstetric hysterectomy is a life-saving surgery. It is difficult, but should be quick and meticulous. All my residents, all postgraduates who are doing cesarean should be well-versed with the obstetric hysterectomy, simple obstetric hysterectomy. They must know by the time they call the senior person, they should be able to proceed. And total is, of course, always better than subtotal. And high-risk cases should be timely referred to a tertiary care center. Post-op care is equally important. Detailed and timed documentation, which is also important, including the preoperative events, indication, and therapeutic and surgical detail, is to be put into the writing. So with prudence, preparedness, we can definitely overcome pitfalls and problems. They are complicated cases, they are difficult cases, but we have to be prepared for everything, and we have to save the mother first rather than waiting for conservative management to work. Thank you.
Thank you, ma'am, for such an excellent deliberation. You've touched almost all the practical points, and it's very informative and very nicely. Such a good teacher you've been. You've taught us very well once again.
Thank you.
It's a very good revision of what we usually do.
Thank you.
And one question, regarding the twisting of clamps, we don't leave the clamps for a long time. As soon as it's required, we just cut up, remove the clamps.
Yes.
So torsion with the clamp doesn't.
Everybody is not as expert as you,
No,
so
ma'am. Sorry.
this is for everybody, in general, our postgraduates and our residents, they try to really hamper as in a normal abdominal hysterectomy.
Okay.
So that is why we just wanted to highlight, please, because if they just start tearing, then you have nothing. You cannot handle that hemorrhage.
Yes, ma'am.
So that was an excellent talk, Dr. Pratima madam. How come your spaces were so avascular? I mean, the uterus is so
I have not made it yet. They are always like this.
There must be a tuning in place, because when we are doing
you see, we had put those, we had put brace sutures, so that had helped the bleeding. Bleeding to control a little bit, but of course the field was definitely better. And of course, I always tell them to put a pressure on the aorta. We just ask them to compress the aorta when we are doing this hysterectomy.
It was a dream surgery performed. I mean, it is like absolutely just like textbook surgery, So
this video is borrowed from Achla. So I'll have to ask Achla. Thank you, Achla. Dr. Achla.
Excellent talk, Dr. Pratima. She has explained very nicely on all basics of obstetric hysterectomy, because obstetric hysterectomy is different in every case. It is different, and she has explained very nicely that there are so many problems in placenta previa percreta because adjacent organs are involved. So hysterectomy is difficult and different, and she has explained very nicely double sutures of vascular pedicles and transformation, because edematous tissues are there. Afterwards, they will be loose and bleed again. And important is she has stressed on bladder dissection. Very important. Thank you. Thank you so much. Thank you.
Dr. Pratima?
Yes.
Can I ask a question?
Kishore ji, zarur puchiye.
I just wanted to know that actually, the important thing is a decision. When we should not do the conservative thing and prolong it.
See, so that once I feel
number two, then when we put the clamps and you cut them, can we put all the clamps and then ligate later on, so that we get the more time?
Yes.
So, second question is mine, ma'am. Retrograde hysterectomy, which cases you select, to do the retrograde, because it's definitely a difficult thing to do than normal. Normally we are not practiced for doing retrograde hysterectomies.
I'll answer all your question. The timing is very important. Once you have tried, once the patient's blood pressure falls, then in those cases, once the vitals are being compromised and you have tried your, compression sutures and it is not improving. So in those cases, we will not waste much time.
Excellent. Yes.
The first, second thing is about the sutures. As you said, that depends on the surgeon. If the surgeon is confident enough, if you are confident about your clamps, that your clamps are not going to slip, and you are confident enough that you will be, doing it later on, so you can definitely do it after putting all the clamps, removing removing the uterus first and tying the clamp, definitely. And the third is retrograde cystectomy is much, much better in the cases where you are feeding the placenta accreta and
Yes.
accreta. In those cases, we have seen that the bladder, you can identify the real exact place where the bladder is adherent. So other things, if you are able to, from one side window, you are going from posterior to anterior. So sides by, you can be able to separate most of the bladder. Only the adherent portion will be able to identify. So in those cases, we prefer a retrograde hysterectomy. And when you do it, then it is not difficult. It is only thing is important is that you cut the uterosacrals first, you go from posterior to anterior. So you are ligating the uterine, and then you are, coming in front. And so you're opening the vagina from the posterior to anterior. And only portion which in those cases is left adherent is only the portion which is accreta. So you can really, really localize the adherent portion of the bladder to the uterus.
Thank you.
Excellent talk, Dr. Pratima Mittal, and very useful tips for all of us. And there is just one slide here. I just want to share, very happy to share with all of you that at present 3,500 delegates are watching this web conference, and they all are enjoying this scientific feast from all of you experts. And in this, again, I would like to say, in this time of webinars where 4 to 5 webinars in a day are there, so many webinars are there, and usually presence are 100 to 200 or 300 in the webinar nowadays. But here, because of this scientific program and all of you, all the faculties, experts across India, pan-India, we can have this good number of delegates watching watching the conference on Zoom. At the same time, there are many more who are on the YouTube, which we do not know how much are there. So we are expecting more than 4,000 are attending this conference. Thank you, all the faculties.
Thank you.
Thank you, sir.
Thank you. Thank you all the.
Yes, Monica madam, we can conclude.
Sure. We should thank all the faculty and the chairpersons for joining the session, for such an excellent session. And now we hand over the session to the next conveners, Dr. Monica Umarband, to conduct the next session. Thank you very much.
Thank you, Dr. Parth. Thank you, Dr. Parth and Dr. Monica. It was an excellent session indeed. At the onset, I would like to thank Dr. M.C. Patel sir and Alpesh sir, Dr. Dolly Mehra and Dr. Manjal for giving me an opportunity to coordinate this session. This is yet another important session, tips for vaginal surgeries. And the other coordinators, Dr. Rahul Wani sir, he will join in some time. Our chairpersons for today's session, Dr. Mitra Saxena madam, Dr. Sudhir Shah, and Dr. Shabana Sultan ma'am. Can we have the series, Vasu, please, for their introduction?
You're not audible.
You are mute. Monica, you are mute.
Yes. Dr. Mitra Saxena madam is the chairperson of the Practical Obstetric Committee of FOXY from 21 to 24. She is the convener and project director of Haryana OBGY Society, a senior consultant in private practice in Rewari, Haryana, and active in FOXY since last 20 years. She has been the past president and the patron of the Rewari OBGY Society, and she has many awards to her credit. We welcome you. We welcome you, ma'am. Yes, ma'am. Our next chairperson, Dr. Shabana madam, also has joined us today. She also is the president of the Bhopal Ob-Gyn Society and has published many papers in national and international journals. She is also a member of the esteemed team of PPH Bundle along with Sevagram. She is the past Joint Secretary of Bhopal, as Treasurer. She has had many posts in the Bhopal Ob-Gyn Society, as well as she is the executive member of MC-HR. I would request Mitra Madam to please chair the session and introduce our first speaker, Dr. Sarogi sir.
A very good evening to all the esteemed faculty, all the delegates from all over the country and abroad. I'm extremely grateful to Dr. Patel and the organizers, Dr. Alpesh, to think of us to be the chairperson. The double advantage is that, you are alert and you listen to the master teachers. It gives me immense pleasure to introduce our first speaker, Dr. Rajendra Sarogi. Can you please share his CV? Sir is a very, very well-known teacher, mentor, and emeritus professor of St. G.S. Medical College and KM Hospital. He was the ex-honorary and HOD of R.N. Cooper Hospital, senior consultant, and director of Sarogi Group of Hospitals. Friends, I feel very privileged that in my last meeting, Sir was my main speaker, and I got an excellent time to listen to his obstetric teaching and skills. And today, he is going to be telling us about nuances of NDVH. And at the ripe age of 72 years, I can say that Sir performs many, many more surgeries, including NDVH and difficult obstetric hysterectomies currently. So over to you, Sir. We are waiting to hear from you the important topic for today's tips and tricks for vaginal hysterectomy. Dr. Sarogi.
Good evening, everybody. My special thanks to our organizing chairperson, Dr. Patel, the conveners and co-conveners, respected chairpersons, respected coordinators, my senior colleague and junior colleagues. My talk today is on tips and tricks in vaginal hysterectomy. I have nothing against abdominal or laparoscopic hysterectomy, but I'll try and concentrate more on my vaginal hysterectomy.
There is information issue. 1 minute. Mission done.
Yeah.
Sir, you need to make it full screen.
Okay.
Yes,
Is
sir.
it all right?
Yes, sir. Yes, sir.
Thank you. We were listening to the obstetric part. Now we come to the gynec part, which is more important. I am going to talk about conversion and complications in vaginal hysterectomy and tips and tricks in vaginal hysterectomy. We are grateful to have had eminent teachers like Dr. B.N. Purandare, Dr. D.K. Tank, and Dr. Sirish Sheth, who popularized vaginal hysterectomy. We all know they are father of vaginal surgeries. Why a vaginal hysterectomy? If you look at 3 pictures, you will find abdominal hysterectomy is something where we make an incision, big one, in the wall. Vaginal is through the natural orifice, and laparoscopy is, again, we make so many holes in the wall. So vaginal hysterectomy is a scarless surgery. LAVH is a minimal scar, and TAH is scarred abdomen. Vaginal hysterectomy differentiates gynecologists from general surgeon. As you know, abdominal surgery in PHCs are being done by general surgeon. Why a vaginal hysterectomy? If you look at the 2 sets of slides, one is vaginal hysterectomy instruments, which I purchased almost 45 years back. They are still working. If you look on this side, you will find laparoscopic instruments, which are being still, every year the instruments keep changing, and every year you have to keep investing. Spinal anesthesia requires a needle, while this one requires general anesthesia equipments, which also keeps changing. If you look at this, nowadays we all know, we discussed in previous talk, that number of cesareans have increased. It is therefore conceivable that the surgeon of tomorrow will be confronted with the need to carry out hysterectomies in women with 1 or 2 cesareans. Women who had not delivered vaginally and have had LSCS are vaginally nulliparous and abdominally parous. Hence, every hysterectomy should be considered for vaginal approach unless there is a contraindication. Luckily, with passage of time, indications have increased and contraindications have decreased. And the fear for vaginal hysterectomy is also going down. Complications usually occur due to a casual or an overconfident approach, whether it is a vaginal surgery, laparoscopic surgery, or abdominal surgery. Patience and perseverance are more important than the surgical steps. Don't be in a hurry. Learn to respect the tissues, and tissues will respect you. Preoperative assessment, we all know fitness, counseling, and consent has to be there. Preoperative preparations are required, and antibiotic coverage is in a regular way. What is more important is when you decide about some hysterectomy, look at the volume. So sonography plays a major role as far as our tips and tricks of vaginal hysterectomies are concerned. You will come across a case when you refer the patient for sonography, they never mention about uterine volume. If you look at this slide, you will find uterine volume less than 100, 101 to 200, 201 to 400, 300 to 350, and 401 to 500. Why I have mentioned this is, if you look at the size of the uterus, the normal volume of the uterus is about less than 100. If it's 8-week size, it will be 101 to 200, and if it is 17 to 20-week, 4-week size, it will be 400 to 500. Why this is important? That possibility of vaginal hysterectomy, easy average gynec should be able to do if it's a normal size uterus. Interested gynecologist should be able to do it easily if it's less than 8-week size. Best performed by a gynecologist with expertise when it is 9 to 12-week size. May require debulking if it is 13 to 16-week size, and be scheduled as tentative or trial of vaginal hysterectomy if it's a bulky uterus, more than 17 to 24-week size. So sonography plays a major role. Always tell the sonologist to write volume as far as size of the uterus is concerned. Another thing about sonography is it differentiates between a fibroid and adenomyosis. Adenomyosis, we all know, is comparatively difficult to operate vaginally as compared to fibroid. If it's a fibroid, it helps in mapping of the fibroid by various dimensions, size, number, degenerative changes, etc. It gives you an idea about presence of adnexal masses, rules out malignancies. What's more important, spaces on both sides of the uterus is equally important. Any abnormal position of the kidney or back pressure changes in the ureter can be seen, and endometriosis, if present at various sites, can be located. Further on sonography, adhesions between uterus and the surrounding structures can be made out. Congenital anomalies of the uterus, for example, uterus diadelphys, biconjugate, etc., you will know. This is one of the most important thing, angle between lateral cervical surfaces and ascending uterine wall of the uterus. Smaller the angle, more difficult is the vaginal hysterectomy. I am talking about this angle. If you look at this angle, if it is more, it's easier to perform vaginal hysterectomy. If here you can see it is about 90 degrees or less than 90 degrees, it's difficult to perform a vaginal hysterectomy. What is more important when you do vaginal hysterectomy? The things which are important for you to understand is proper positioning of the patient. Many times we know that vaginal hysterectomy may require little slight head low position. In that case, patient moves up Your speculum touches the table and you are not comfortable. So proper positioning in the form of lithotomy, exaggerated lithotomy, proper exposure of the surgical site, proper illumination, comfort of surgeon and assistant, proper instrumentation, proper draping. Bladder and bowel of the patient as well as the surgeon should be empty, proper anesthesia, preferably regional, and blood pressure to be maintained on lower side of normal. All these should be kept in mind before starting with the surgery. What are the various contraindications to the vaginal route? If you are suspecting malignancy, please avoid it doing vaginally. Disease primarily in the adnexa, again avoid it. Inaccessible cervix, again avoid it. Excessive narrow vagina, avoid it. Uterine size is more than 12 to 16 weeks. Please don't do it if you are a beginner. And if history of past surgery like cervical amputation, Fothergill's repair, Sling repair, ventrifixation, VVF repair, and cystotomy, avoid doing a vaginal hysterectomy. However, in some cases, it may be difficult but possible. For example, disease primarily in the adnexa with minimal adnexal disease, restricted descent, virginity or nulliparity, broad ligament fibroid, and post-surgery, particularly cesarean section or myomectomy, etc. Not contraindicated are CIN, endometrial hyperplasia, benign ovarian cyst. If oophorectomy these days we have been doing routinely with vaginal hysterectomy, it's not a contraindication. What is more important, bulky uterus and most other past abdominopelvic surgeries are also not contraindications. Look at the mobility and the descent. If it is freely mobile and descent to the introitus, it's much easier to perform a vaginal hysterectomy. If there is adequate uterus-free space to maneuver and the instruments, it's good case for vaginal hysterectomy. Subpubic arch should be normal. Cervix is normal size and length. Fibroid should be accessible. Location, proper mapping should be done. And attitude should be trained and enthusiastic and experienced rather than untrained and preoccupied. Give me a reliable finding of EUA and I'll give you an unambiguous decision on the route of hysterectomy. This was mentioned by Dr. Shirish Sheth. So how do you decide about route of hysterectomy? Favorable finding under EUA, absence of any contraindication, mobility of the uterus in all planes, uterine descent, adequate free pelvic space around uterus, uterine size and volume is known to you, free vaginal mucosa around the side of both bladder and rectum, no puckering, normal cervical length of portio vaginalis. You should 100% go ahead with vaginal hysterectomy. What is more important, there is something like a traction test. If traction on the cervix with a valsalum is applied to the anterior and posterior lip separately, it leads to a finding of external loss remaining above the ischial spine without any descent. Under anesthesia or without anesthesia, it is not a suitable case for vaginal hysterectomy. Normally, we find that cervix is extending up to the level of ischial spine. When you pull it, it comes down. If it doesn't come down, that means she is not a good case for vaginal hysterectomy. Then there is dimple sign by Dr. Shirish Sheth. A retraction of the posterior vaginal wall of more than 1 centimeter diameter adjacent to the site of pouch of Douglas when the cervix is raised using a valsalum indicates ovarian endometriosis, and that has resulted in obliteration of the pouch of Douglas, making surgical access challenging for the surgeon and risky for the patient and thus contraindicated for vaginal hysterectomy. Cervicofundal sign or dimpling sign by Dr. Shirish Sheth, inability to visualize the cervix on introduction of a large speculum when you don't see a cervix at all. Along with pulling up of the posterior vaginal wall signifies uterine adhesion to the anti-abdominal wall, seen mostly in women who have previously undergone abdominal surgeries, particularly cesarean section. In these cases, uterine fundus is attached to the abdominal wall and it's going to be difficult. As we all know, there is trial of Forceps, trial of vaginal delivery. Similarly, there is trial of vaginal route. Like trial of labor, we can do a trial of vaginal hysterectomy, taking a consent for laparoscopic or abdominal surgery if required. Sometimes in cases with previous LSCS, opening of anterior pouch may be difficult. However, if the bladder is adherent, remember that it is always adherent to the central 3/5 portion and not in the lateral 1/5 portion. Mind you, this is applicable even in cases of laparoscopic surgery or even in cases of abdominal hysterectomy. The non-adherent portion of the bladder can be easily approached for separation through shades uterocervical broad ligament space as a surgical window. Familiarity with this space helps in easily finding out the vesicouterine fold of peritoneum and the anterior pouch. In some cases, uterus may be very bulky, hence difficult to deliver vaginally. In these conditions, we can do debulking. That means we cut off the portion of the uterus, do debulking. This may be done particularly if volume of the uterus is more than 300 ml. We can do coring. This is best suited for removal of a smoothly enlarged globular uterus, particularly in adenomyotic. This is very useful when vaginal canal and or suprapubic arch is narrow. With strong cervical traction, the outer myometrium beneath the uterine serosa is circumferentially incised. By this, an enlarged uterine fundus delivers with an elongated sausage-shaped mass. Hemisection or bivalving of the uterus cervix is held with the clamp at 3 o'clock and 9 o'clock position, and traction is applied using a knife. The cervix is incised anteriorly and then posteriorly. The incision is carried up to the uterine fundus, thus splitting the uterus in two halves. Mind you, any of these procedures have to be done after transfixing the uterine arteries, not before that. If they are fibroids, then you can go ahead with myomectomy. There can be wedge morcellation. It's a technique of choice for a grossly enlarged uterus when coring or hemisection fails. Conventional wedge morcellation proceeds through the midline of the uterus. It may be initiated by alternative wedging of the anterior and posterior cervical walls up to the isthmic region. Then there is morcellation. Removal in piecemeal may be viewed as a destructive mutilating procedure. It is not useful when the uterus is fixed to the PID due to PID or endometriosis. Then there is Pyro's technique, that is anterior morcellation. Then there is posterior fundal morcellation. Then there is Doyen's method of enucleation. I'm going to tell you the difference between vaginal hysterectomy and laparoscopic hysterectomy. I have nothing against laparoscopic surgeons, but there are basic differences between vaginal surgeons and the laparoscopic surgeons. God has given us 5 sensory organs: eyes to see, nose to smell, ears to hear, tongue to taste, and skin to touch. In laparoscopic surgery, the touch of skin is not there. We all know that vaginal surgery is a natural route, while laparoscopic surgery is an artificial route with multiple holes. After seeing this, I am getting the famous Bollywood dialogue from Chulbul Pandey: I'll make so many holes in your body that you will be confused with from where to breathe and from where to dash. This is done under regional anesthesia. This can be done under, it can't be done under regional, so you have to give GA with all possible tubes and gadgets inserted. Condition of the anesthetist. We always think about ourselves, we don't bother about the anesthetist. Look at the condition of the anesthetist. Is relaxed while in laparoscopic surgeon, under tension with eyes constantly on monitor and watching. Have you heard about boys trapped in flooded caves? Yeah, same feeling right now. Position of the patient is slight Trendelenburg position, while in laparoscopic surgery you will find steep head low. And this is what happens. The anesthetist is asking the surgeon, you want head low or Sirsasana position? We all know that vaginal surgery, even a first gynec poster gets a chance to do it. We all know that laparoscopic surgeon, even a postgraduate, doesn't get a chance to do it. They have to have a special training for laparoscopic surgeries. Hence, vaginal surgery has a short learning curve, while laparoscopic surgery has a long pelvic learning curve. The problem is not with the students, the problem is with the teachers, because teaching is also like that only. In today's history class, we'll learn about the iPhone 5. Vaginal surgery is a conventional surgery. It's a cheap surgery meant for masses, while laparoscopic surgery is unconventional, very expensive, meant for elite class. Because you require all these gadgets and instruments and harmonic scalpel. Look at this now. Do you want to go with deluxe colonoscopy using a tiny fiber optic camera, or the economy procedure using the hamster and GoPro helmets? Imagine various prolapse repairs like anterior colporrhaphy, posterior colpoperineuraphy, SUI repair can be performed vaginally, while laparoscopy, it can't be done. Nowadays, of course, we find laparoscopic surgeons doing it using foreign materials like this. And you will see the result shortly, because these meshes come out from different parts of the body. Vaginal surgery can be performed easily in high-risk cases. Difficult to perform, particularly with incisional hernia or previous abdominal surgeries. No preoperative preparation required. Here, preoperative preparation is required. You want bowel to be totally empty. Only 2 nurses are sufficient as assistant, while here many assistants are required. Many people are required behind the scene monitoring gases and other gadgets. The patient feels that I feel like I am watching an IPL match. It can be performed in rural areas, in camps where electricity is a problem. Time required is much less. Surgeon is comfortable sitting on a stool. In laparoscopy, no, if requires a modern theater, time required is much more. Neither surgeon nor assistants are comfortable. And this is what happens to the surgeon or the assistant who is constantly looking at the monitor. Complications are much less. We all know vaginal surgery has practically no complications, while laparoscopic surgeries have more of ureteric and bladder injuries. The problem is with the examiner also. Examiners are asking what are the causes of excessive bleeding during surgery. The student is telling hypervascular area, bleeding, deformity, tearing vessels. No, the examiner wants what? High plane of anesthesia, hypercarbia, high BP, cautery not working, etc. No gas is put, so no question of pain at the shoulder, abdomen, no air embolism. Overall patient satisfaction is much better. Here gas is put, pain in the shoulder and abdomen, risk of air embolism. Let's skip this. Technology has stopped him from thinking for himself. He is using the GPS to guide him to go to the bathroom also. Have you something suitable for my husband's endoscopy photo? Situation is that we are handing over all our cases to other branches. SUI, VVF, cystocele, we are handing over to neurosurgeon. Fibroid and hysterectomy to lab surgeons. RVF to proctosurgeons. Carcinoma to oncosurgeons. Infertility to IVF specialists. Menopause to IMS, and endocrine disorders to endocrinologists. So what is remaining with us is only deliveries, because MTP is being done by pharmacists. A good physician treats the disease, and a great physician treats the patient who has the disease, as mentioned by William Alsler. Let's accept the fact that vaginal route is always the preferred route. If you cannot access vaginally, then you can take help of laparoscopy, and if that is also not feasible, you would resort to abdominal surgery. Time has come to conduct learning courses and workshops all over India, just like laparoscopic surgery workshop, in order to remove fear and misconception about vaginal hysterectomy. Friends, forceps, vacuum, and now episiotomy are becoming extinct due to rising LSCS rates. Similarly, vaginal surgeries will also become extinct one day. Remember, no surgeon can be an efficient lap hysterectomist unless he or she is also efficient vaginal hysterectomist. The Society of Vaginal Surgeon of India, that is called as SOSI, is a very good initiative started by Dr. P.C. Mahapatra and Patnaik. First president of this society is our very own Dr. Shirishet. We want to conduct various workshops all over India to train our budding gynecologists. Thank you. Thanks a lot for giving me this wonderful opportunity.
Thank you so much, sir. It was a wonderful presentation in favor of vaginal surgeries. I would like Mitra madam and Shabana madam to have their comments. Thank you.
Sir, as always, it was such a nice, lucid talk, and where your tricks were very, very important. Some very, very important things like, emptying the bladder of the surgeon himself and to be seated and comfortable, and the mindset. Honest to goodness, I feel that most of the times we lose our capability only because we are not that enthusiastic and encouraged. But your talk was so beautiful, and I'm sure that all obstetricians who can do hysterectomy abdominal, vaginal is not tough at all. So I think it was your whole lecture was very interesting, and especially all the cartoons, and it kept all of us interested what's coming next. And honest to goodness, sir, it's my wish that sometimes when you're operating, I should come and watch you live in your OT.
Thanks a
So
lot.
thank you very much, sir. All the tips were really wonderful, and I think anybody can do it. We can start. Thank you, sir.
Thanks a lot.
Thank you, Dr. Sarogi. And I just want to add that I am the president of the Society of Vaginal Surgeons of Delhi.
Oh, very good. I'm of Maharashtra chapter.
Really, that is so. And my aim is also to propagate this the vaginal surgery, because most of the postgraduate opt for the laparoscopic learning. They're not much
I
interested
do
in
agree with you.
vaginal thing.
But now what has happened in Maharashtra, many people are opting for vaginal surgeries now.
Yes, that is
Because
very good.
in
That,
city
that
like
is a good
Mumbai,
sign.
I've told them anybody wants to do vaginal surgery, call me, I'll come and assist you.
Very great. That is
So
greatness
that's what
of
I said, sir. You are a fantastic mentor. And thanks to these webinars, thank you, Dr. Alpesh, Dr. Patel, that you have brought the best of the obstetricians and the gynecologists, vaginal surgeons and endoscopic surgeons on one day. And it's a treat, actually. So, we all should never lose the interest of doing vaginal hysterectomy. And especially, sir, my little point is that in a very obese woman, of course, if we can save a hysterectomy by putting Mirena, but sometimes in an obese woman and a multiparasized uterus, I think that the vaginal hysterectomy is easier than going through all those layers of abdomen, especially with all the laxity that you have explained. It's not difficult, it's just mental block.
I totally agree on that point. It's a mental block, and that's the reason one should start with a normal size uterus, then gradually keep on going to a little bigger, and then with previous surgeries. And this is how you have to learn. The mental block is if I'll open the bladder. What happens if you open the bladder, suture it? What is there to be worried about bladder opening?
And
The
it is easier
problem is
also
of
from
mental
below.
block.
To suture the bladder is easier from below.
Yeah. You will be surprised. I'm talking about 1978 and 79. I had presented a paper at Indore AICOG conference. We had opened deliberately the bladder and removed almost 27 cases where bladder stones were removed vaginally and sutured it back.
Oh, great. That is fantastic.
27 cases we did, and I presented it at Indore conference, AICOG. That was only to get rid of that fear of opening the bladder.
Yeah, but that is also extending the indications of vaginal hysterectomy.
See, we forget that the bladder is not pathological when we are doing a surgery. Problem comes when it's a pathological bladder. Then the healing is a problem.
My one small input for with opening bladder from below in vaginal hysterectomy is usually when we are pushing the bladder up. So we have to be sure that if we have injured the bladder, we have to make sure the integrity of the ureters, because invariably if the ureters are compromised, then it's not that simple. So wherever you are injuring the bladder, whether abdominal or vaginal, if it's fundus, it's very simple. But if it is from below and you are pushing the bladder up and you have compromised at the area of the trigone, operator has to be careful about the ureters.
I totally agree with you. And the best way is to give Lasix and see the flow of the urine from the ureteric orifices.
Yeah.
They're fine. They are away from your suture line. You are not worried about putting even a stent.
I think, Joe, when we make these mistakes, you remember when I opened the bladder, that was the mistake, that the ureters I failed to check at the first instant, and I was very confident. But then later, after doing everything, when saw no urine, went back and opened the rent and did everything that you said. So our mistakes are our best teachers also.
We learn by making mistakes. Nah?
Yes.
Thank you,
Thank you,
Mitra
sir.
ma'am. Thank you, Mitra ma'am, and thank you, Rajendra sir. I would request Shabana madam to introduce our next speaker, Dr. Dholakia sir, who would be speaking on LDVH and multiple fibroids. Shabana ma'am, are you there? Ma'am, Mitra ma'am, can you please introduce our next speaker?
Yeah, please share the CV of our next speaker.
Sure, Vasu, can you please share the slide? The previous one, Dr. Dholakia sir. Vasu?
Hello.
Yeah,
No,
Dr.
this is
Deepesh
not the
Dholakia
same.
sir.
Yeah, can you hear me? I'm Dr. Deepesh Dholakia from Ahmedabad.
Sir,
Yes, sir.
1 minute, please.
Let us introduce, formally introduce you, sir.
Madam,
Yes.
Madam, this is my turn or Dr. Deepesh Dholakia, sir?
Yeah, Sanjay, I am giving you the preference because you are having some work to do.
Yes.
So I am giving the preference.
Sorry for that.
preference
Deepesh
for
sir, I think it's extremely sorry because in between I came and I think I delivered my talk. Eh?
Sir.
So
Ma'am,
Sanjay,
please,
what
can you introduce
happens?
Sanjay, sir?
So Sanjay, what happens? We are doing the vaginal surgery, but there is a thick endometriosis, and that endometriosis involving the rectum. So we are giving you the chance to do the laparoscopy of that patient.
Yes, yes, sir. Actually, I try to make the simplified today. My talk is morely aspect on the fertility enhancing endometriosis surgery rather than involve the bowel, ureter, nephrectomy, bowel resections. But I make the simple things, which important point is important for the fertility outcome.
Sir, should I introduce you? वैसे तो आपको पूरा हिंदुस्तान जानता है, and most of us who have been interested in following surgeons, good surgeons of India, know your existence. I have watched you live in many conferences, which is a very courageous thing to do. But it is my honor to introduce Dr. Sanjay Patel, who hails from Ahmedabad. And we all know him to be a fantastic surgeon, laparoscopic surgeon with special, mastery in tackling any and every case of endoscopy, especially endometriosis, which is the, bugbear. And he has performed more than 50,000 gynae endoscopic surgeries till date. And he is the first gynecologist in Asia to perform laparoscopic vertime hysterectomy in way back 1997 and 98. One of the pioneers for bowel resection and anastomosis in endometriosis in India. I'm so sorry that the print is so small. Yet I would like to say that as an excellent surgeon, he has received multiple awards. Junior Foxy Korean Award in 2007, Senior Foxy Korean Award in 2019, and many more awards. So I will not be coming in between you and your talk. And I want to say that his hospital, Mayflower, is a really, heaven for all the women who need all kind of surgeries. So it's the pride of Ahmedabad. Thank you, sir. Over to you for your talk.
Thank you for the kind words, madam. First, I would like to thanks to the Dr. MC Patel Sahib and entire team to giving me this opportunity. Also, all the best to the MC Patel Sahib for the presidency of the Foxy. I think MC Patel Sahib contributed a lot for the Foxy, and I think his contribution is everybody is recognized. As a vice president and as a part of the one of the committee member, and even the also aspect of the medical legal aspect. Today my talk is related to fertility enhancing the endometriosis surgery. I try to make the focus some of the most important point, and I narrate it step by step. Endometriosis still is the enigma. We are not ever the real reason of this disease, but we know the certain fact on the base which is the present treatment is designed. Still is the enigma. Exact cause is we couldn't know. Now we simplified this, particularly the fertility enhancing endometriosis surgery. How we deal it? Effect on the ovary, effect on the tube, effect on the uterus, effect on the peritoneum, and associated with the deep infiltrating endometriosis. Rectovaginal plate and the parametrium involvement, we ignore it, but it is create the dyspareunia, and this is the main cause for the infertility. Vaginal involvement also it's create the main cause for the infertility, because it's create the dyspareunia and also associated with the dystocia and parametrium involvement. I think this is the one of the retrograde menstruation concept. It's implant over this peritoneal surface, is invasive site, and over a period of time it's formed the white lesion. Look here, the inclusion cyst is first is formed, and lastly it's formed the eversion of stigma. So this is whatever we remove the chocolate cyst is the part of the ovary, and that's why the AMH level is going down. Look here, it's implant inside, invasive site, and form the chocolate cyst. Whatever we call the chocolate cyst, it's the part of the invasion of the ovary. And whatever we take the care for removal of this cyst, some of the primordial follicles we compromise. And that's why the AMH level is going down. And look here, try to make the remove the entire cyst. Once you try to make the lift up, the fibrin is secreted and automatically stuck together. Look here, this is another case of the kissing ovary. This is the eversion of stigma. It's the thinnest portion. You try to make the lift up it. Never put the incision on the cortex of the ovary. Try to make the lift up from the below. And this is the active endometriotic gland. It's the gateway for the DI. In this case, we perform the cystectomy. Definitely the ovarian volume is going down. And sometimes I prefer to take the stage stitches to give the good memory of this ovary. This is the wrong technique of tissue retrieval, because sometimes it's presented with the scar endometriosis. And look here, this is the port side scar endometriosis. Always we prefer to endobag, put inside, and then we remove it. In the last cyst, we put the directly trocar, we aspirate it. This is the weight variety of endometriosis, is easily separated with the success. And we break the adhesions with the success. This is the spontaneous. Sometimes patient is presented with the high level of Ca 125 associated with the severe pain, and this case is associated with the spontaneous rupture of the endometrium. In this case, I think ovarian abscess is very common after the endometrium aspirations. So this is not the right approach to, I think, aspirate the endometrium with the transvaginal approach. So majority time, I think we tried in the beginning of our career and we fail it because it's the fluid is so thick sometimes and we not aspirate properly and it's create the leaking. Now we explain related to effect on the fallopian tube. Look here, small implant, it's create the kinking of the tube. It's already interfere related to ovum pickup and even the formation of the embryo. So try to remove the nodule, do the straightening of the nodule. Look here, this is the small nodules near to the fibria, and it's altered the tube-ovarian relationship. So we excise this nodule, restore the tube-ovarian relationship. The small things is related to fertility part is very important. In these cases, presented with the hydrosalpinx. Never jump for the removal of the fallopian tube in cases of the endometriosis, because it's always the tube is better. And even to perform the salpingoscopy, we find out the salpingoscopy is normal. Sometimes due to this endometriosis implant, the axis rotation of the fallopian tube, you correct the axis rotations and maintain the tube-ovarian relationship. This is very interesting case. It looks hydrosalpinx tube with a lot of dense adhesions. This is the kissing ovary, kissing fallopian tube. You have to do the adhesiolysis and maintain the tube-ovarian relationship. This is another case. Looks here. This is the dilated tube with the hydrosalpinx, and this patient came for the removal of this fallopian tube, and just we try to make the split the nodules. We find out immediately just below to the nodules, we find out the healthy ovary and do the adhesiolysis, and this fibria is pop out. So in endometriosis, never jump for the go for the salpingectomy in the dilated fallopian tube. Very rarely is the appendix is associated with the PID. In those cases, I think it's damage endosalping. In those cases, we require to perform the salpingectomy. Now we discuss related to effect on the uterus. So look here, due to this anterior compartment DIE, deep filtrating endometriosis with the brilliant involvement, the axis rotation of the uterus is happen. So you correct the axis rotation because it gives the abnormal uterine contraction and it prevent the implantations of the embryo. Sometimes associated to check the perform the cystoscopy. Previously we used the fiber optic catheter, this illumination effect to find out the pathway of the ureter, but now we dissect the ureter. This is the very old school of throats, and we not use any fiber optic catheter. One of the important part, peritoneal implantations. And I think we developed the end block removal of the affected peritoneum, and it's give the wonderful outcome related to fertility part. Look here, this is the multiple implantation over this peritoneum. So in these cases, we have to have the remove the end block removal of the peritoneum. First, we dissect the ureter, anterior surface of the ureter. We try to make the dissect parallel to the ureter, and above the level of ureter, this is the upper wing of the butterfly, and below the ureter, we give the lower limb of the butterfly. And associated, this is the entire middle portion is the posterior cervical pathology is the rectovaginal plate. This is one of the causes create the dyspareunia, and that's why the majority of patient is presented with the infertility. Always we try to make the in this case is go enter in the middle parietal space, but the nerve sparing surgery is very important. Try to make the preserve the hypogastric nerve, and then we enter in the two layer of the denominator space here. We split the vagina, we mobilize the colon, and then entire affected peritoneum with the rectovaginal plate we remove it. So we started this approach in 2007, and we find out that it's give the wonderful outcome not related to part of the fertility, but it's improve the quality of life. Patient is free from the pain, and second, fertility outcome is excellent, and the recurrence rate is very less. So this is the end block removal of the affected peritoneum. This is the another on the left side. We entered in the middle parietal space. We dissect properly. And this is the posterior affected portion associated with the, we do the nerve sparing surgery. We preserve the hypogastric nerve. And all affected peritoneum we remove and block. So I think in endometriosis surgery, first surgery is very important, because whatever you take the care, recurrence is bound to be happen. So if you do the complete surgery, thorough surgery, I think its recurrence is delayed and it's improve the patient's quality of life. So this is the end block removal of the entire affected peritoneum associated with the removal of the torus uterus, rectovaginal plate we remove. This torus uterus is as a body of the Mayflower butterfly technique, and this entire four wings is shaped like the butterfly, and that's why we call the Mayflower butterfly technique for the cases of the endometriosis associated with the peritoneal implantations. I think I showed some of the cases, those who multiple times the IVF failure. Look here, this case, presented with the multiple type of IVF failure, associated with the DI, deep endometriosis, associated with the adenoma. This tubio-ovary relations may be altered due to these adhesions, may be due to the combo of due to the endometriosis and due to the previous surgery. So first stage, to restore the tube-ovary relationship. Always the ovary is adherent on the posterior surface of the uterus, and this is the nodule. We split the nodules. First, we maintain the proper tube-ovary relationship. We excise all the bend. Rather than divide the bend, we excise the adhesions bend. And we try to create the proper mobility of the tube and ovary. Then we split the nodule. This is the entire affected rectovaginal plate. And this is the main cause for the dyspareunia. Also associated with the involvement of the uterosacral and parametrium in these cases. So we split the nodules, we enter with the two layer of the duodenal fascia, and half of the nodules we bring with the column. But even though in the first surgery, if you find out the bowel involvement, you have to have the remove it, because this even though associated with the DI with the bowel involvement, it's changed the chemical molecule of the pelvis, and this is also one of the cause related to fertility part. So this is the same concept of the Mayflower butterfly technique. This is the advanced case associated with the uterosacral involvement, rectovaginal plate with the vaginal involvement, with the bowel involvement. And over a period of time, we realized that endometriosis surgery is like the mathematics. If you come with some of the concept, it gives the wonderful outcome. And it's this is the simplified way for the how we deal particularly for the endometriosis surgery. And this is the entire rectovaginal plate involved, associated with the upper vagina is involved in these cases. We remove it properly. We never leave the halfway of the related to this. This is the also parametrium involvement, because ureter is the first victim. It's near to the parametrium. Once the parametrium ureter is the first victim and presented with the hydronephrosis and hydroureter. And this is the adenomyotic tissue on the posterior surface. Majority time we find out adenomyotic tissue just behind to the adhesions. So proper mobilization of the colon is very important. And look here, this is the vein, uterine vein. This is both the side of ureter I show you in little white. And this is the nodule over this column. This is mushroom shape. First we mobilize the fat and we expose the proper nodule. So even though in the fertility enhancing surgery, you have to have the deal with some of the advanced cases associated with the bowel involvement, and you remove it. Because if you remove such kind of the nodules over this bowel, it's for in the future, because it's the progressive disease. Further, it's maybe invade inside and end up with the bowel resection. So this is some sort of, we do the sieving over it. We remove the entire tissue of endometriosis and just we suture it. We do the single layer suture with the 3-0 below, and patient is absolutely uneventful. And even though it's multiple time IVF failure, this patient is carrying the natural pregnancy, and that's why I put this case. In our center, we realized that 30% patient is carrying the pregnancy after the proper surgery. So single layer closure, because we not open the mucosa, and that's why just we save over from the muscularis portion of the colon. So single layer closure is enough. I think we couldn't keep them at least 6 to 8 hours. We keep the lid by mouth, and then we start the liquid. In particular, these cases. So this is the end result. If you look at this is urine. Just below it's the hypogastric nerve. This is the nerve sparing surgery, and we remove the entire affected portion of the pelvis. Also associated with the adenoma, we realized that first time I spoke related to adenoma resection in 2003. At that time, so many people is tell me, I think you have the surgical mind, that's why you spoke related to adenoma resection. Now it's the gold standard. Localized adenoma, I think if you excise that, it's improved the fertility part. And this is the seromuscular involvement with the adenomyosis. Just we excise the localized adenoma because it's interfere related to uterine contractions, and that's why it's prevent the implantation. If you remove the such kind of the adenoma, I think it gives the better quality life for the patient. Patient is immediately free from the dysmenorrhea, and even the it's improved in the menorrhagia. So this is the end result of this case. Another one case I show the very interesting. This patient is also multiple time of IVF associated with the dyspareunia dyschezia, 6 centimeter of the vaginal nodules. Look here. This is the kissing ovary and associated with the chocolate cyst. First, I think dissect because ureter is the first victim. In such kind of the advanced cases, always try to make them mobilize. Then we split the nodules and mobilize the colon. This is very important. Again, we enter in the middle pararectal space and we mobilize the colon. Because it's the 6 centimeter size of the vaginal nodules. Also affected, this is the uterocecal with the parametrium involvement. So we thoroughly excise the parametrium involvement because in this case is hydronephrosis and hydroureter. So we have to have the entire remove of this parametrial disease. And also just like the rectovaginal plate, torus uterus, the parametrium is also one of the cause for the severe dyspareunia. And this is the entire vaginal nodules. Look here, I show you in little white with a lot of lacunae collections. This lacunae collection is work like the volcano. And this patient is suffering from the severe pain during the time of menstruation. Even though you take the detailed history, some of the patients have the suicidal tendency due to this lacunae collections. Because this patient is suffering from the very severe pain. And this is the entire vaginal nodules, we remove it. Look here, the big nodules associated with the multiple lacunae collections. Associated, this is the 8 centimeter of the colonic nodules. So we don't leave the halfway through. I think the surgery, if should we do the complete surgery in such kind of the cases, this is benefited to improve the first quality life of the patient, and second, it's improve the fertility part, and third is the recurrences you delay in such kind of the cases. So this is the lateral fat is involved, mesenteric fat is involved with the endometriosis. We remove it. And this is the entire 8 centimeter long nodules over this sigmoid and rectum. Even though in such kind of the cases, rather than directly jump for the bowel resections, ideally newcomers is very fascinated for the bowel resection. But in our center, the first approach, we go for the conservative line of surgery, organ sparing surgery. And I think organ sparing surgery is always the complications rate is comparatively very less. Because any fecal peritonitis or fecal fistula happen, the morbidity and mortality is so much high. So I think in our center, as far as possible, we try to do the organs sparing surgery. In these cases, this is the muscularis involvement and long segment. We try to make the same over this colon. We put the rectal probe just below to the it, and parallel to this rectal probe, we save the entire nodules. MRI is very best to know the exact depth of the involvement of the colon. And that's why in such kind of surgery, proper mapping is very important. So mapping in the cases of the endometriosis is very key part for the success and outcome related to this surgery. So look here, this is the entire 8 centimeter long nodules. We save over it. And then we suture it. I think some cases even though not required any suturing after saving, but it's the muscularis. Whenever you realize that the muscularis involvement of the colon, better you do the suturing. It's for the safety. There is no medal for the bravery in the medical field. You kept in your mind. This is very important. बहादुरी का कोई मेडल नहीं होता. The safety of the patient is very important part, and this is the another. We left the small vaginal nodules. We also excise it properly. So I think now we realize, due to this IVF and due to this, in cases of the endometriosis, ovum pickup, I think by the transvaginal sonography, day by day, the vaginal involvement with the endometriosis, this is like the scar endometriosis. And that's why I presented this case. Because due to this increase the incidence of the IVF, and even though in the endometriosis cases, people is try to make the do the ovum pickup through the vaginally. In those cases, ample of chances of the scar endometriosis and vaginal endometriosis cases will be day by day increase. We do the suturing, we do the good approximation of the muscularis portion of the colon, and just we put the rectal probe. So we know that there is no stricture, no narrowing of the lumen. Okay, can you appreciate this one? So this is the end result, and this patient is carry the natural pregnancy after this surgery. Those underwent go for the 6 or 7 time IVF failure, and that's why I choose the couple of cases so people is know that the surgery is really gold standard for the endometriosis. And I think if you do the proper surgery, the outcome related to not only the related fertility part, but pain score, I think related to sexual life, dyspareunia, dyschezia is improved. At the end, I conclude my session. Management of the endometriosis remaining is the challenging. It's a multitask approach is required. No place of GNRH analogous and Dynogest preoperative. Another one point I noted is Dynogest is created, it's lost the tissue elasticity of the tissue, and it's the worse than the GNRH. It's improved related to pain scoring, but it's created a lot of fibrosis. Management in advanced endometriosis require higher level of surgical skill. IVF is better option in advanced cases of the endometriosis. I am not against to the IVF. Adenoma resection improve the implantation rate in the IVF. In recurrence cases, sometimes bilateral salpingo-operectomy and ovum donations may be required. Removal of the rectovaginal plate, torus uterus, and removal of the vaginal nodules, it's improved the fertility part. So this is new concept we given it. And I think the incidence of the vaginal nodules is increased after the ovum pickup. We realize in our institutes.
Over to you, Mitra ma'am.
Thank you.
I think Dr. Sanjay, that was just simply beautiful, because all of your learning points you have elaborated with each of your videos. And I am actually really so impressed. Once again, I'm watching you now after a long time. But what is so beautiful is that, for anybody to learn, to who wants to tackle with endometriosis, of course, it's not a one-day phenomenon. You have to grow along with your cases, learning everything. But there are so many strategies in managing the vaginal and the rectal endometriosis. And you took us through everything from peritonectomy to removal of the nodules without even dissecting the ureters. And then you also showed us how ureters need to be dissected. So actually each case is different. And with your level of expertise, of course, you could remove the nodule without even touching the ureters. I was making a deep note of that. And your concluding remarks, actually, anybody who has cared to listen to your presentation would see all of them case-wise. So I think it was a treat. Thank you. I was supposed to chair the previous session, but this was like a bonanza. Thanks so much. And if Farendra, I can see Dr. Farendra over there. I'm sure he's a good learner as well. So Farendra, for your comments.
Sanjay Patel, as usual, we all of us are growing, seeing you and listening. And the way, in a simply way, you are explaining the pathophysiology and its clinical correlation, and using this knowledge in the treatment of endometriosis is fabulous. It's really enlightening all of us, those who are involving in endoscopic surgery. Sir, preoperatively, you have told many things, and no use of GnRH and Dinogens. Of course, we know that it's once it become a fibrotic state, then the surgery is the only solution for endometriosis. What is your protocol post-operatively in such patients, in one, where the patients need treatment for dysmenorrhea, pain? Second, if for fertility. For fertility, most of them, you recommend a cyclical ovulation induction or IVF. But for the pain management, what treatment you prescribe them post-operatively to reduce the chances of reoccurrence?
I think, Farinder, thank you. It's a very good question. I tell you, once upon a time, I think we prefer to use the overall L. Because we not in, if you use the Dynogest to GnRH, what's happened? Actually, Dynogest is create the patient is benefited related to pain. It's create the amenorrhea and scanty menstruations, but the disease of the progress is going on. Yes. It's not stop there. It's give the better improvement in the pain and give the good quality life. But disease is progressing and it's created a lot of fibrosis. Ultimate gold standard for the endometriosis is the surgery. So I think we prefer to use the previously OC pills. Yes. I think it's the best one. But after the COVID era, even though we find out that so many patients presented with the thromboembolism, deep vein thrombosis. And I think also we stop this one because I think estrogen is the one of the cause to create, also the progesterone is create the thromboembolic phenomena. So I think we find out in our studies so many patients presented with the deep vein thrombosis, those who are on the OC pills. So I think we stop using after the COVID era, whether it's due to the vaccine or whether it's due to the COVID itself. So and now we give the symptomatic treatment, particularly the paracetamol. And if you do the complete surgery, I think patient is 110% is benefited related to pain score. Before I conclude my session, I thanks to the Dr. MC Patel Sahib to giving me this opportunity and all the best for the Foxy elections. And second important part, you contributed a lot, particularly for the Foxy, not for the Gujarat, for the entire India.
Sir, एक question और है, you cannot go. एक question और है. Two sets of patients. One is the unmarried girls who come with big endometriomas and pain. So, what is your take? Because honestly, giving Dynogest and all is like time pass, but making it difficult for the longer run.
Madam, people is doing the foolish things for the unmarried girls. Majority kept in mind, पहले इसकी शादी करा दो, जब तक सर्जरी नहीं करते, सोशल स्टिग्मा चला जाएगा. Patient is benefited, give the Dynogest and everything. The disease is progress like anything. In the last month, we do the two nephrectomy. Those who, one is 23 years old and another is 26 years old. So I think any patient is present, you go for the particular mapping. Whether you go, if you expert people, go for the transvaginal sonography and assess for the involvement of the disease. Second is the MRI. If disease is involved the parametrium, disease is involved the rectovaginal plate with the torus uterus, disease is involved with the colon, you have to address this particular disease, whether it's the age of 18 years old or 24 years old. If you leave this disease, it's the catastrophic. And I think when you wait for the longer time, the disease is more progress and the surgeries become the more complex. So I think everybody you kept in. What I am telling with not the cases of the 500 or 1000. This is the story is more than 25,000 of the endometriosis surgery. And then I tell you, this is my experience. I think because in the unmarried girl, we ignore the pain. We ignore and just we write down the OC pill and Lupride and Dynogest and everything. And patient is presented with the severe form of the involvement of the DIE. So I think the proper mapping, particular for this disease, is very important.
Thank you so much. And what is the second look of peritonectomy, the butterfly peritonectomy, because you have denuded the peritoneum? So what does it look like?
I think definitely in the next lecture I show the series of cases after peritoneum.
You should.
Majority time we identify during the time of cesarean sections, and I show the wonderful pelvis without any adhesions, and it looks like there is no evidence of the endometriosis, because whatever you remove the peritoneum, regrow of the peritoneum happen in 20. Okay, and adhesion is depend upon the body tendency of the patient. None of the drugs available in the market to prevent the 100% adhesion. You live for the nature, and believe me, out of 100 peritonectomy, hardly you find out some of the flimsy adhesion in less than 5% of the cases.
Thank you so much.
Thank you, Sanjay sir.
Thank you so much for this elaborated talk.
Yes, sir.
I just want to make a comment, sir.
Yes, sir.
Yes, sir.
Excellent surgery, and I completely agree with you that endometriosis is not a gynecological problem. It is a chronic inflammation. Therefore, even if you remove the uterus, it is not going to go. It is going to progress, and therefore, complete removal of all the deposit is the only answer for endometriosis.
Sir, I do the one comment. In our center, now the maximum cases after post-hysterectomy, not only hysterectomy, post-pan-hysterectomy, uterus with the removal of the bilateral salpingo-operectomy, patient is presented with the hydronephrosis, hydroureter, dyschezia, colonic involvement, rectovaginal plate, and bladder involvement. The maximum cases now we done it after post-removal of the uterus and bilateral salpingo-operectomy.
Yes, it's a terrible disease. What can we do? It's very terrible.
Because inner estrogen, it's play.
Yes.
We realize the fat, adrenal gland, kidney, liver, it's also secrete the estrogen.
Yes,
and it's
yes,
indirectly,
that
I think, continuously.
Because it's a chronic inflammation. Basically, it's a chronic inflammation. Yes. Thank you, sir. Thank you.
Thank you, sir. Mitra ma'am, I request you to please introduce our next speaker also, because Shabana ma'am is still in a meeting, ma'am.
So,
MC sir, yes.
Excellent talk, Dr. Sanjay, as usual, and it shows your tremendous experience in your endoscopic surgery by your video, by your explanation, an easy way how to deal with that very situation. It shows your vast experience in that very surgery. So, congratulations for the same. Thank you for joining and sparing time for us.
Thank you, sir.
Thank you, Sanjay sir. Yes, Mitra ma'am, over to you.
Yeah, thank you, Monica. Thank you, Dr. Patel, because आपने इतने important session में हम लोग को involve किया है कि हम वैसे भी सुनी रहे थे सुबह से और अभी भी सुनी रहेंगे. तो please share the CV of Dr. Deepesh Dholakia. Thank you, Dr. Sanjay. So, friends, we are going to go back to the last. Is this the last talk of the middle sector, Dr. Monica?
Dr. Mitra, I think I am the last one.
Okay. Sorry, apologies. So today we are having Dr. Deepesh Dholakia, an excellent vaginal surgeon who has been the past president of Ahmedabad Ob-Gyn Society, secretary of SOGOG, ex-associate professor of NHLM Municipality Medical College Ahmedabad, who has been the organizing chairperson for AICOG 2017, and he has special interest in difficult NDVH and high-risk obstetrics. So, Dr. Deepesh, please come out with your tips and tricks to deal with difficult vaginal hysterectomies in multiple fibroids.
Good evening, everybody.
Welcome, Deepesh bhai.
Can you hear me?
Oh yes, you are audible. Welcome.
Yeah. So, first of all, I am very much thankful to Dr. MC Patel. Belated happy birthday to you, my dear MC Patel sir, and the candidate for the coming Foxy president election, and I wish him all the very best for this coming Foxy president election. And I think He doesn't require any introduction. In Pan India, he is known to everybody in every aspect. He is very much useful to each and every gynecologist in the each corner of the India. So everybody knows him. And my humble request to all the gynecologists in this endeavor to vote for him and make him elect in coming election. Thank you. These are the good words for him. And now I am proceed for my presentation of NDVH in bulky uterus, particularly fibroids. Can you see my presentation?
You share your screen.
Share the screen.
Green button at the bottom. Yes, now it is. Make it full screen. No, it is not full screen still. Click at the bottom picture of TV or cup, whichever we call, and it will be full screen. At the bottom, you have to in a presentation was okay. You have to only make it full screen. At the bottom, there is a picture of TV or cup like. You have to go to that button.
मैंने जहाँ दिख रहा है सर उसका बाजू में प्रेजेंटेशन मोड
नीचे
माइनस के बाजू वाला
बाजू में राइट साइड yes yes fine go ahead.
So Dr. Sarogi sir has already introduced the art of vaginal hysterectomy, particularly in non-descent vaginal hysterectomy. Hysterectomy is one of the most commonly performed surgery in the world. Hysterectomy can be performed vaginally, abdominally, laparoscopically, or with robot-assisted laparoscopy. Still, vaginal hysterectomy is the preferred route of hysterectomy when it is possible. We know all the advantages of the vaginal route, and it is well known to all the gynecologists, and it is well known to be enumerated. Hysterectomy has been associated with the improvements in physical and mental quality of life measures, body image, and aspects of the sexual activity, with few differences among the surgical routes. We know the indications. Hysterectomy can be performed in different ways. Most of the indications are DUB, fibroid, and adenomyosis. The best way to tackle is vaginal hysterectomy, which is safer, which does not require any modern gadgets and can be mastered by every gynecologist. We should not fall prey to the gimmicks, gadgets, and glamour and subject our patient to such a surgeries which may be associated with higher rates of complication and most of which may be iatrogenic also. We should promote and propagate vaginal hysterectomy, which is an indigenous surgery, which is a natural root surgery, and in accordance with our new Prime Minister Modi's now in the third term to have a Atmanirbhar Bharat, and we should upgrade our skills to do the vaginal hysterectomy, which is a like Aam Admi or Aam gynecologist surgery. So, important clues to learn the art of this hysterectomy vaginal route, cervicofundal sign by Dr. Siris said, to see for dimpling and implying that there were dense adhesions with the anterior abdominal wall. In such cases, we have to take the help of the laparoscopy in these cases. Put the speculum in the posterior vaginal wall and see if the cervix is high up and behind the pubic symphysis. We should not try NDVH in such cases. And remember, anterior posterior bulge is easier to tackle than transverse bulge. Appropriate insertion of myoma screw is of real help in inoculating the fibroid and for pulling force to drag out. While clamping remain near to the uterine border, these are the principles of non-descent vaginal hysterectomy. And Dr. Sarogi has already enumerated that when there is an obtuse angle, there is we can uterus is in vertical, we can remove this. And if it is transversely spread, particularly in the cases of the severe adenomyosis, the difficult because it is stuck at the level of the inner pelvis, and we cannot pull this down in the vagina. So I can show you the technique of the vaginal hysterectomy in the non-descent cases. We infiltrate lots of saline with adrenaline, so the tissue becomes soft. And second, there is a vasoconstriction because of the adrenaline, so blood loss is less. We always believe in the sharp dissection. So after putting the anterior incision, we cut the bladder pillars and push the bladder little bit up and then leave. So for the clamping of the uterosacral ligaments, we does not require to push the bladder higher up. In the first clamp, we have to include the uterosacral ligaments plus McIndore's complex. In opening the posterior pouch, we always put the bold incision, and usually in the first attempt, if it is not adherent, we open the posterior pouch. We usually cut the lateral wall of the vagina also to facilitate our clamp applications, so we can easily apply the clamp over the McIndore's and uterosacral complex. Nowadays, just we applying a single clamping and single ligation. Just we pass the needle, just get the needle and just ligate. There is no need of transfixation also. So before the uterine vessels, you need not to open to the anterior peritoneum. We always ligate the uterine vessels extraperitoneally. So whatever the big uterus, whatever the fibroid uterus, if you ligate the uterine first and then approach for the morcellation or removal of the fibroids and debulking of the uterus, makes the hysterectomy in the bigger uterus easy. Now you can see the anterior pouch is automatically open. We should not go behind to open the anterior pouch all the time. When the stage comes, usually it automatically open. We always ligating the ascending branch of the uterine vessel separately, and it always very much helpful to us for the big uterus. So after ligating these ascending vessels also, if the fibroid is in a fundal region or anterior or posterior, you can easily debulk the uterus, without any much more blood loss. This is the ascending vessels ligation. Just we apply the single clamp and single ligation. Just we pass our needle, we catch the needle posteriorly and simply ligate the pedicles. There is no need to transfixation of this. Now, the morcellation technique, in which after ligating the ascending vessel, usually there is only blood supply from the ovarian vessels. It is not that much, and you can see the bloodless field even after morcellation or the debulking of the uterus. So now the uterus is attached only with the infundibulopelvic ligament, ovarian and round ligament. So there are the different techniques, either morcellation or pull out or applying the screws, myoma screw. You can directly approach to the three cornual structure. To learn this art of surgery, you have to go step by step. You have to learn normal size, then 6 to 8 week size, then with the bigger size of 10 to 12 week size, and then you can learn this art. You can see we are doing everything under vision. So many friends that telling that you are doing the blind procedure. Vaginal hysterectomy is never blind. It is everything is under our vision, and we can apply the clamp easily. So this is a almost 12 week size of the uterus. We remove it easily. Again, I want to show you one more hysterectomy of the fibroid uterus. We usually regularly injecting the normal saline with the adrenaline. In this patient, you can see the level of the cervix is so high. We are making the space anteriorly and posteriorly. We use the single speculum. When we are injecting anteriorly, just put the anterior speculum so we get some space. When we injecting posteriorly, just put the posterior speculum also so we can get some more space even in the patient of nulliparous uterus or with the previous cesarean section, or there is some adhesions inside. Always prefer the sharp dissection. Sharp dissection, there is less blood loss. So posteriorly, now we are opening the posterior pouch with the deep bold incisions. If there is no puckering, don't worry about that, rectum will come. And always try to open in second thrust, so it will be under vision. So here we cut the bladder pillars, lateral vaginal wall we cut to accommodate our clamp and to make the pedicles of the uterosacral with McEnroe's complex. Here we are using the modern gadget. This is a bipolar vessel sealer system. I want to show you that particularly when the uterus is high, the cervix is high, this vessel sealer system definitely help you to learn this art of the hysterectomy by vaginal route. This is bipolar vessel system, vessel sealer system, which coagulate even 7 millimeter of diameters of the blood vessels. Nowadays, the shearer with the bipolar or shearer with the vessel sealer comes, in which cases you does not require even cut with the scissor. It will automatically seal and cuts. So this is the base of the broad ligament, and I have taken the branches of the uterine vessels extraperitoneally. So for when you are doing the big size of the uterus with fibroids, good ultrasonography with mapping of all the fibroids will helpful you the line of dissection that will have to remains in the plane all the times. So there is a less blood loss. If you are remain in the plane all the time, there is always less blood loss in the non-descent hysterectomy. So after ligating the uterine vessels, now I cannot approach. I just chop out the cervix first. Now you can see the fibroid. There is a big fibroid, and I am using the myoma screw at this level. Even 1, 2, 3 myoma screw you can accommodate when there is a big fibroid. And after ligating the uterine vessels, usually the field is little bit bloodless. Always pull downwards, and your anterior speculum is between the capsule of the myoma. Even if there is a big fibroid is there, you can morcellate the fibroid itself. So here is the morcellation of the fibroid. It's a 16 to 18 week size of the myoma. And can you appreciate how easily we are going to morcellate the fibroid and approach through the vaginal wall? We always use the posterior sacral curve. Once there is an anterior or posterior myoma is there, you use the posterior sacral curve, the uterus and myoma fits into the posterior sacral curve, and if you go by midline, you cut in the midline, the uterus with myoma comes down automatically. Now I am ligating the ascending vessels of the uterine branch. This is IUCD inside. So use the whatever vaginal space, you retract on one side and go towards the lateral pelvic wall. You can get some space all the time. This is coagulation of the ascending branch of the uterine vessels. Again, I am morcellating the uterus. Again, applying the myoma screw. Because it's a magic box. one and one more fibroids is coming out. So that's why the fibroid mapping is required. So you can absolutely see what is the size of the fibroid, what is the position of the fibroids, how many fibroids are there in the uterus. Now, usually there is a myohyperplasia around the fibrosis. So there is a hyperplastic tissue of the myometrium also with the fibroid. So I cut in the midline, I bisect the uterus. Now I open the peritoneum. Can you appreciate at which level we have opened the peritoneum? At the last pedicle level. So never worried about whether you have opened the anterior pouch or not opened. So always put the uterus in the anatomical position. So your pedicle is crumpled little bit. So now we check all the hemostasis and catch the posterior vaginal wall with the peritoneum and anterior vaginal wall to close. So we have removed, this is a one nulliparous patient with this number of fibroids. We have removed up to the 20 to 24 week size. If the mobility is good and good mapping, there is a multiple fibroid, we can remove this much number of the fibroids. This is the weight of the fibroid. 1 kg, 180 grams. So, take-home messages is the vaginal hysterectomy in the bulky uterus. This art can be mastered by every gynecologist. Use of modern gadgets like bipolar vessel sealer is the removal of the big uterus by vaginal route. And we as a gynecologist use this route maximally, which is cheaper, natural, and no stitch technique for the benefit of the patient. Thank you very much for seeing the videos and kindly give me this opportunity to show me the art of this non-descent vaginal hysterectomy. Thank you very much.
Mitra ma'am, are you there?
There. And
Yes,
there,
ma'am.
I will just conclude Dr. Deepesh Dholakia's excellent presentation. To watch your videos was the cherry on the cake, and very, very nicely done. And actually, it needs so much of nerves to deal with multiple fibroids. Be very confident about your ligation of the vessels, and then keep in the anatomical planes and not worry about opening the peritoneum, especially with such a big fibroid, irregular fibroids, big uterus. It would not have been so easy to open the anterior peritoneum. So I think it was an excellent demonstration. Thank you so much. And Dr. Patel, sir, our best wishes are with you. You have always been supportive of all of us, and we are all there to see you successful in your endeavors in Foxy. Thank you so much. If you will please allow me, I have
Thank you,
some
chairpersons and
OPD patients.
coordinators of this
Monica, can I
one-day
make a comment?
workshop
Please.
of this
Thank
all
you, Monica.
operative techniques.
Thank you, ma'am.
We are very much happy. Such a large number from the Pan India people have accepted this and this art of this different surgery. They are taking advantages of this. Thank you very much.
Monica, can I say something?
Yes, ma'am. Yes, ma'am.
Yeah, Deepak bhai, I was watching your videos And I'm very happy to say that when I was a unit chief and professor at Science, we had made it a rule that all the uteri has to come out vaginally unless it's an ovarian tumor where you have no choice but to do a laparotomy. So NDVH was the norm, and we started with normal size and finally went up to 16 and even 18 week size uterus. So I know what a wonderful surgical skill that is to do vaginally. And I was very happy that all the residents who trained with me, they all became excellent vaginal surgeons. Some of them have also become endoscopic surgeons now, but they have mastered that skill of vaginal surgery and then moved on. So Monica will remember that because Monica's husband Shashikant was working with me as a resident. And you know that wonderful feeling which you get, you're helping the woman, particularly if they're obese women. You know, they don't have to go through any scars with relatively less money, and the recovery rates are so fast. They're just moving about. By day 3 you can even discharge them. Day 2 evening also you can discharge them. They do so well. And Deepak bhai, I know of your skills. I have always heard that you go and assist a lot of people, and lovely to see your surgeries.
And madam, particularly some medical disorders like obese patient, hypothyroidism, some cardiac disease, bronchial asthma. These are the patients in which the even laparoscopic is difficult one, or there is a complicated thing. We can make easy and be less complication with the vaginal route.
Absolutely, I fully agree with you. Thank you.
Thank you.
Thank you, ma'am. Thank you, Mitra ma'am, for chairing this session. I would now like to introduce Dr. Bhagyalakshmi ma'am, who will be the next speaker today. Vasu, can we have the slide, please?
Yes, ma'am.
Yes, sir. Today's talk is on thermal ablation by none other than Dr. Bhagyalakshmi madam. She is currently the HOD in the Department of Oncology at AHPGIC Cuttack. She is also the chairperson of the Oncology Committee FOXI from 2018 to 21, a governing council member of ICOG, vice president of Association of Gynecologists India, honorary secretary of AGOI.
Thank you, Monica. Thank you, Monica.
Sure, ma'am. Over to you, ma'am, for your talk.
Yes,
Thank
yes. And at the outset, I'd really like to thank MC Patel sir for giving me this opportunity, and I bring all the blessings from, I think the host has disabled me from screen sharing. So Monica, please.
Vasu, can you please take care and allow ma'am to share the screen?
And sir, thank you for giving me this platform and sharing this platform with so many elite people. And we really had the best of the surgeons, Dr. Sanjay Patel, Dr. Dholakia, and sir's CNS's oration was so excellent actually about the Odon. So after all that 3D movies, we will now go to Mogliasm. I think thermal ablation, people don't think it's very important, but I think it is important, and we all need to actually learn and do it. It is a very simple procedure, and that's how we have to take it. Sir, is my screen visible now?
Bhagyalakshmi, Mogliasm is the eternal classic.
Yes, madam, like you. So is my screen visible?
Yes, it is visible.
Okay, thank you, sir. So I bring all the blessings for you, sir, from the land of Lord Jagannath. So we will be talking about cervical cancer, which is a totally preventable disease. So I think we now know that breast cancer is the highest cancer, but cervical cancer is a preventable disease. And the last 20, I have to put it in slideshow, I think.
Make it full screen.
Yes, sir. Thank you. Yes, sir. So the last 2020 Globocon data shows that there has been a rise in the new cases and the deaths from cervical cancer in spite of it being a preventable disease. So I think we need all to wake up to this call. And I think WHO has given a call for elimination of cervical cancer. And for this, we need to vaccinate 90% of the girls, screen 70% of the women, and reduction in mortality by 30% of the diagnosed cases. And so today's topic would be about this 70% of the women whom we screen. And there are various methods of screening available: pap smear, visual inspection with acetic acid, HPV testing. And please remember that colposcopy is not a direct screening test, but it is an addendum to all these tests which are available. So I think VIA screening should be an extended gynecologic examination for everyone, and to actually identify a VIA negative from a VIA positive, it needs a little training to our eyes. And I think we should, as all gynecologists, we should learn this technique. And so, and learn a bit of colposcopy also when we are in a doubt, learn a little about documentation and scoring. And this is how we score colposcopy findings, and then we plan as to how to manage such a patient. And but at the same time, I have to remind everyone that screening is not going to save lives. So if you leave the woman after screening, it is not going to do any good to the patient. So we have to learn a bit about the treatment which will save lives. So for this managing these screen positive women, we have procedures in the form of ablative methods and excisional methods. So the ablative procedure, the basic principle is to destroy the entire transformation zone up to a depth of at least 5 millimeters, based on the observation that CIN may exist up to 4 mm inside the gland crypts, and hence 7 mm is a suitable safety margin. Prerequisites for ablative methods: the entire portion of the lesion and the transformation zone should be fully visible, no or minimal endocervical extension of the lesion. A colposcopic biopsy, it's not a must according to WHO, but it's better if it is possible to take a biopsy from the lesion. And there should not be any suspicion of invasive cancer or glandular disease. And there are various types of ablative methods like radical diathermy, cold coagulation, cryopen, electrocautery, we have cryopop, laser, and so many new things which are coming up. But for us today, we are focusing on cold coagulation that generates heat by passing electric current at a very low temperature. Hence, it's called cold coagulation because the temperature never goes beyond 100 to 120 degrees. There's lesser possibility of any severe burn to the tissue or charring. There's never happens charring, and lesser side effects such as stenosis of the cervical loss or any other problems as in comparison with excisional methods. It is a very low cost and appropriate for all low to middle income countries like ours. So what is cold coagulation? The heat coagulation up to 100 to 120 degrees. We started with the same cold coagulator long back, and we have now very new modifications to that. Initially, it was a metallic probe which was heated by electricity, and the depth of destruction was around more than 4 mm, and it took more than 30 seconds. There is no need of local anesthesia, and sterilization also is very simple. You just have to heat it up for 45 seconds and it is done, and effectiveness is as good as a cryotherapy probe. The newer methods that we have is now called various types are there. This is a handheld thermal coagulator, low cost, portable, lightweight. It's battery powered, so it comes with 2 rechargeable batteries, and each battery once charged properly, you can go ahead and do more than 10 procedures. It is autoclavable probes in 16 mm flat, 19 mm flat, or sometimes we may have 19 mm pointed tips or nipple tips. We don't need any wires or cables in this brand, and there is no external power supply required during a procedure. Automated procedure timing with visual and audible indicators, and we don't need a watch or clock to see that whether it is 20 seconds or 30 seconds. So this is a better view of that. So we have a timer and status indicator lights in the front, and once the activation causes on or off of the button, and it also has a low battery indicator, and these are all detachable and can be fitted into a small box less than a kilo weighing. So once the light is on, it takes time to be heated. Then we place it on the cervix, and once the procedure is started, it takes at least 20 seconds. And once the procedure is over, the light goes off, and it takes some 10 seconds to cool down, and we remove it off after it is cooled down. So it comes in the form of many probes, one charger, one main unit, one manual book, and a handy case. And these are the types of probes that we have, and they are Teflon coated and can be sterilized easily. So the other one is also a Vicep. It has a bigger version, which is the bench one, and the other one is a handheld one. A handheld is again by battery, and the bench we need electricity for that. So this again has a nipple probe, and these are Teflon coated. So eligibility is that following VIA, we should do a VIA or maybe a colposcopy or HPV testing, and women who screen positive, but there is no suspicion of invasive or glandular disease. So that's the important caveat to that. are eligible to ablative therapy if the whole transformation is zone is fully visible, whole lesion is visible, and it does not extend into the endocervical canal. So that's the only thing we have. So the lesion is a type 1. The type 1 transformation zone means the entire transformation zone is visible. The lesion is type 2, where the probe tip can achieve complete ablation of the squamocolumnar junction epithelium, where it can reach the upper limit of the transformation zone. So if the lesion is just extending into the endocervical canal, we can still use a thermal ablator to do that. So the depth of crypt involvement in CIN is usually 5 millimeters. So ablative methods destroy up to 7 millimeters. So it's a handheld rechargeable or a bench top, and compatible for use with at least 2 probes and a flat tip and a tip with a nipple for placement into the cervical canal. And usually it takes 8 seconds to heat up, 20 to 45 seconds for treatment, again 10 seconds to cool down. So that's the cycle. And the advantage is that we can apply multiple times if there are bigger lesions. But the important thing is that our hand should be steady. Once we fit it on the cervix, the hand should not shake, so that we do not touch the vagina walls around, and wait till it cools down before taking it out. And the tricks is that visualizing the entirety of the transformation zone and the lesion is important. We need to treat the entire transformation zone, and even if it's a HPV positive lesion, and the coagulation of the transformation zone without any lesion is also acceptable by WHO. It's a painless procedure. It's an OPD procedure, short treatment time, convenient for the patient and the provider as well. And there is no fear of bleeding or scarring. But then I think it needs a bit of counseling to the patients. So women who screen positive are not eligible for ablative therapy if there is any suspicion of invasive or glandular disease, or in a type 3 transformation zone, that is the lesion extending into the endocervical canal, or type 2 zone where the squamocolumnar junction is out of reach of the probe. So here you can see that this is a VIA positive lesion, which you can see with naked eye only. It's not necessary. You need a colposcope or a smart scope to this. And then this is the thermal ablation has been done. You see it's just coagulation. There is no charring. It's just like boiling of egg, and the protein coagulates into and forms a white coagulum. The difference between diathermy is that when we do diathermy, it actually chars the tissue, and the heat is not able to penetrate into the crypts where there may be some kind of dysplastic cells. And after follow-up, you can see that the lesion has healed so completely well, and all women who have received treatment should receive post-treatment follow-up at 1 year to ensure effectiveness of the treatment. And it is more critical in particular for women living with HIV or women of unknown HIV status in areas with high endemic HIV infection, because they tend to have very high risk disease and are recurrently infected with various types of HPV infection that may lead to recurrent disease as well. But the precaution is that we really don't need any antibiotics. There should not be any active vaginal infections, and have to counsel her about watery discharge, which may happen for 3 to 4 weeks. No sexual contact, no vaginal douche is required, and there may be a 5% treatment failure also. But it is such a simple procedure. It can be done by all trained staff, sisters as well. But it's also ideal to do a biopsy before ablation. That's a desirable procedure, and you can always use a tishless forceps for that. So are ablative methods effective? Yes, it has been proved beyond doubt that the risk of persistent recurrence following ablation was significantly little higher. It's not significantly, but it is little higher than excision. But the eligibility criteria for ablation and excision are totally different. So we have to keep ablation in mind in low income settings where we are aiming for cervical cancer elimination. The findings remain similar even among women living with HIV. Both the procedures are equally safe. So we have to keep thermal ablation in mind for our day-to-day practice. And the cure rates are almost similar. You can see the thermal coagulation also gives us a cure rate about around 95%. So how do we meet the targets? We do a screen and treat. Please don't send a patient back and tell her to come back after a week. She'll never have time to come back again. So you have a lesion like this. This is called VIA positive. You can see the entire margin of the transformation zone is the entire margin of the lesions. She is eligible for ablation. So we can do a cryotherapy or a thermal ablation. Thermal ablation is better, handy, and less time consuming. But if you have a lesion like this, which is a bigger lesion, which is extending into the endocervical canal, she is not eligible for ablation. please remember, and she would need some other excisional procedure. Similarly, this is a para 3, living 3 self-collected cervical sample for HPV. So if she has the HPV positive and you have a scope for doing some kind of treatment without also doing a VIA, you can treat her. But if you do a VIA, you can see the geographic lesions like this. So this procedure is again eligible for ablation, and you can do the ablation. But if this is a high grade lesion, you can see this is very dense acetovite area. There are abnormal vessels. I think this also suspicious of malignancy. You need to do excisional procedure, and this is again a very high grade disease, and you need to send her for a second opinion or some other procedure to a higher center. So screen, triage and treat is again an option. So either you do direct treatment or you triage and treat, but try to do it in the same setting. And if you're doing it by HPV and it is negative, you rescreen with HPV test in 5 to 10 years. But if she's positive, manage by colposcopy or VIA. And if she's positive and eligible for thermal ablation, you do the thermal ablation. If there is suspected cancer, you send her off. So now is the time to act, because we don't have much time. We, with knowledge and innovative solutions, we can eliminate cervical cancer. So this is our FOXY GCPR guideline, which was released in June 2023. Again, here also we have the facility that we have the guidelines about how to go about the ablative procedure that is there in our FOXY website. You can all refer to that. And similarly, the WHO 2021 guidelines also state that if you are doing a VIA test, you can, if the patient is eligible for ablation, go ahead and do ablative treatment. If you are doing a HPV test, if again you have some method to triage and she's eligible for ablation, you ablate. Otherwise, also you can ablate the entire transformation zone. If you are doing a cytology, there is some suspicious lesion, she is eligible for ablation, you can still ablate. So eligibility, I think we have already discussed that. Identify that this is WHO guideline. Identify the transformation zone, locate the lesion of the size of the lesion. To assess eligibility, visualization of the cervix with magnified or naked eye view after application of 3 to 5% acetic acid is required, and histological diagnosis is not required. This is according to WHO. But if possible, if feasible, you have the facility, it's better to have a histological diagnosis in hand. And of course, there should be no suspicion of invasive cancer or any other glandular disease. The transformation zone should be fully visible. Whole lesion is visible and it does not extend much into the endocervical canal and should be a type 1 transformation zone. So this is a brief idea about to show you how a type 1 or 2 transformation zone is. Here you can see that the lesion is entirely outside on the ectocervix, and here it is just entering into the transformation into the endocervical canal. So these are type 1 and type 2 in which we can plan ablative therapy. But if this is a type 3, here you can see that the lesion has extended entirely into the transformation zone, and here you cannot see the margin also. The entire lesion has extended into the, so this is a type 3 lesion in which ablation is strictly a no-no. So again, coming back to our 90, 70, 90 by 2030, I think there is very, very less time left for that. So the alarm is already ringing. 2030 is just there, and we all have to rush towards it. So let's all start today. It's my sincere request to all my gynecologist friends who are actually listening to us today, and thankful to Dr. Patel sir for having organized this meeting, that I would like to appeal to all of you that please do speculum examination. You do the ultrasound, that's fine, but please do speculum examination. Look at the cervix once, and if there is a lesion, please give some kind of treatment, because we are lagging behind very badly as against the Western world, because we are not able to prevent the completely preventable disease. So thank you very much, sir, for giving me this opportunity. And this thermal ablation is a very, very simple trick. I think everyone can learn, and it is a gold mine. I have to tell for all the private practitioners, if you start looking at the cervix, pick up lesions and start doing treatment, I think that will be a great help to womankind. And thank you again, sir, and Suchitra madam, for being there for my talk. Thank you so much.
MC sir, can you please
Can I ask a question?
Yes, ma'am.
Bhagya, I just wanted to know, you said that, you know, if the HPV DNA is negative, you also said that it's still better to take a biopsy?
No, madam. If you are doing a visual inspection with acetic acid, if there is a lesion, it's ideal to take a biopsy.
Okay.
If there is no lesion, you may not take a biopsy. But still, WHO allows that even if you don't have facility to do a biopsy also, you can go ahead and ablate the transformation zone completely.
Okay. Now, supposing you finish your ablation successfully, how frequently will you call her for a follow-up? And when will you do the next, you'll do a per speculum, but when would you do a next test for a pap smear or a HPV DNA?
Madam, everything after 1 year. Because it's a reparative procedure. If you do a pap smear in between, you'll have a lot of inflammatory smears. They will mimic all those dysplastic cells. But I will like to call her once after 1.5 months just to see whether it's healing properly or whether there is some other secondary infection or not. But any other follow-up for cure of disease will be after 1 year.
Okay. Thank you. Thank you so much. Excellent talk.
So congratulations, Bhagya.
Thank you, sir.
Your excellent talk. And as you mentioned, as far as eradication of cervical cancer is concerned, WHO and central government of India is also very keen.
Yes,
so
sir.
by 2030, and you rightly mentioned 90, 70, 90 method, that is 90% vaccination, 70% detection, and not only detection, but early detection is very much required, and meticulous management of cervical cancer, whichever stage we receive patient, but it should be meticulous management. It is the only way to eradicate. And as far as this screening part is concerned, just to mention about VIA, HPV testing, etc. But for that, I would like to mention that awareness, not only in public, but in our doctor fraternity is also very much required. And I know you have taken this task in northern eastern area in a big way, and you are doing marvelous work in this era. So congratulations for that also. Thank you for joining this and accepting my invitation to deliver this talk.
Thank you, sir, so much.
And so the government of India has allocated a big budget for this, and particularly for the HPV vaccines. But then no budget was allocated for this screening part. Now there is a attempt to do that, and in that context, I can tell that HPV test is being propagated now with a lesser cost of 600 or 700 rupees, like that. And it was an excellent talk. And see and treat is the notion, and also boiling and roasting is the difference between diathermy and your ablation.
Yes, sir. Exactly. Thank you, sir.
Thank you, sir. Can we move ahead with the next session? Thank you, Bhagya ma'am. Thank you. Yes. Our next speaker is Dr. Archana Batra, madam. Can we have her CV version? Yeah. Madam is going to speak about surgical management of urinary incontinence. She is a part of the governing council member Foxy ICOG, the chairperson of IHCP Division Stillbirth Society India. She is also a member of the Foxy project on reducing cesarean births, president of Nachi Delhi in the year 19 to 21, professor of Ob-Gyn at VMMC and Safdarjung Hospital with an experience of more than 40 years. She is also a reviewer of national and international journals. We welcome you, ma'am.
Thank you very much for your kind. Can I share my screen?
Vashu, please make madam the host.
Thank you, Dr. Patel, for making me part of this prestigious conference. You know, so many good speakers and stalwarts in this. I really been stuck to the very good talks. And after Bhagyalakshmi's talk about cervical cancer and the awareness, I think we need to have awareness about this important condition, which women have and not much, talked about, not much treated. And most of the gynecologists, even women, they just leave it like that, okay, it is part of it. So I'm going to talk about surgical management of SUI. SUI, as we all know, it is characterized by leak of urine in the setting of increased abdominal pressure. There are various treatments medical treatment, surgical treatments, and once there is a failure of medical treatment or moderate to severe SUI needs surgical treatment because it is only a durable treatment option. There are many treatment options which are there, slings, retropubic slings, burst, facial slings, and there's not one treatment. Like you have multiple and different patients will need different treatment because of their characteristics. They may have a failed surgery, they may have a hypermobile urethra, they may have a fixed urethra, they may have intrinsic sphincter deficiency, they may have some diverticular fistula, or very obese, diabetic, or immuno. So all require different kind of surgery. It's very important that the patient is characterized into an index patient who is a healthy patient with no prolapse or very little prolapse and wants surgical therapy. She has either SUI or stress predominant mixed incontinence. All other patients are non-index who have all the medical surgical problem or they have been operated for prolapse or SUI. So I'm going to talk
it full screen, Achla.
Recommended surgical.
Your screen is not full screen.
Okay, so I'm going to describe the recommended surgical procedure because there are more than 200 procedures, but only 4 till now have been recommended by various societies. Their complications, recurrence rate, and choice of procedures. What causes SUI? The mucosal seal being absent, the submucosal plexus being thin, bladder neck not being competent, mobility of the bladder neck is more, or the support of the urethra have gone. So the techniques are all related to this pathophysiology. The traditional technique of anterior culpography rate is only 52% and failure rate at 5 years is 41%. So it is not recommended. So what is recommended is Bush pulpus suspension, autologous fascia pubovaginal sling, mid-urethral sling, and bulking agents. And you don't have to do UDS for all patients. The index patient may not have a UDS, but if a non-index patient is there, those patients will have to have a UDS if you're not able to diagnose properly, if there's a neurogenic bladder. And besides urodynamic, basic lab work, the consent, the bowel preparation is not there. That's very wrong to do bowel preparation when you're doing vaginal surgery because the stool becomes liquid and you are in problem. Antibiotic, of course, at time of incision. So Bush was described in 1961 and it has had a resurgence, especially after the mesh controversy. It elevates and stabilizes the bladder neck and proximal urethra. So the transmission of the pressure to urethra is there and it doesn't allow leakage. So who should have a Bush? Somebody who has no ISD, that is intrinsic sphincter deficiency, a mobile urethra and bladder neck, who are having high intra-abdominal pressure, like having constipation or COPD, because they will need something which is really fixes their urethra. If some abdominal surgery has to be done, if the vaginal access is poor, or if surgeon wants to do it. The procedure is that you enter the space of LSCS by an abdominal incision, which is the space between the bladder and the anterior abdominal wall. Reach the paravaginal space, stay away from urethra with the catheters, push the, with the bulb of the catheter, push the bladder to one side. Then you take a bite into the vagina and an assistant will elevate the vagina with the finger. You take a bite. The bite is taken lateral to the proximal third of the urethra, and then you take another bite, and then you tie it to the pectineal ligament, which is present over the pubic rami. And you don't approximate the vagina and the pectineal ligament suture. You leave it 2 centimeter bridge, which is just anchor the periurethral tissue and elevate the bladder. Now, this procedure can be done abdominally, it can be done laparoscopically, it can be done robotically. When you do it laparoscopy, then you identify the obliterated bladder fold, make an incision between them, enter the space of LSCS by dissecting the anterior peritoneum. You can see the pubic rami and the pectineal ligament over it. Then you dissect the paravaginal tissue here. Remember not to go near the urethra or bladder. Stay 2 centimeters away laterally. Then you take a bite helical stitch from the vagina, and this stitch is taken from the contralateral side. Then you take the stitch from the pectineal ligament from the same side port. Then another stitch is taken 1 centimeter lateral, and again they are tied loosely as we did in open procedure. The procedure is same, and it gives adequate support. Then you irrigate the retropubic space, insert a suprapubic catheter, and cystoscopic examination should be done to see that those suture material. So placement of true trocars have to be done in the left lower quadrant and right lower quadrant. And you should do coagulation of the pectineal ligament and the anterior vaginal wall before taking the stitch for hemostasis. Foley's catheter for deviation of the urethra, and contralateral suturing on the anterior vaginal wall, and ipsilateral on the Cooper's ligament. Post of antibiotics, drain for 3 days, catheter for 2 days. Voiding may take up to 7 days to be normal. Hemorrhage, bladder trauma, urethral trauma, kinking of uterus, overactive bladder, voiding difficulty are the complications which can happen, but it is better than anterior coprorrhaphy. MMK, which is no longer done, needle suspension procedures which are no longer done. And whether you do it laparoscopically or you do open, the subjective and objective outcomes are same. Then we have pubovaginal slings. It can be done for SUI of all type, in recurrent SUI, when there is some pathology of the urethra or bladder, fistula, diverticulum, patient who doesn't want to have a mesh, or somebody who's had a radiation therapy. This provides adequate urethral coaptation, re-establishes the hammock, and increases the urethral responsiveness to the abdominal pressure. Sling material are various: autologous, xenografts, allografts, synthetic. We are mostly using autologous and mostly rectus fascia because we are familiar, but fascia lata can also. Patient is put in low lithotomy, legs in stirrup, bladder catheter has to be there. Give a low transverse abdominal incision 2 centimeter above the symphysis pubis, take 8.2 centimeter length of the rectus fascia, and stay suture are put with number 1 chlorine on 2 ends, and then it is put in a kidney tray containing dexamethasone, heparin, gentamicin, and normal saline. Then you do the dissection in the paraurethral space between and separate the vagina from the urethra. And so you go till the inferior pubic rami with your dissection, and then from the abdominal incision site, you go to the space of LSCS and put in a calyx or a trocar in the space you have made. This calyx goes down. You take out the urethral, the sling you have made, hold it with the proline, pull it up. Then similar thing is done on the other side, and the abdominal threads are brought out through the rectus sheath, lower incision. We've not closed the rectus sheath as yet after having taken the graft. And then you don't tie it as yet. You close the rectus sheath and then give tension over this proline thread, keeping a right angle. And then you tie it after having closed the rectus sheath. Then you close the rectus sheath with nylon, put in a drain, then close the skin and close the vaginal incision. This gives a good support to the urethra, and the drain has to be put, otherwise there would be seroma formation. Negative suction pressure has to be done where you've taken the rectus sheath. Now, these colpus suspension versus traditional sling gives a higher success rate, but greater morbidity such as infection, urge incontinence, and voiding dysfunction is more. But long-term efficacy is very good. What is there in 1 year remains so for 10 years. So autologous facial sling is more effective than colpus suspension, but has more complications. And colpus suspension has higher long-term risk of pelvic organ prolapse and than mid-urethral slings. Laparoscopy, though the objective and subjective cure rate are same for laparoscopic birth, but it is more cost-effective and lesser hospital stay. Then came the controversy, the beautiful slings which came, which prevented all the complication of the birth and the retropubic slings. And what they do is they are placed loosely at the mid-urethra to prevent movement of the posterior urethral wall. You can put them top down or bottom up. Available retropubic slings. You can put it in symptomatic SUI, even with Strinker deficiency, in recurrent SUI, even in mixed incontinence, and women with prolapse. Again, the position is dorsal anatomy. This is a schematic diagram showing that bladder has been catheterized, and then you make an incision in the suburethra 1 centimeter below the urethral opening, 1 centimeter incision, create 2 tunnels, and then you can put the needle with the tape from below up or upward down. So below up is better than upward. And then I'll show you that you first make 2 suprapubic incision, 1 centimeter on each side of the midline on the abdomen. Then you start a point 1 centimeter below the urethral opening, give a 1 centimeter incision, dissect on the ipsilateral shoulder side toward the istiopubic rami for about 5 centimeter till you reach the inferior pubic rami. And then after having done the dissection, you put in the sling needle through the tunnel you have made. And when you reach the inferior pubic rami, remember the tip is to remain close to the pubic rami. And the bladder is kept away by a metal sound into the Foley's, which pulls the bladder to the opposite side and urethra to the opposite side. So we have taken out the needle of the sling through the abdominal incision we had made, and the plastic of the sling is removed, and we have this sling. And similarly, we do it on the other side, and then it is tied under tension by putting artery or a Cayley's clamp or a Hager's dilator at the base. So, and this above down is the same. You similarly make a tunnel, but here you come from the abdominal incision to the vaginal part. And then when you are tying it, you always have to put a artery beneath the portion which is at the urethral neck. They have a success rate of 73 to 82%. Bottom to top route was more effective as facial slings, less operative time, less voiding dysfunction, as effective as open retropubic colpal suspension with fewer complication, and even it can be used in ISD and mixed incontinence. Then, because of this complication, came obturator tapes, which did not go above into the abdomen, but just perforated the obturator membrane. We must always remember to do a cystoscopy when we are putting a TVT, and the cystoscopy has to be done when you put in the trocar of the tape, because in case you perforate the bladder, you can remove the trocar and re-put it. So it has to be done before removing the needle of the tape. Cystoscopy must be done. TOT may or may not do a cystoscopy because it has less chances of bladder. So this also can be inside out or outside in. There are various tapes available, and patient is placed in the dorsal position, legs are hyperflexed, and exit point is marked 2 centimeter above the level of the urethra at the level of clitoris and 2 centimeter lateral to the labial fold. Again, the dissection below is the same. Only thing is that this time when you are dissecting lateral to the urethra, you are going towards the istiopubic rami, perforating the obturator membrane, and then inserting the sling. So this is inside out. And when you are putting the tension, again, you have to put a right angle. So the dissection is done in the paraurethral space. The incision for the abdomen is, for the TOT is marked 2 centimeter lateral to the labiopleural fold at the level of clitoris. And then you dissect for 5 centimeter. You will be able to reach the obturator membrane. You perforate it. And then you take out your sling, see which side is which. Then this, for inside out, there is a guard. You put in the guard, and then you put in the needle above the guard. The needle comes out to the point you have marked, and then the tape comes out. The tape has a center portion marked where it should be placed in the center of the urethra. So the tape is out, and similarly the other side tape is out, and again you cut the needle and put the artery beneath the base of the urethra to tie it. Outside in, inside out and outside in, they are similar, but inside out is more precise. And outside in, again, the marking is same. Here you go in from the marking you made lateral to the crural fold and just press this trocar in first, right angle, and then the helical way it goes. And when you are rotating it, you should put your finger in the vagina and the needle comes above your needle, above your finger, so that you don't injure the urethra. And again, it has to be put with the right angle or artery so that it is, that's why it is called tension free. We don't want to cause tension. And this is the outside in procedure. Here the tape has to be put into the eye of the needle, then it goes to one side, then to the other side, and then you put the artery, and then you cut it flushed with the skin after pressing the skin, so the tape goes in. You don't have to put any stitches for the tape. The cure rate is 75 to 96%, and long-term cure rate is 71%, which is less than the TOT, though voided dysfunction is less, but you can't do it with sphincter deficiency. Then we have single incision sticks, which we haven't used as yet. TVT Secure came and went away because it was not giving good result. Miniac, Adjust, such slings are there. Here the tapes don't go till the accreta membrane, don't pierce. They go only till, and they're secured by spicule on the tape. And then these tapes are monofilament proline tapes, so that tissue fibroblasts grow in and this remains secure. They have very less complication. The cure rate up till now, whatever follow-up is there, is as good as TOT. But there's only one study of 54 months. Other studies are only 2 years. So Cochrane says that you have to still wait whether we can use these as a single incision slings or not till we have more data, but they are as good as TOT in terms of cure rate and complications. So you can see the complications are maximum with TVT, but TVT has maximum long-term, correction rate. Bush 68 to 97%, TVT, TOT 81 to 100, but long-term rate is more with the TVT. Single incision is as good as TOT, and facial sing is almost as good as TVT, TOT. And Cochrane says that transobturator and retropubic have similar subjective cure rates in short and medium term, but long-term TVT is better. So summary says that this is from the EUA, mid-urethral synthetic sling inserted either by the transobturator or retropubic route provide equivalent patient-reported outcome. Mid-urethral synthetic sling inserted by the retropubic route have higher objective patient-reported cure rate at 8 years. Long-term analysis of mid-urethral sling cohort showed a sustained response beyond 10 years also. Retropubic route of insertion is associated with higher intraoperative risk of bladder perforation and higher rate of widening dysfunction than transobturator. The transobturator route of insertion is associated with higher risk of groin pain. Long-term analysis shows no difference in efficacy skin to vagina or vagina to skin direction up to 9 years. Top to bottom direction is associated with higher risk of post-operative widening dysfunction. Now, what about this controversy? Now, Royal College says, since there is a controversy, do not use it if you can avoid it. But if it is required, you can use it. FDA said, we never said not to use sling and sacrocolpopexy mesh. The warning was against the vaginal mesh. And the slings are so good, they have less complication. I think they will come back. They had gone away for some time. And patients who can't have any of the surgery, we can put periurethral bulking agents. What it does is it causes closure of the bladder neck. It can be put periurethral or intraurethral. But the fallacy is that you have to keep on repeating doing it. Patients who are unfit for surgery, have a fixed urethra, want to just delay surgery, have all failed surgery, you can use these agents. Infection, burning, obstruction, erosion, hypersensitivity are the side effects, which are minor ones. But efficacy is inferior to synthetic tape, though we have about 5 years data that if repeatedly used, they can be used as an effective. The upcoming thing is stem cell therapy, but we don't have enough data to choose a patient in young patient with hypermobility is TVT and Bush because she has a long way to go. Young patient with recurrent SUI, again TVT. But when there is mixed stress predominant, it's better to do TOT and SIS because TVT can cause de novo urgency. Old patient, TVT or TOT. When prolapse, better to use TOT or SIS. Recurrent SUI, old patient, better to use TVT or facial slings. Recurrent with fixed urethra, bulking agents. Recurrent SUI with previous failed synthetic sink, you can use facial slings or Bursch. So to summarize, there is lack of clear consensus as to which surgical procedure for stress incontinence is more effective. Proper counseling is merged. Surgeon's preference, patient's problem, anatomic feature will influence the choice. We don't know it is the sphincteric weakness or hypermobility which contributes more to the SUI. Bursch is effective in primary or secondary surgery. Laparoscopy is as effective as open, and it is better because it offers same success rate, lesser time. No difference in cure rate of Bursch and pubovaginal sinks. Mid-urethral sinks are the most preferred choice in the current era with good cure rates and minimal side effects. Thank you.
Hello, Suchitra ma'am?
Yes.
Yes, MC sir, for your concluding remarks, both of you.
Yeah. So I think, yeah, I've heard the entire talk, and Dr. Ashla, you've made a very extensive review of the entire surgeries. And I agree with you that there has to be some procedure available. And if you choose a procedure carefully, keeping the patient's benefit in mind, I think the chances are that you are successful. And of course, one important thing is any of the sling procedures, one has to be very, very careful of not overcorrection, because the overcorrection becomes, an issue. So therefore, as you very rightly mentioned, doing a cystoscopy just prior to that overcorrection always helps, and making sure an undercorrection is little better, but overcorrection, then the patient ends up in an obstructive problem. So yes, very careful choice of surgery, and not rushing it through and doing it very carefully definitely is the answer. Thank you, Dr. Achula. Very, very, very good detailed thoughts that you've given.
Thank you, Achula, for excellent talk, and thank you for accepting our invitation to be faculty.
Anything for you, Dr. Patel, and it was a privilege to be part of this.
Thank you. Yes, over to you, Monica.
All the best to you for your elections. Yes.
Thank you, Achula ma'am, for an excellent presentation. And thank you, Suchitra ma'am and MC Patel sir, for covering the chairperson for this session also. I now thank you, sir, for the opportunity to coordinate this webinar, and wishing you all the very best for all your future endeavors. I hand over the mic to Dr. Rajesh for the next session.
Monica, I think,
Yes,
in the case of Atul Ganatra, I'm going to speak because Dr. Atul Ganatra is not there.
Yes,
yes, ma'am. Ma'am, Vasu also knows it, and Dr. Rajesh also knows it. They will be conducting the next session.
Message is already conveyed.
Okay.
Yes. Thank you so much, ma'am.
Thank you, madam. So we actually have only one session left for our today's program. So I invite the chairpersons for the session on tips for endoscopic surgery. We have Dr. Farendra Bharadwaj, Dr. Deepak Bagde, and Dr. Vidya Tobi as chairpersons for the session. Can we have the CVs?
I think because Deepak Bagde had the chair one session prior, so he will not be there. And Arindra visit some surgery, he told. So anybody can take. Rajesh,
yes, sir.
You can also introduce Suchitra ma'am, and you can proceed further.
Okay, sir.
If Vidya Tobi is there, I don't think I
didn't see madam's there. Dr. Farendra is logged in, but
he told me that he is in OT. So you can proceed accordingly, no issue.
So can we have the CV for the speaker, please? Dr. Pandit Palaska, sir, endoscopic management of ectopic pregnancy.
It's Dr. Suchitra Pandit.
Sorry,
Yes.
Sujitra
Pandit.
Sujitra Pandit, sorry.
Technical team.
Mine is not. Can I introduce myself? Otherwise,
Suchitra is in session 2.
the last session in place of Atul Ganatra Alpesh.
Last. So Madhurena Samapayat. Suchitai.
Suchitra CB is in session number 2.
Alpesh ऐसे ही बोल दो ना, it doesn't matter.
Just a second.
Yes.
Yeah, thank you. So we have Dr. Suchitra. She's Senior Consultant, Department of Ob-Gyn, Surya Group of Hospitals, Mumbai. Madam has been the Fox's representative to Suffolk for the year 24-26 and has been Chairperson of AICC RCOG and President of ISOPAP, Justices India Association, Foxy ICOG, and Mumbai Society of Ob-Gyn. Madam
Ravi,
has been...
Ravi, it's okay.
Yeah, thank you, madam.
Thank
Over to you, madam.
Can I share screen? If you stop sharing, I'll share screen. If you stop sharing, then I can share my screen. Ravi?
I think they allowed you to share. Still
Madam,
You'll
also can you please, madam, co-host? Yeah, madam, you can share now.
Okay, I just wanted to make sure it's there. Are you able to see?
Yes, madam. Yes, madam.
Make it full screen.
Please full screen.
Yeah. Is it okay?
No, make it full screen.
No, I've made it full screen already. I'll just try once more. 1 second. Hold on. Okay. Now is that okay?
Yes, madam. Perfect.
Okay.
Okay.
Fine.
Yeah. So basically, it's the situation of impacted head and deeply engaged head. So what do you do in such situations? And this is what I'm going to be talking about. Second stage cesarean sections account for 1/4 of the primary cesarean sections. Deeply engaged head, that is the impacted head in the second stage, is a known problem, and this accounts for the obstructed labor. And generally, everybody understands that the second stage are seen more in developing countries where the babies are probably still being delivered at home. Though we say that 90% of the deliveries should occur in the hospital, there are still some places where they are occurring. And of course, RCOG has reported that 6% of cesarean sections for singleton pregnancies occur at full dilatation. Now, if you try to attempt an instrumental delivery, you may be successful or you may be not. But there is a problem, and there can be problems to the baby as well as to the mother. And therefore, a supervised presence of any medical staff, like a consultant, should be there. So basically, when you're trying to do a second impacted stage, obviously you're ending up doing a C-section. There are more of intraoperative complications, unintended extensions, need for blood transfusion, higher rates of endometriosis, and probably the bleeding is a lot more, then sometimes it may end up in a hysterectomy. Of course, in today's day and age, this doesn't happen, but this used to happen once upon a time. And the neonatal complications included a significantly lower Ab-Gar score at 5 minutes, and probably the chances of admissions to the NICU, septicemia, fetal injury are there. And therefore, one has to be very, very careful. So when would you say it is a second stage which is prolonged? When the time exceeds 2 hours. In an epidural, this can be taken as 3 hours. And what are the causes? Probably it's a malpresentation, malposition, ineffective contractions, ineffective maternal effort. And many a times we say it's a classical, medications or whatever has been used, probably not given correctly, that causes the descent abnormalities. And many a times this is more commonly seen in POPs, that is, when there's a persistently occipito posterior position, which is more common in primigrávidas, It does cause a delay in the first stage, prolonged second stage, and this is often seen with induced labors, particularly when induction is done with a very poor Bishop score. Inefficient uterine action and the ROP is 3 times as common as the LOP. And usually what happens is when the occiput tries to engage, it's in the lateral position. 80% of them will rotate, but there are some of them which will go into the terrific TOP. So if there is an anteriorly situated placenta, anthropoid pelvis, early rupture of membranes, or a flat sacrum, and many times in a patient who's had a pendulous abdomen, it can end up in occipito-posterior position. With an OP, about 10 to 12% may deliver spontaneously at occipito-posterior position, which means a phase 2 pubes delivery. But if that transverse arrest, that impaction occurs, then what? Decision here is very important. Do you want to do it vaginally? Do you want to try a vacuum? Or do you want to try a forceps? Quite often, the scalp is so edematous, so you're not even able to make out the sutures. So what do you do at such a situation? Should you just go ahead with the cesarean section? So in a second stage of labor, today people are recommending ultrasound, but at all labor wards, the ultrasound is not available in the labor room setups itself. Some of the modern newer theaters, labor room theaters do have that high performance ultrasound system. But otherwise, if you do have an ultrasound, one is able to make out the fetal head rotation and fetal head position, and probably it is said that digital examination is subjective, but if you have an ultrasound to do it, it may be a little more objective. And there are typically 2-3 measurements that you take, a translabial or a transperineal USG, which can evaluate the fetal position. And you're looking at the 2 different types of methods. Either you're looking very importantly at the linear method, or you're looking at the angle of progression. And here the main pelvic landmarks are the symphysis pubis, the fetal skull, and the angle of progression appears promising, but assessment is restricted usually. If it's an occipito anterior, probably it's much more easier. So this is more of a futuristic tool. If we can use it well, it will at least tell us whether this head is going to come down or not. So then, if you've taken a decision for a cesarean section, what are other precautions and what do you do in this case of impacted fetal head? Most important is counseling the patient, pacifying her, because these C-sections, the patient is already tired. There is lesser amount of liquor. Lower segment is probably thinned out and edematous, and so there may be an additional amount of morbidity. But you still need to have procedural consents, and you need a skilled anesthetist and a neonatal support. And being a second stage, we still have to make sure she's well hydrated. So first, stop the pitocin drip. Give that little Trendelenburg position, because it may just help to a certain extent to disengage the head. And make sure that the patient is well hydrated. When you catheterize the bladder, be very, very careful, because bladder is edematous. So urine can get blood stain. And if you keep in the catheter, it may be difficult to even maneuver the catheter. So you have to put in a finger and gently maneuver it inside and keep the catheter in situ for a longer time post delivery. And obviously, we always prefer regional anesthesia, but there are challenges of position. Now, if she's already had an epidural, you can do a top-up. But otherwise, you can try left lateral sitting position, but sitting is difficult for the patient, and she's getting contractions, she's tired. So there are times when a GA may be needed due to the odd position. First important thing we have to remember is try to do whatever you're doing by skill and not by force. So plan the uterine incision. Remember, lower segment is fully formed. So your incision has to be a little higher up, others will be cutting through the cervix, and suturing may be difficult later. So you give a curvilinear incision on the lower segment, but a little more higher. And Trendelenburg position, do not forget, because a little bit of disengagement of the head can occur, and very gently you yourself can try to do a manual disimpaction. It may not always happen, but then you have your assistant, should not be the junior most person, should be an experienced person who will be doing the push method. And when you're trying to deliver, remember, you can put your hand inside and see whether you can overcome that negative pressure. If your hands are going, your fingers are going below the presenting part, but that may be difficult. Sometimes pushing the head up a little more can help, and you can do it Besides the hand, you can use an Ellis disinfector, or you can use a Tideman's pillow. So I'm going to talk to you about that just a little later. And of course, the second is the reverse breach technique, and third is the Patwardhan's maneuver. So I have videos for that, and I will show you that. So this is the Tideman's pillow. In fact, this pillow is to be put, the whole idea of putting this pillow is there is a uniform pressure, and it is not, somebody pushes too hard, so the damage to the fetal skull is much more lesser. It has to be inflated and put inside the vagina, and it just gently pushes the head up. Currently we don't have it, but we did have the Ellis disinfector, where you had a 50 cc syringe, and this was attached through a tube to two condoms. You could inflate those condoms and give that little push. We had tried that, but it isn't always successful. So then the other method is the reverse breach technique. So earlier times people preferred this breach technique, and here you must remember that when you've taken the incision, the main operating hand of the obstetric surgeon is to be inserted upwards inside the uterine cavity to grab the baby's foot and then deliver it gradually along with the ipsilateral leg through the uterine incision. And when you're doing that, the other leg automatically comes in. So reverse breach technique, the surgeon grasps both the feet and proceeds in a manner similar to like a vaginal breech extraction. Now, there was a study conducted by Asraf, and this is published in the Journal of Gynecology of Women's Health. And he mentioned that this particular technique they found was much more better, lesser risk of extension of the uterine incision compared with the push method. But of course, they have not compared it to Patwardhan's, and they felt that the reverse breach as compared to the push, lesser chances of infection and lesser blood loss. But we have to see what are the other methods. Now, in a Patwardhan's technique, remember this method was devised by Dr. Patwardhan in 57, and they done only 4 cases and published it along with Dr. Nagesh Motashaw. So the whole idea was to ease the delivery of the fetal impacted head. And if you do it carefully, first you try it on the mannequins, and then you realize that it is not such a difficult method as it is thought to be. But here again, remember the incision is got to be higher, as it is the lower segment is over descended. So when you take that incision, you have the fetal shoulders coming in the Patwardhan's view. So this is exactly what happens. The back is facing you. So the Patwardhan's, there is no modification of Patwardhan's. It is Patwardhan's for the back anterior or Patwardhan for the back posterior. So these are the hands which come in the view. So one has to gently move the baby, get one hand out of the side, move the baby the other side, and get the other hand out of the side. So if this is an occipito anterior or a transverse position where the head is deeply engaged, then when you are gently trying to get that anterior shoulder, be very gentle, hook that arm, get it out. And as you're getting it out, just do a slight turn. This may be difficult because there is no amount of liquor and the uterus is tightly gripping the uterus. So you have to be very, very gentle. And then as you're turning the baby, the posterior shoulder is also delivered. And then hold the baby's trunk, and with both, you can use a mop at this time, and gently with thumbs parallel to the spine and with little bit of a fundal pressure given by the assistant, the buttocks are delivered, followed by the legs. So now this is the video. This was taken in when I was working at Sion Hospital, and this is a patient who is tired. Incision has been taken, and as soon as the incision is taken, first thing you check is there a meconium? Yeah, there is no meconium, but you feel that there is a cord over there. So the operator tries to put the hand inside and see whether head can be disimpacted, but it's not possible. It is very, very deeply impacted. So decision is taken to do the Patwardhan's. Now, in this particular case, probably this patient was a third gravida. She'd had previous 2 normal vaginal deliveries, so everybody was complacent. So here you have the shoulder, anterior shoulder coming out very gently. Make sure that you're not compressing on the cord, and gently hook out the other shoulder too. Meanwhile, do not remove the doyens. And at this side, a gentle fundal pressure, and very gradually, very carefully deliver the baby's trunk. And at this time, maybe the assistant can make sure that their edges are, the incision edges are retracted. And once the baby comes out, hold the baby upside down and clamp the cord and hand it over. In this case, fortunately, the baby did not have any injuries. There was no meconium. It was a 3.6 kilo baby. But remember, when you are pushing the baby upwards, you're using your thumb and trunk, there can be a damage to the fetal liver. So be very, very gentle. Do not haste, because haste can make waste in this particular case. And of course, anterior shoulder is always much more easier when the back is facing you. Now, if the back is facing the maternal spine, which means that the baby is spine is in apposition with the maternal spine, this is more difficult. So here what you do is in the incision side, whatever, usually one of the hands will come in. So what you do is you follow a clockwise pattern. First deliver the hand in the side, followed by the leg of the same side. Now, many a times what we have seen is when the hand comes out, it's obviously the opposite leg comes out. Don't even be tempted to hold the opposite side leg, otherwise it will become like a seesaw. So put your hand behind along the buttocks and deliver the same side leg. So you got the left hand, you got the left leg. Once you've got the left leg, slide your hand over the buttock and go on to the right leg, deliver that leg, and then gently come on to the same side arm, and the baby can be delivered. And lastly, of course, the head comes out. So this is again video. Remember, in those days we didn't have very good mobiles. One of the first batches of the mobiles which had come. So here again, opposite side leg and same side hand comes out. So the operator is putting their hand inside. Once he's caught hold of both the legs, hold the legs and gently get the baby out. So here also, if you are careful, you are still able to do it, but refrain from pulling the opposite side leg. So remember, friends, this particular method needs a little bit of training. So on the mannequins, try it out. And this is a much more nicer and a much more simpler method as compared to the reverse breech, because reverse breech the amount of liquor is already gone. And when you try to put your hands above, you hardly have any space. So in this particular case, the bladder is edematous, the urine can be blood stained. So keep the catheter in for at least 48 hours or maybe even 3 days. The patient may have had an episiotomy because you were trying to do a vaginal delivery. So remember, suture that episiotomy, and in your post-operative care, you have to take care of that too. Adequate painkillers, and try to mobilize this patient as soon as possible. Give her a lot of reassurance. Poor lady, she's tired. She's happy that the baby's come out fine, but there are times when there may be meconium and the baby may need bag and mask and may sometimes even be needed to go to the NICU. Completely analyze the sequence of event for debriefing and for counseling your team and for counseling the patient. If you find that when you have delivered, always check the lower segment for incision extensions. Many a times there may be a vertical incision extension or there may be a side extension. Fortunately, in Patwardhan, the side extensions are not so common, but vertical extension look out for. If there is a vertical extension, please suture it. And normally, when you're counseling this patient, tell her that the next time it is better she has a planned elective C-section, because it is, particularly when there's an extension, there's a contraindication to allowing a subsequent vaginal delivery. So remember, friends, CS at full dilatation with or without attempt at operative vaginal delivery is a challenging surgical procedure than a first stage C-section. First stage C-section also has lesser morbidity. Again, the morbidity is directly because of the incidence of extension of uterine angles, prolonged surgical time, bladder injury, increased incidence of postpartum hemorrhage. So friends, as soon as the babies come out, immediately start your postpartum prophylaxis. Give her oxytocin, carbetocin, whatever you're giving, but make sure that the uterus contracts. It may take a little more time to contract. Make sure your antibiotics are covered up. And neonatal complications, you must have a skilled birth, a skilled neonatal attendant with you. Fortunately, at Surya, we have all these people. So look out for fetal acidemia. They can be cephalohematoma, intracranial hemorrhage. Particularly if you've tried vacuum and it has failed, please tell the neonatologist so they can keep a watch. Sometimes because of the excessive pressure, there can be damage to the abdomen when you're doing the Patwardhan. So be very careful. And remember, you have to keep a watch on the babies for the next 2-3 days. And atraumatic delivery is our goal. But any time in a fetal, in an impacted head, do not give a deep incision because you may lacerate the fetal parts, particularly because there is hardly any liquor. Do not take a very small incision because it may trap the fetal parts, and don't do hasty or because that will cause more of difficulty, injuring not just the soft tissue for the baby but also fracturing the limbs. And one study I'll just quickly tell you before I finish off. There was a retrospective analysis of 135 C-sections done at a tertiary care center. I think it was Safdarjung. 71 babies were delivered by the push and pull method and 64 babies by the Patvardhans. And they found that there was significant less uterine extensions in the Patvardhan method as compared to the push and pull. And that was statistically significant. And extension, traumatic PBH, and need for blood transfusions were also less in the Patvardhan technique as compared to push and pull. And baby outcomes were almost similar. So this was published in 216 International Reproductive Contraceptive Obstetrics Gynecology. So in conclusion, friends, cesarean sections done in second stage of labor for impacted head always will be more difficult. So skilled surgeons should be necessary and take care, do all the prophylaxis for the hemorrhage and the infections. And in general, when you are monitoring a patient, avoid early rupture of membranes at 2 centimeters and 3 centimeters. Wait for the bag of membranes to be formed. Don't keep giving unnecessary oxytocins. Let her get, once she's induced, let her get into labor. Use of partograms will help you in decision making for an earlier operative delivery, and practice the Patvardhan's technique. It's easier to learn it and needs to be much more widely publicized and utilized. And skill labs today, you're all fortunate, you're living in an era where there are skill labs. So even for consultants, they can go and train themselves at the skill lab. Thank you very much. And I'd like to say a big thanks to Dr. MC Patel for this opportunity. I know I should have come in much more earlier, but my mistake that I forgot to take my laptop to the hospital and I missed that particular time. But thank you very much and all the best for your elections. You've done a lot of hard work, and I know this is a very crucial time. Once the election starts, you will still need help and support from everybody, and all the best for your elections. Thank you very much.
Thank you, Sujita, for kind words for my election campaign. But thank you for sparing time to impacted with section. You have justified our invitation and you have justified the topics also. Thank you.
Thank you.
Thank you, madam. Thank you, madam, for that wonderful talk. We'll move ahead with our next talk. We have Dr. Pandit sir. Can we have the CV? Dr. Pandit Palaskar, he'll be talking on the endoscopic management of ectopic pregnancy. Sir is the gynec endoscopic surgeon and IVF specialist at Endoworld Hospital, and was the first president of IAG last year. And sir has been recognized center for training in endoscopy and Foxy recognized training for endoscopy, infertility, and ultrasound. Over to you, sir, on your talk on endoscopic management of ectopic pregnancy.
Yes. Good evening, everybody. Thank you so much, the organizers, Dr. MC Patel, sir, and the all team members of this web conference. It's really a unique conference, and since afternoon we are enjoying the rich scientific content and the stalwart faculties. They have explained how to manage the all complicated cases. So I'll be talking on the endoscopic management of the ectopic pregnancy, which is a quite common condition in day-to-day practice. Can you see my screen?
Yes, but make it full screen. Make it full screen. Yeah.
Friends, ectopic pregnancy is a very common gynecological condition, and every gynecologist comes across the different types of the ectopic pregnancies. So not all pregnancies who are ectopic, they need surgical management. Obviously, they need to be diagnosed properly before treating, and we have various diagnostic modalities. Nowadays, ultrasound, beta HCG titers, progesterone levels, the transvaginal ultrasound has greatly made it simplified to diagnose the ectopic pregnancies in the earlier periods, so that we can treat them by medical method. Not all ectopics, they need surgical management. So definitely there are certain criteria to manage the ectopic pregnancy by surgery. So ectopic pregnancy is a pregnancy which is implanted outside the normal endometrial cavity. So there are various types of the ectopic pregnancies. It can implant into the tube, which is the most common variety. Then ovary, the cornal or interstitial part of the tube. There can be ectopic. It can get implanted over the cervix, abdominal cavity, and the pregnancy of unknown location, wherein the beta HCG titer is positive, but you can't locate the pregnancy by ultrasound. So these are the various types. Again, we have heterotopic pregnancy, wherein there is simultaneous intrauterine and ectopic pregnancy. So I'll be focusing mainly on the surgical part. So these are the indications for the surgery. When the tube is ruptured, there is hemoperitoneum on ultrasound. Definitely this patient needs surgical management. If the sac size is more than 3.5 centimeter, gestational the sac with cardiac activity, in such patient, they are usually they don't respond to medical management. 12 cases of medical management, heterotopic ectopic pregnancy, cases of uncertain diagnosis. These patients, they require surgical management. And of course, in today's era of endoscopic surgery, all these ectopic, they should be managed by the endoscopy, because it has various advantages. And these patients with ectopic pregnancy, they are already disappointed by having ectopic pregnancy. And adding a scar to it, I think it is very detrimental. So as far as possible, if facilities are available, I think this patient, they should be managed by endoscopically. That is the minimally invasive way. So this is a patient with tubal ectopic pregnancy, both videos. So it is not always necessary to remove the tube. You can very well preserve the tube. So here you can see the tubes are looking relatively healthy. They are not adherent, they are not damaged. So in such cases, we can do salpingotomy or salpingostomy. We inject dilute vasopressin with spinal needle into the mesosalpinx and give a nick either with monopolar or scissor on the antimesenteric border of the tube. And here you can see the sac beautifully comes out. You can put normal saline with the pressure of the normal saline suction cannula. You can see the sac comes out easily, and you have to handle these delicate tubes very gently with a traumatic grasper, so that you don't cause adhesions. You minimize the peritoneal tissue injury intraoperatively, so that this patient will have minimal adhesions. Here you can see the gestational sac containing the fetus, which can be seen in little advanced pregnancies. Nowadays, we almost suture all the tubes. We don't keep the wound open. That salpingotomy wound, we don't keep open. We close with 7-0 non-observable suture, that is 7-0 proline. And here you can see absolutely normal looking tubes. The tubes are looking edematous because we have injected vasopressin. In post-operative period, the healing is good. There are minimal adhesions, and sometimes this tube can function. I think as much as possible, we should preserve the tube if the tubes are healthy. And if the patient is not willing to do the salpingectomy, because doing salpingectomy is very traumatic to the female. Maximum what will happen if the tube don't function, it's okay. That doesn't matter. But I have seen there are some patients after salpingectomy, there are cases of the divorce because the husband said that your fertility is over. So as far as possible, if the tubes are healthy and patient is willing to take the risk of recurrence ectopic in the same tube, I think we should give the chance to preserve the tube. Some patients here, you can see the tubes is badly damaged. It is adherent. You can't see the fimbria. Obviously, if the tube is ruptured, there is hemoperitoneum, we have to do the salpingectomy. So while doing the salpingectomy, you have to take care that you preserve the ovarian vascularity as much as possible, so that this patient, they require IVF and they don't land into the low AMH and non-response to the hormones. coagulate the tube as close as possible towards the tube, preserve the vascularity of the ovary, and do the complete hemostasis. So here, the salpingectomy is done, and this patient, she has been advised the IVF. This is a ovarian ectopic pregnancy. Here you can see there is a lot of hemoperitoneum with blood clots into the pelvis. Whenever there is a large hemoperitoneum, first try to achieve the hemostasis. Here you can see this is a ovarian ectopic that is arising from the right ovary. We always inject vasopressin. I think it is a very wonderful drug which minimizes the intraoperative bleeding. It makes the surgical field little clear, and you use minimal energy source so that you preserve the ovarian tissue. Here you can see we are removing the ectopic sac which is implanted on the surface of the right ovary. This incision we are doing with the monopolar cautery. You can take the help of the scissor, harmonic, whatever energy source you are used to. Take out this sac completely with all chorionic tissue. It's like doing a cystectomy. You see this complete sac is removed, and you can see the chorionic tissue. The typical appearance of the chorionic tissue is seen. The hemostasis from the operative site is checked. Try to minimize the use of energy source so that you preserve the ovarian tissue. Give thorough lavage. And once you do the removal of the ectopic, then you can take ample time to give lavage and take all blood clots so that the post-operative adhesions will be minimized. You can see the tubal patency in the same sitting. This chorionic tissue was put into the endobag and then it was taken out. This is a coronal ectopic pregnancy. I think one of the most dangerous form of the ectopic pregnancy is a coronal ectopic because it is very vascular. And usually as the corno has the more distensibility, they present late. This patient presented to us with, she was hemodynamically unstable. She was almost, the pulse was very 3D. Here you can see almost 2.5 liters of the blood with the blood clots was there. So immediately we took her for laparoscopy. Don't waste your time in doing suction for hours and don't take time. Immediately go to the site of the bleeding. First control the bleeding. Here we have injected the vasopressin and you can see the effect of the vasopressin. Complete blanching of the myometrium and the uterus is there. You can see the fetus because it was almost 11 to 12 weeks pregnancy. All the chorionic tissue, they need to be taken out. Otherwise, the patient will have the high beta ECG titers even after the surgery. In coronal ectopic pregnancy, you have to, sometimes you have to take out the tube. So again, try to preserve the vascularity of the mesosalpinx and ovary, give thorough lavage, take out all the chorionic tissue, and then reconstruction of the myometrium has to be done very properly. This can be done either with barb suture. This was old video. At that time, we have closed with the delayed observable suture like myomectomy, intermittent suturing with proper edge to edge approximation of the myometrium so that the scar integrity is maintained. The fetus was taken out by enlarging one of the ports. And then once the surgery is done, then you can take ample time to do suction. If the clots are very thick, you can change the 5 millimeter suction to the 10 millimeters so you can shorten the duration of surgery. And if there are collection more, you can keep the drain post-operative. So whatever drain is there into the peritoneum, it will come out. So that is the ectopic, coronal ectopic pregnancy. Now coming to the heterotopic pregnancies. See, this is a heterotopic tubal ectopic. These are patients both of IVF. Nowadays, with increasing incidence of the ERT procedures, there can be intrauterine and extrauterine pregnancies. So, my suggestion to the gynecologist, if patient of IVF comes to you with severe pain, you have to be ectopic minded. Heterotopic ectopic can be there because don't get satisfied just by seeing the intrauterine sac. Always look for the adnexa, always look for the hemoperitoneum. In this left video, the pregnancy, the tube was not ruptured. In the right side, you can see there is a rupture of the tube with lot of hemoperitoneum. So we have to do the salpingectomy. In heterotopic, we have to handle the uterus very carefully because there is intrauterine pregnancy. Rash handling of the tissue can cause the spontaneous initiation of the abortion. So we have to be very gentle. Don't touch the uterus. And once the salpingectomy is done, the hemostasis is achieved, you can leisurely do the suction lavage. Obviously, this patient, they will need the tocolytic and the progesterone therapy in the post-operative period to prevent the abortion and preterm deliveries. This is a patient with a heterotopic ovarian pregnancy. There is intrauterine pregnancy. This was again a patient of ERT. IVF was done at our center. And the one of the embryo got expelled from the femoral end, got implanted on the left ovary. And always look the other side tube and ovary when you are handling the cases of ectopic pregnancy. Again, here you can see the ectopic sac, which is implanted on the left ovary, has been excised with the help of the monopolar. Then achieve the hemostasis, minimal use of the energy source, give thorough lavage, minimal handling of the tissue. And this chorionic tissue was put into the endobag and it was removed by enlarging one of the port. So heterotopic, it can occur at the cornu, it can occur on the tube, there can be pregnancy on the ovaries also. This is a heterotopic pregnancy, which is intrauterine pregnancy and ectopic at the interstitium. Again, this patient presented with severe pain and ultrasound showed there is hemoperitoneum. So we suspected there is a ectopic. So we put the laparoscope here. You can see there is a rupture of the interstitial pregnancy. And here, as this is a heterotopic pregnancy, we have to handle this uterus very carefully. We can't inject vasopressin in this patient because it can initiate the uterine contractions. So gently, this ruptured rag margins, they were refreshened. We took out all the chorionic tissue that were implanted at the cornu and then reconstructed the this myometrium. While doing the reconstruction in heterotopic pregnancy in cornal ectopic, we have to be very careful so that the needle doesn't puncture the amniotic sac. Otherwise, there can be leakage and the whole procedure will go in vain. So gentle handling of the tissue, careful passage of the needle to the myometrium, avoiding the puncture of the amniotic sac. Intermittent suturing was done, the complete hemostasis was achieved, and then all the blood clots, they were removed. Minimal handling of the tissue, and we can keep the drain so that whatever collection is there, it will come through the drain. Don't waste too much time in washing the intraperitoneal contents. Scar ectopic pregnancies, nowadays with the increasing incidence of the cesarean section, we are getting almost 2 to 3 patients of the scar ectopic every month. So when the pregnancy is advanced, we prepare to ligate this uterine artery at origin by opening the paravesical spaces lateral to the IP ligament. Then we inject the vasopressin, and you can see the effect of the vasopressin. The scar ectopic is highly vascular, but with injection, you can see there is a complete blanching of the tissue. Bladder is dissected, and then the scar is open, the sac is open. Here you can see the fetus, which is around 9 to 10 weeks. All chorionic tissue, they are suck out, give thorough lavage, take out all the tissue, and you have to excise this thinned out scar tissue. Otherwise, the reconstruction of the myometrium will be little difficult. The scar tissue is excised, and then the reconstruction has to be done because these are young patients who are willing to have, they are desirous to have future childbearing. So proper reconstruction like a myomectomy needs to be done. And there has to be good age-to-age approximation. There should not be any overlapping of the myometrium. Otherwise, there will be development of the again isthmosil, and patient can have again scar ectopics. So you have to obliterate the this scar istomosil site with 2 to 3 layer closure, and good anatomic correction is required in these patients. Nowadays, we don't ligate the uterine at origin for scar ectopic pregnancy. The injection of the vasopressin is sufficient. This is our experience. We get a lot of cases of ectopic pregnancies, and almost all cases, they have been managed by the laparoscopy. Even the patients are hemodynamically unstable with hemoperitoneum 2 to 3 liters. It doesn't take much time to put a laparoscope and tackle the site. For laparotomy, it will take the same time. If the team is experienced, you have the all team and infrastructure available. Even in patients with hemodynamically unstable, put the trocar. Don't waste your time doing suction. Go to the site of bleeding, catch the bleeder, do the salpingectomy, and then you can keep on taking out the blood clots and doing the suction. So the patients we also manage by medical method by giving methotrexate by single dose or multiple regime. Everybody is aware of that, and all these pregnancies they can be managed by the laparoscopy, which is very good for the patient because they are already traumatized by having the ectopic pregnancy. And if you manage this ectopic pregnancy by endoscopic way, I think that is a very good joy for the patient and surgeon as well. So to conclude, laparoscopy is gold standard in the surgical management of the ectopic pregnancy, and in doubtful cases, it also helps in diagnosis and management. Sometimes it is not possible to locate the site of ectopic pregnancy. In such cases, you can just put the 5mm scope and you can identify the site of the ectopic and you can manage in the same setting. So that is the beauty of the laparoscopy. So thank you so much for patient listening. I'm very thankful to Dr. MC Patel and the organizers for giving me this opportunity to share our experience. Thank you so much. And I wish you all the best for your elections for the Foxy president. Thank you so much.
Can I ask you a question?
Yes, madam.
In a heterotopic pregnancy, could we reduce the incidence of heterotopicity by reducing the number of embryos put in? One, and two is if the tubes were known to be bad, by delinking of the tubes, would that reduce the, because the incidence of heterotopic is really very high now.
Yeah. Yes, madam. I think by transferring reducing the number of embryos to one will not reduce the incidence of heterotopic, but the embryo transfer technique, we should deposit the embryo not 10 millimeter, but 1.5 centimeter below the fundal endometrium. And it should be injected by slow technique, not as a bush, as a gush, you can go into the cornu. So you have to inject by slow method. I think that can reduce the incidence of the ectopic pregnancy. And obviously, preoperatively, before IVF, if you see the hydrosalpinx, damaged tube by ultrasound, I think delinking is a good method. And while doing the delinking, take adequate care that you don't keep any residual tubal segment at the cornu. I have seen some people, they cut the tube little lateral to the cornu. You have to burn all that tube very close to the cornu so that there is nothing is remaining there. No segment of tube is left if you do a delinking or doing the salpingectomy.
Right. And in that video was very good. You showed the 11 weeks, fetus that came out. So there, when they did an earlier ultrasound, they were not able to, or that was missed.
That was missed, madam. The patient first time came with collapse in the collapse state.
Oh, okay.
She was not aware that she is having cornwall. And the cornules, they present late because cornu is distensible. Tubal ectopic pregnancy, they will present around in second to third month. But this patient, they present after 3 to 4 months. And they are very vascular. So if they rupture, there will be a lot of hemoperitoneum will be there.
Very nice talk. Very good videos also.
Thank you, madam.
Pandit sir.
Yes, Parendraji.
Yes, sir. Sir, excellent talk and a beautiful collection of surgeries. One message you have given, which is absolutely correct on social ground, that if you're preserving the tube in tubal ectopic, that can give some confidence to the women. So that. But on a medical ground, sir, what do you say that the reason of ectopic pregnancy is that there is some tubal, ciliary, mucosal pathologies in the tube. So preserving that tube is putting a risk of the patient that again they can very high chances of developing ectopic in the same tube. So What is your take and what is your
What
experience?
I-
Because I've seen 450 cases of experience of ectopic, maximum a tubal one. So you must have done many tubal conservative surgeries, sir.
See, Farendra, at our center, we don't do salpingectomy unless the tube is ruptured or damaged.
Very nice.
See, people are very sentimental. The women are very sentimental regarding their organs. That to tube, if they are infertile, see, if she has completed family, the story is totally different. If the family is completed, she is not interested in future childbearing. I think doing salpingectomy, she is not worried. But if she is infertile and the tubes are healthy, see, removal of the tube, I have seen patient gone in depression after, in emergency, if she's having pain, hemoperitoneuria, she'll give the consent. There is no problem. But post-operatively, she regrets why my tube is removed. I may not become pregnant in the future. Some people, female, they believe she has lost her femininity. And I have seen one case of divorce also. The husband left because I have counseled her husband. She can become pregnant by IVF, but he thought कि natural pregnancy अभी तो नहीं होने वाला है. So there was divorce. So all these factors they have to be taken into consideration, and proper pre-operative counseling is very important.
No, sir. The social ground is acceptable, sir. I agree.
Yeah.
What I am asking
You
in
have to
your
explain
huge
to the
study,
patient there is chance of recurrent ectopic. If she is ready to accept the chance of recurrence ectopic,
yes, sir.
then you can preserve. If she is not ready to accept the chance of recurrence, you have to scientifically give there is a
Correct.
repeat chance of 15% of repeat ectopic if we preserve the tube. If she is
Yes.
ready to agree that chance, it is we can preserve. And
Yes.
see, now managing ectopic is not a big problem. We can
Not
diagnose
at all.
earlier, you can give methotrexates.
True.
So it is now the things are now very rarely now we get the patient of ruptured ectopic because
Exactly.
patients have become so aware. We can diagnose. We do the early scan, so it is diagnosed earlier. We have good machines. TVS picks up the ectopic like anything.
Yeah.
So management has become very simple nowadays.
True, sir. True. One more question, sir. In your data, you have shown a scar ectopic in which you have medically managed a good number of cases.
Yeah.
Now, what is that medical management? Can you put some light or experience on that?
Yeah, scar ectopic. We select criteria depending on whether she wants future childbearing or not. If she wants future childbearing and if the sac is very big, we prefer laparoscopy because we need to reconstruct that istomosil part. If the patient is not interested in childbearing, the sac is small, there is no cardiac activity, then we inject methotrexate on the ultrasound guidance with the help of the injection needle into the sac. If the sac, there is a lot of amniotic fluid, we aspirate the amniotic fluid and inject methotrexate and observe post-operatively. Obviously, post-operatively, it takes longer time for the scar ectopic to resolve. It takes months. Yeah, if the cardiac activity is there, we first inject KCl into the heart of the fetus, unless there is a cardiac asystole. After asystole, we inject the methotrexate into the sac. If
Because
cardiac activity is there, we have to inject two drugs.
Yes.
If
Yes.
cardiac activity is there, we have to inject two drugs. First, KCl to cause the death of the fetus, and then methotrexate to take care of the chorionic tissue.
Correct. Because identifying and putting a KCl in a very small fetus is very difficult. Intervention release. And nowadays, it is really replacing the very big surgeries. And there are types of ectopics in scar, exophatic one and the endophatic one. What you have shown in surgery is the exophatic one.
Yes.
And very nice repair also you have shown, sir, which I can appreciate when you have almost taken care of the defect also. Thank you so much, sir. Thank you so much. A wonderful presentation.
It was a great pleasure to interact with everybody. Thank you so much.
Congratulations, Dr. Pandit. Nicely representing the case of ectopic by surgical management. You are excellent surgeon and having a vast experience as far as ectopic management is concerned. And thank you for spending time to join us as a faculty.
Thank you so much. Thank you.
Thank you so
Thank
much,
you, Pandit sir. Thank you,
Thank
Pandit
you,
sir.
sir.
Thank you.
Thank you.
Thank you, Parinta sir, Suitra madam.
Thank
So
you.
by that, we have come to the end of that session. Would like to have the concluding remarks from FC sir.
First, I have given my concluding remarks. If Suchitra has anything to add, then
Hello.
Munja will conclude.
Yeah, sir. Sir, you are not audible, sir. MC Patel, sir.
Voice is not proper.
Yes, sir.
So I had comment to Dr. Pandit. So if anything has to be from Dr. Suchitra, otherwise Munjal can conclude.
No, I think it was a great organizing so many different specialities and so many stalwarts coming in and talking about different kinds of surgeries. I'm sure it has benefited a lot of listeners and viewers. And since the time I came back from the hospital, I've been watching, so it's interesting and good effort. Congratulations to yourself and the entire team for coordinating and collaborating for this entire day. And once again, all the best to your election campaign.
Thank you, Suchita. Thank you.
Thank you so much, ma'am. Thank you so much, everyone, the faculties and delegates, the guests of honor for their kind words, all the coordinators and chairpersons for being on time and taking responsibility of this smooth execution of the webinar or web conference we had. Thank you, Purendra sir, for wonderful oration and all the stalwarts of various branches. As it was rightly mentioned that sir had planned this particular program covering up all the segments of OB/GYN, right from conventional to the very advanced and fascinating zone as well. And one presentation of Sarawagi sir was amazing with regards to challenging both the zones or poles. Thank you so much, Corona Remedies and Vasubai. Thank you so much, Vasubai, for always standing by to all the advices and points for correction. And MC Patel, sir, thank you so much. Actually, I would like to thank on behalf of all the delegates as well, because at times the knowledge is always there on various platforms and various forms. But you have made it possible for all of us to have it in one concise package. And it was an optimal selection of the faculties and topics. And salute to you, sir, for the same. And all of us wish you the best for your campaign as Foxy President. And let's wish that we would like to see you, spreading the colors of security and safety, which you have been spreading over the period of many decades in Foxy from that particular chair. So thank you so much, sir. Thank you.
Thank you, Munjal. So, Vasu, are you there?
Yes, sir. Yes.
Yes. So, with your concluding remarks, we can close the session.
Very nice, sir. So, on behalf of Team Corona Remedies, I would like to thank and extend our warm regards to MC Patel, sir, for his campaign. And beyond the campaign, sir has taken the immense initiative in organizing the National Web Conference for a whole day. This is like a 9-hour conference, and with the stalwart presenting their surgery theater to the virtual media. And across the country, 3,500 plus delegates who have participated and made this program so successful. It is because of one man thought and initiative, and the thought was supported with the awesome faculty. Ideally, watching the sessions right from the 12 o'clock to today, now it's 8:15. But I'm telling each faculty has kept their immense effort in making this program so successful, and MC Patel sir for selecting the ARC faculty and making this program so successful. You are truly commendable, sir. And working with you for us, though is our support, but working with you is like our support is negligible. You make everything easy for us.
Our journey to stop Foxy on this academic activity part is concerned is continue, and we are going to come up with one more this type of session with critical care in obstetric and high risk pregnancy on 22nd of June. Same way with some other different stalwarts in the respective subject and respective field. We'll be there again on live 22nd June.
So stay tuned with us for 22nd for a second National Web Conference in enriching your surgical skills in critical care and high-risk pregnancy.
Yes.
All set for 72nd, sir.
Thank you very much. Thank you all.
Thank you, Suchitra ma'am. Thank you, Bhagli ma'am.
Thank you everybody for everything.
Thank you, Ashlabhadra ma'am.